we had was International Dialogue on Integrating Psychiatry, Psychotherapeutic, Spiritual Approaches, and Legal Perspectives for Enhanced Mental Health. One of the strategic objectives that we had was to integrate multidisciplinary approaches to understanding how spirituality, psychiatry, and legal frameworks create a comprehensive mental health strategy. And the key actions is to facilitate knowledge exchange among experts in psychiatry, psychotherapy, spiritual care, and legal fields, and be able to develop integrated mental health programs that incorporate these diverse perspectives, and also be able to promote interdisciplinary research and practice. The other objective, which is very urgent, is to promote global mental health literacy. This will increase awareness and understanding of mental health issues across different cultures and societies. The key actions is to implement global educational campaigns to reduce the stigma associated with mental health, and then be able to share best practices and successful case studies from different countries, and then be able to develop culturally sensitive mental health resources. Objective number 3 is to strengthen legal and policy frameworks so that we can advocate for legal reforms and policies that support comprehensive mental health care. The actions that need to be done is to encourage the adoption of laws that protect the rights of individuals with mental health conditions. This, of course, will help us to promote policies that will ensure access to mental health services, and also work with governments to implement supportive mental health legislation. Objective number 4 is to enhance training and capacity building. By doing so, we should have professionals in these areas be equipped with the skills and knowledge to integrate multidisciplinary approaches in mental health care. The key actions that need to be done is to develop and offer specialized training programs for mental health professionals, and then be able to facilitate workshops and seminars for continuous professional development. This, of course, will help us to create platforms in terms of conferences for ongoing collaborations and support among practitioners. And of course, this will help us to foster community and family engagement. The objective of this strategic objective is to engage the communities and families in the support and care of individuals with mental health issues. The actions to take is to develop community-based mental health programs and provide education and resources for families. This ultimately will lead to the encouragement of community participation in mental health initiatives. Our last objective is to ensure accessibility and equity so that members, individuals, irrespective of their background, are able to access mental health services. And the key actions that we need to take is to advocate for funding and resources to support undeserved populations. And that's why we are having a number of universities and also institutions that will help us to coordinate these resources through research, and then we'll be able to implement outreach programs in rural and marginalized communities, and also be able to promote policies that address social determinants of mental health. Earlier on, as we discussed in the previous day, we indicated that there are a number of challenges, and these current challenges are often fragmented with the integration of these institutions, and also the fact that healing of persons has been just left for the pastors and reverends. We believe that the pastors and reverends need to be augmented in terms of the skills that will be drawn from the various disciplines, especially in psychotherapy, psychiatry, and other legal approaches. The challenge that we have is that mental health issues are stigmatizing and therefore prevent individuals from seeking help and receiving adequate care. So we need to find a means of how we can destigmatize these psychological conditions. The other challenge we have is that we have lack of resources. Many regions face a shortage of mental health professionals and resources, leading to inadequate care. And therefore, by expanding our partnerships and collaborations, this will be able to help us. We already know that existing laws and policies often fail to protect the rights of individuals with mental health conditions. And yesterday there was a lot of debate and dialogue on the legal implication, especially when we are helping the mental health populations. Like I mentioned, that persons that have deviated, they have demonstrated behaviors that have deviated from the norms, are sometimes affected because we do not have laws that really protect them. For example, when we talk about the LGBTQ+, these could be deviations that are associated with the biology of the brain, and little has been done to help them understand what leads them to that condition. So this conference is important because it ensures a holistic approach to mental health care and addresses the needs of individuals in diverse population. So this, of course, will enable us to have an international dialogue which will facilitate the sharing of best practices and innovative solutions, fostering global advancements in mental health care. And of course, the presenters yesterday provided a platform, especially in articulating the conditions that affect individuals in terms of psychological ill health. And therefore, we may now, this dialogue will help us in engaging with policy makers that can lead the development of robust legal and policy frameworks that support mental health initiatives. And also, this conference will enhance skills and knowledge of professionals, ensuring the effective implementation of integrated mental health approaches. I believe that our participants who have really been involved in this have really seen the ways that we want to use to reach out to the community. And yesterday, one of the participants mentioned that we need to get in touch with faith-based organizations that will help us involve the communities and families in mental health care, which of course will promote sustainable support systems and reduce stigma. Imagine a country successfully integrating psychiatric, psychotherapeutic, and spiritual approaches in a community mental health program. The outcome would be that there shall be improved patient outcomes and reduced relapse rates and increased community support. Imagine a nation implements a comprehensive mental health legislation that ensures access to care and protects patient rights, the outcome is that enhanced legal protections for individuals with mental health conditions will be able to better access these mental-related services. So I want to imagine an international education campaign addressing mental health stigma across different cultures. The outcome is that there shall be increased mental health literacy, reduced stigma, and higher rates of help-seeking behavior. Imagine a situation where there is a series of training workshops equipping mental health professionals with skills in integrated care approaches. The outcome would be improved competency among professionals and better patient care outcomes. So this conference is so vital that it is going and has already started addressing some of the multifaceted challenges of mental health care by fostering international collaboration with colleagues from Harvard University, with colleagues from other institutions, Kenya Methodist University, colleagues from Kawara University, those ones who are already online, and even colleagues from the 20 universities that have really been represented in this conference. And you will notice that this conference has attracted a number of institutions, those ones from East Africa, those ones from the US, those ones from Europe, those ones from the diaspora. I think quite a number of them, about 21 institutions. So this conference aims to address the multifaceted challenges of mental health care by fostering international collaboration and promoting holistic and integrated approaches, advocating for robust legal and policy frameworks. So this dialogue provides a way of how we can share and debate about some of these conditions that are affecting humanity. Therefore, I want to welcome you again in this conference. This is our second day, and I believe that you'll enjoy the deliberations and also look at what is. I think maybe I need to talk about the deliverables that we arrived at yesterday. We said this collaboration should inform us to think about establishment of a brain bank, which of course will provide strategies of assessment, and the assessment that will give proper and effective treatment of these mental health conditions. And Professor Sabina yesterday mentioned about some psychological conditions that are unidentified, and these psychological conditions like schizophrenia. Most of us are not even able to know the local term for schizophrenia in our mother tongue. But when we talk about stress, talk about depression, these are conditions we always underestimate. We don't have equivalent names for such kind of conditions. Therefore, when someone is stressed and develops a coping strategy by, say, taking alcohol, when you take alcohol, you get addicted. And when you get addicted, you feel that that's the way you can cope with the stresses of life or depressions. And therefore, you do not get out of that condition unless there is proper assessment and diagnosis so that you can be helped to get out. So the only way we can do is to have a concerted effort and collaboration with our partners who have the infrastructure frameworks that will help us to do analysis. And she mentioned what we really can do and suggested that we can have some further communication on this subject. The other thing that, which of course is a deliverable, is that we need to have enhanced research. Research is very cardinal and very important because it provides evidence-based interventions to some of these ecological conditions. Last but not least, we continue engaging ourselves in dialogue to some of these issues, which of course will provide a platform for continued workshops and conferences. And I believe that the product of this conference will bring about many other conferences within the region, not only in Kenya Methodist University, not even in East Africa, not only even in Africa, but globally. This will be a call for purposes of enhancing mental health, rendering mental health, healing lives is what we need to advocate for. So I want to thank you and welcome you again to this meeting.
Hi, everyone. So welcome today to our second session of the Mental Health Conference. And today I have the pleasure of introducing you one of my mentors, Dr. Arturo Zavala. He's a professor in the Department of Psychology at California State University, Long Beach. He received his PhD in behavioral neuroscience from Arizona State University. Dr. Zavala's research program focuses on the functional consequences of early exposure to psychoactive drugs and later susceptibility to drug abuse, as well as the role of serotonin and glucagon-like peptides, which is a gut peptide, in modulating the effects of drug abuse. His laboratory combines neurochemical, molecular, and pharmacological approaches with animal behavior models to understand the basis of addiction in humans. Dr. Zavala is also the co-director of the Building Infrastructure Leading to Diversity programs, which aims to increase the number of underrepresented students entering biomedical and health-related research careers. Dr. Zavala received his Distinguished Faculty Research Scholarly and Creativity Activity Mentoring Award from Cal State and the National Award of Excellence and Mentorship from the National Hispanic Science Network for his involvement with the undergraduate and graduate minority graduate students in research. So thank you and welcome, Dr. Zavala.
Good morning. Can everyone hear me? Great. And so thank you very much for inviting me today, Dr. Pallavicino Maggio. I'm really excited to be here. And I think I'm going to start sharing my screen, but I don't think I can. I think I can. See me turn the lights. Can you see my screen?
Yes.
Okay, great. And so thank you very much for the invitation. I really appreciate it. And it sounds like a very exciting conference that you guys are having there. And so what I'm going to talk to you today about, as Dr. Pallavicino mentioned, is that I'm interested in the functional consequences of psychotropic drugs exposure during early in development and how that leads to susceptibility to drug abuse later in life. And but I'm going to give you a brief history of my career path and my life, because I think it's always important to share where we come from. And then I'll talk to you about the trends in medication in children, my overall research goals. And I'm going to tell you sort of three stories. One, exposure to drugs like methylphenidate, fluoxetine, and ketamine, and how that increases susceptibility to drugs like cocaine, nicotine, and alcohol later in life, and then talk to you about some future directions and clinical implications after that. And so the first part, I was born in Mexico. So I was born in a state called Puebla, and Puebla is just southeast of Mexico City that most people actually let me see, let me get my pointer, southeast of Mexico City. And these are my parents that lived in Puebla for just about 6 months or so. But then we moved to a state called León, Guanajuato. And León means lion in Spanish. And one of the central fountains in the downtown area has these lions. And that's where my sister was born. And a little fun fact about me is that my family is fairly large. I have 11 uncles and aunts from my dad's side. And in fact, my youngest uncle is actually 6 months younger than I am. So I came from a very big family in Mexico. And so we didn't stay very long in León. We moved to Mexico City. Actually, we were in Chiapas, which is the most southern state in Mexico, for about 6 months. But then we moved to Mexico City. And I grew up in Mexico City from about 3 to 10 years of age before we moved to California or Los Angeles, the United States. And I mostly grew up in southeast Los Angeles, which is primarily Hispanic population. 98% tend to be Hispanic, and about 80% tend to be Mexican. And I went to several different schools. We moved around a lot, but eventually we moved again to Fontana, which is about 60 miles, or I can't think in kilometers, but it's about maybe, I think, 80 kilometers, 90 kilometers east of Los Angeles. And then I grew up in Fontana and went to a local university nearby. And so as an immigrant, I'm a first-generation student. My parents didn't really know how to get me into college, but they said that I had to go to college. And so I followed most of what people did in the city that I lived in, is they went to the nearby institution, which was California State University, San Bernardino, which is actually a sister campus to one of the campuses that I'm currently working on. And so while I was in San Bernardino, I was very much interested in doing research. And I like to talk about this, especially because oftentimes we don't have sort of a direct trajectory in terms of where we end up going after we start our program. And so I started in my sophomore year working with David Chavez. And David Chavez was the only Mexican-American faculty that was in the department. And I gravitated towards him in part because he was Mexican. And so I did a lot of work with him doing cross-cultural research. And then over the career as an undergrad, I actually participated in several summer research experiences that we have available here in the U.S. And so I participated in the first one at University of California, Riverside, working with Ross Park, doing developmental psychology. The next summer, I went to Yale University to work with Alan Kasten and did developmental psychopathology. And then when I came back from my senior year, I actually started working with Robert Rico on my honors thesis in cognitive development, right? And so you can see that I've always had this interest in development and how, especially nowadays, how the brain sort of changes across development. I graduated. Before I graduated, I went to do another summer research internship at UCSF with Dr. Ricardo Munoz doing clinical psychology. And it wasn't until I took a class shortly at the end of my senior year that I actually became interested in neuroscience. But shortly after I finished, I actually went to work as a research assistant for the Thomas Rivera Policy Institute. And I also did research with Raymond Burrell at Pomona College. But then I came back to Cal State San Bernardino to do my master's in developmental neuropsychopharmacology. And I had taken a class with Dr. McDougall at the very end of my senior year where he looked at animal models and used animal models to try to understand the development of the brain and how different receptor systems sort of change across the lifespan. And I did a master's thesis where I focused on kappa opioid receptors, which are one of 3 opioid receptors that are found in the brain. The other ones that probably most people know about are the mu receptors, which is where things like morphine and fentanyl tend to act upon and produce euphoric effects. Kappa receptors are actually almost opposite of what you see with opioid receptors. And so one interesting thing that we discovered was that if you give a drug that activates these receptors at 16 days of age, you produce this locomotor activity or this enhanced movement in the animals. But if you waited just 2 days, you actually would not see that activity anymore. So the behavior almost completely goes away in just a short amount of time, or 2 days. And I want to highlight that point because I will talk about sort of why we use animal models to study certain things in neuroscience. After I finished my master's, I applied to work with Dr. Janet Nicewinder at Arizona State University, and I did my PhD there, as Dr. Pallavicino said, doing drug addiction and looking at the neural circuitry of cocaine-seeking behavior. And then rarely do you get to go directly into a faculty position, but that's what I did. As a grad student, I applied to work at Cal State University, Long Beach, and I've been there since 2008, teaching courses in the physiology of behavior, psychopharmacology, psychology of addiction, research in physiological psychology, and biological psychology. And there I work with a lot of students as part of a program that we call BUILD, which is there intended as a way to engage students in the lab in order to help them get into doctoral programs. And at our campus, we only have master's students and undergraduate students, so they aren't able to pursue the degree. And so what I'm going to tell you about today are these two studies that we worked on in the lab. One of them is a collaboration with my good friend and colleague, Dr. Sergio Iñiguez, who's at University of Texas El Paso, where we both are very much interested in looking at the effects of drugs across development. And so I'm going to switch over now to talking to you about my career trajectory, about what I've been doing at CSULB. And what I'm interested in is sort of the medications that we give to children, right? And so if we look, one thing that we tend to treat a lot is attention deficit hyperactivity disorder. And so this is a neurobehavioral disorder that's characterized by impulsivity, inattention, and restlessness. And what I find interesting is that we have seen about a 90% increase in the diagnosis of the ADHD in children, right, since the early 90s. And in fact, it's probably even higher now. And we're even seeing a trend to diagnosing people who are in adulthood, right? And so the push is to diagnose across adulthood now. And what's interesting to me is that a lot of these diagnoses actually occur in kids that are under 6 years of age. And so in fact, of the 6 million kids, 2 million of them are diagnosed with ADHD as early as 2 years of age, or 2 to 5 years of age, or what we would consider here in the US sort of preschool age. You typically start first grade at 6 years of age, or you start kindergarten at 5 years of age. And so we diagnose a lot of these kids prior to 6 years of age, and we often rely on two things when we think of ADHD. One is sort of behavioral approaches to dealing with the impulsivity or the symptoms, right? And the other one is actually using psychostimulants. Psychostimulants like methylphenidate, which is more commonly known as Ritalin, and amphetamine, which is more commonly known as Adderall. These two medications are the ones that are primarily used to treat kids who have ADHD. And what you can see in this graph here is that if you look at the percentage on this axis, and on the bottom you see the age of the kids, behavioral treatments tends to be the predominant approach in kids that are 2 to 4 or 5 years of age. But by 6 especially, you start to see an increase in the amount of medication that's given to kids. And in fact, it's the predominant one after 6 years of age. Largely, it's due to the fact that the Federal Drug Administration, or what approves the medications here in the U.S., the FDA, has an approval of 6 years of age and beyond. But in the U.S., you can actually prescribe the medication. It's called off-label use of the medication, and you can give that. You can see about 20% of the kids are getting medication even at 4 or 5 years of age. And in fact, I'll mention it in a little bit, but there's even chewable forms of Adderall that you can actually prescribe that has been approved about 4 or 5 years ago. And so because it's obviously difficult to give medications to young children because they don't know how to swallow pills, and so they're making it easier by providing them with a chewable form of the Adderall. And so because we're sort of an international conference, I sort of wanted to point out that amphetamine and methylphenidate are primarily used across the U.S., right? We're the #1 user of amphetamine and methylphenidate in North America, but it's also popular in Europe and Western Europe, and not very popular in Africa, for example. There's only a few countries here. Largely, partly it's because of the cost of the medication tends to be high. Right. But in general, we have, lots of use of these medications, particularly in these younger populations. And so in addition to ADHD medications, antidepressants have also been used more so in the last 15 to 20 years. And the one medication that it's used that most people are familiar with is called Prozac or fluoxetine. Fluoxetine was probably the most popular antidepressant that was sort of developed in the 1980s and by Eli Lilly. And you can see that the number of antidepressants across here's the number of years, and the rate per 1,000 has increased quite a bit for these antidepressants. In fact, the age period at which you see a lot of these medications is actually 15 to 18 years of age, as you can see highlighted here during the same period, right? And this trend has sort of continued into the 2020s, where you're seeing a lot of the adolescents that get exposed to these medications. And so why should we care, right? Why should we care about all these medications being prescribed? Well, in the case of ADHD, right, diagnosing ADHD is actually a pretty complicated diagnosis, I would say, right? Or it's not something that should be taken lightly. In fact, a lot of studies show that ADHD is actually misdiagnosed in a lot of children. Some kids, especially boys, tend to be less mature than females, and in fact, most of the diagnosis for ADHD tends to be diagnosed in males compared to females. And a lot of times, most of the kids are actually just expressing this immature behavior that if you actually didn't treat would eventually go away a few years after that, because they're not as developmentally advanced as females, for example. But it could be even things like not checking kids that are not paying attention, not because they're inattentive, it's because they can't see very well, right? We don't accustom to checking kids that are 2-3 years of age for vision problems. And then the other one that what we saw is that the two conditions that we see a lot of diagnosis for is actually major depressive disorder or bipolar disorder. So kids could be actually experiencing major depressive disorder, and one of the characteristics of hallmark of depression is to actually be withdrawn, not engage in activities that you normally find pleasurable. And so it seems that these kids that are sort of expressing depressive-like sort of symptoms early in life are being misdiagnosed with ADHD. And probably the most striking one, which probably is not surprising, is that it's not psychiatrists or psychologists that are actually diagnosing these kids with ADHD, right? It's mostly physicians, and a lot of the physicians don't really adhere to the DSM or the Diagnostic Statistical Manual, which is what's used in the U.S. to diagnose people with ADHD and other psychiatric conditions. And so they don't really follow these guidelines, and in fact rely mostly on testimonies from parents or guardians or even teachers, right? Teachers basically highlight to the parents that the kid is not as attentive, is not paying attention. That gets reported to the doctor, and the doctor then diagnoses them with ADHD and prescribes them the medication, right? And so that's one problem, is that we don't really have these biomarkers or a good understanding of the biological causes of ADHD to be able to create a test, for example, right? It's not like diabetes where we can, for example, check somebody's glucose levels over the past 3 months, and if they're above a certain level, we assume that it's because they're not regulating their glucose levels well as a result of insulin resistance, for example, right? So there aren't things like that for psychiatric conditions, which makes it difficult. Same is true of depression. We don't necessarily have a test that we can do. We rely primarily on these behavioral observations about diagnosing these conditions. And so it becomes especially problematic in these younger kids, right? The other thing is that the prescriptions haven't really been tested in terms of the long-term effects. Most of what has been tested is whether kids can actually tolerate, right, these medications. Or in other words, they're looking at toxicity, right, levels in these kids. And one study found actually that these ADHD medications tend to be not as metabolized as quickly as they are in older kids. And so that's one thing that they found, which is why they prescribe or they suggested to only give it to 6 years and above, because the younger kids were metabolizing the drug as well and had higher concentrations of it. But they still, as I showed you, is still being prescribed because it's off-label prescriptions of medications is acceptable within the U.S. And so a few studies have really examined the long-term consequences of Ritalin in preschoolers with ADHD, or possibly no ADHD, since there's a lot of misdiagnosis, as I mentioned. And so the same is true for antidepressants. There aren't really studies that have looked at the long-term effects of looking at these antidepressants early in life and how that makes you more susceptible later in adulthood, for example, right? Those are not, mostly what has been tested is, again, the toxicity or the safety of the drugs in that age period, but not necessarily the long-term effects. And why might that be problematic? A lot of research in neuroscience has pointed to the fact that especially during adolescence, we see a lot of reorganization of the brain. We see changes in the number of synapses and the myelination of different pathways between the brains. In fact, neurogenesis, or the ability to reorganize in the adolescence and even early childhood, is actually a lot more heightened than it is in adults, which is why, you know, it's easier to teach kids a new language as opposed to an adult, right? They don't pick it up as quickly because their brains are just more malleable. Here's one example of how much change you see, particularly in the prefrontal cortex. So this is the frontal part of the brain called the frontal cortex. And then this is images across 5 to 18 years. And what you're seeing is a lot of reorganization of the brain occurring between 5 and 18 years of age. The amount of gray matter, which represents the number of cells, right, is actually decreasing because it's all being rearranged. And so one of the things that's problematic about using things like ADHD medications and antidepressants is that a lot of the perspectives about how they tend to work is actually by changing the brain, right? Changing the brains of these individuals. And so we don't know the interaction of this developmental change with addition of these drugs and how that makes people, how that affects the brains of these individuals, right? And so one of the things that myself and my colleague have been interested in is looking at whether there is a vulnerability, right, to other drugs later in life if you get exposed to things like Ritalin, fluoxetine, and ketamine, which I'll talk in a little bit, when the kids are children or adolescents, right? And for children, it's mostly Ritalin and Adderall that's being prescribed. For adolescents, it's mostly the fluoxetine or the ketamine that's being prescribed. Right? And so our overall hypothesis, we suspected, because a lot of these drugs tend to work on similar systems to nicotine and cocaine and alcohol, they work by activating these natural reward pathways in the brain. And these medications activate those same systems. And so it's not unlikely that we would see some long-term effects as a result of using these drugs early in life. And so the problem, which is why there hasn't been studies on this, is because it would take a very long time to do this in a clinical population, right? You would have to follow kids for 15, 20 years before you might actually see some effects. And of course, no PhD student or master's student is going to want to do that. And so it's difficult to study this topic, and that's why there's not as much research on that. You have to do these other approaches, cross-sectional studies, to be able to do something, but those are problematic on their own. And there's actually a lot of kids that start medications early and continue for like 5-6 years and then stop taking the medication. And so those kids aren't really followed or tracked, right? And that's kind of the problem with studying this topic in clinical populations. However, we have time frame, right? And so a much more quicker time frame. And so neonatal exposure, or what is considered sort of the infancy, is days 1 through 20. Adolescence is around 31 to 60. Juvenile, which would be equivalent to the pre-adolescent and childhood, is around 21 to 30. And then the adulthood happens at 61 years of age. And so using animal models has been advantageous to ask questions about exposure to drugs early in life. That, for example, that's very characteristic of humans is the emergence of sex hormones in adolescence, right? And females tend to experience puberty a little bit sooner than males. But you can see that in rats, they also tend to see the emergence of hormones relatively around the same time, juvenile adolescent period, a little bit earlier for females than it is for males. And if we look at the brains, right, a lot of the things that I told you of in terms of the changes that we see in the brain are actually based on animal studies, where they can examine changes in receptors much more easily. And so we see a lot of correspondence in terms of the brain development, even behavioral characteristics, right? Adolescents tend to be more novelty seekers, tend to be more influenced by peers. We see that adolescents in rodents also are very playful and are dependent on others during this age period. And so behaviorally, and in looking at the brain, we have pretty good correspondence. And so using this approach, we can ask questions like, well, what would happen if we provide animals with exposure to methylphenidate early in life, and how does that affect their responses to nicotine and cocaine, for example, during adolescence? And in the same way for antidepressants, we can ask what would happen if we expose animals to fluoxetine or ketamine early in adolescence, and how does that affect their responses to alcohol and cocaine? And those are the studies that I'm going to be focusing on today. And so one thing that we are interested in our lab is to look at vulnerability to drug abuse, and we examine the susceptibility to drug abuse by looking at what's called the condition place preference, which allows us to assess whether a drug is actually rewarding or not, right, in this example here. And so you can see that there's different phases: preconditioning, conditioning, and post-conditioning. During preconditioning, the animals are put in a box that has two different sides that are different in terms of the visual cues and tactile cues, and we give them access to both sides to explore, right? They can explore, and one of them they tend to prefer, the other one they don't prefer as much. During conditioning, we confine them to only one side, and so what we do is we pair the drug to one side and we pair water or saline to the other side. And what we're trying to do is associate the effect of the drug with this particular environment, right? And so this environment will be associated with drug. This environment will be associated with saline or water. And we do this for 2 to 9 days. Sometimes we only give one drug pairing, sometimes we give 3, sometimes we give 4. The more you do, the more the association, right, that you create. And then during post-conditioning, we don't give them any drugs anymore, and now we ask the animals to choose which side they prefer. And so if they like the effect of the drug, what we'll see is that animals spend more time on the drug-paired side compared to the side that was paired with saline. And so we can actually determine that by looking at the time spent on the drug-paired side versus time spent on the saline paired side, and we can subtract that. That's one way, so that higher scores, if they spend more time here, let's say 500 seconds and only 300 seconds, the difference is 200, so it's plus 200 on the drug paired side. Sometimes we can compare the preconditioning and post-conditioning time. So this is the time that on the drug paired side after they've been given drug. This is before they've been given drug. And again, the higher the preference score, the more it is that the animals are telling us that they liked the effects of the drug, that they found them rewarding. And the lower the number means that they didn't like the effect of the drug, right? And for some drugs, we actually see that the animals don't like the effects, as I'll explain to you in a little bit. And so we have a model that allows us to see whether the animals find the effects of the drug rewarding or whether they find them aversive. And that's what the condition-placed preference is allowing us to do. And so the first study I'm going to talk to you about is one where we expose animals that were 11 days of age to 20 days of age, which is we think is comparable to the preschool age period, to either methylphenidate or saline. And then we waited until they were adolescents, which is 34, to expose them to nicotine and assess this nicotine-placed preference, where we pair one side with nicotine, one side with saline, and we see if they like which side they spend the most time on, right? But notice that we only give methylphenidate up until 20, right? After that, we give them no more methylphenidate, so that's why it's sort of a long-term effect of these drugs, because they haven't received methylphenidate for at least 14 days before we started the conditioning. And so on this graph, I'm showing you the time the animals spent on the nicotine-paired compartment on this axis here, and different doses of nicotine that they receive, 0.2 or 0.6. And this is the time before, and this is the time afterwards, right? And you can see that animals that are given 0.2 milligrams of nicotine that have not been given any methylphenidate when they were young, so they receive saline, they basically don't find the effect of 2.2. There's no change in their amount of time that they spend. But the animals that got 0.6 showed a preference for the nicotine-paired side. And so this tells us that this dose the animals liked because they tend to seek out, right, the drug in that particular environment. And so they're exhibiting what we call nicotine-seeking behavior because they know that this side is associated with drug, and so they're spending more time seeking out that side compared to before. And so now we're going to see animals that get 2 or 4 milligrams of methylphenidate, right? And we picked 2 different doses to try to model the fact that some kids are actually getting extended release tablets of these Ritalin when they're young. And so when we look at the 0.2 milligram dose, we see a increase towards the nicotine paired side when they were given methylphenidate as in the preschool age period, right? During adolescence, they actually like the effects of nicotine and don't necessarily, and in a dose-dependent way, right? As we increase the dose of methylphenidate, we see an increase. And so this, in essence, shows us that the animals are showing an enhanced sensitivity to the effects of nicotine. We've enhanced the effect of nicotine because now animals like the effect of 0.2, whereas animals that don't get the drug are actually showing no preference at all. And then when we gave them the higher dose, initially we saw no changes, which was a little perplexing, right? The 2 and the 4 both didn't produce preference for that side, but this one did produce preference. And so I'm going to take this data and show it to you again here. All right, this is, again, the same data. We see preference at 0.2 and no preference at 0.6 in these animals that were given methylphenidate. When you look at nicotine, and this is based on a different study, right, where it's looking at a different score now, and so it's taking the time here minus the time here, and so this is equivalent to the preference score. Higher values means that they like the side that was paired with nicotine. Lower values means that they don't like the side that was paired with nicotine. And here you see adolescents and adults. And this is one thing that's very characteristic of adolescents, is that what we see when we give animals different doses of nicotine, adolescents tend to like the effects of nicotine more so than adults. So this graph, this line here represents the adults. Adult animals that are given 0.8 don't show a preference, 0.6. In fact, at 1.2, they actually show what's called aversion. They're spending a lot less time there because they don't like the effect of the nicotine. Whereas adolescents tend to like doses much longer than the adults do, right? So that's one thing that we know about adolescents, that all those things that we talked about in terms of the changes in the brain, and especially in the prefrontal cortex and mesolimbic areas, leads us to believe that adolescents are more prone to like the effects of drugs and actually less likely to exhibit aversion, right? So they're already a vulnerable population because they tend to like the effects of drugs and don't show aversion to these. And this is true of both nicotine and alcohol and other drugs that we've tested. And so what we think is happening then is that this is the normal response of adolescents. When we give animals methylphenidate, we're kind of shifting the dose response curve to the left, right? Where a low dose that normally doesn't produce preference, now we find that the animals that are given methylphenidate like it, right? And animals that show preference to the higher dose move towards this lower end of the curve, right? And so this early exposure to methylphenidate seems to be shifting the dose response to nicotine towards the left, indicating that there's an increased sensitivity to the effects of nicotine as an adolescent that had been exposed to methylphenidate early in life, right? And so one question that we asked ourselves, well, is this a general effect? Does giving methylphenidate to animals is going to produce a marked change in the effects of nicotine across any behavior that we are interested in? We also know that if you give animals nicotine or methylphenidate or a lot of these medications that are used, you actually see an increase in locomotor activity or this enhanced movement when you put them in a box. So if you inject them with cocaine, nicotine, what you see is a lot more movement compared to animals that don't. And so we tested this idea where we gave the animals methylphenidate and now wanted to see if there was changes in this behavior sensitization as a result of the early exposure to nicotine. And so here I have the data. And so what you're seeing here is the amount of distance traveled. Got cut off, but this is the number of centimeters that the animals explored within the box across 7 days that were given different doses of nicotine, the 0.2 and the 0.6 that we used in the other study. And these are animals that were given methylphenidate. These are animals that were given saline. And you can see that there's no difference between the saline and methylphenidate pre-treated animals. And in fact, what you see is that animals that get saline don't really change how much they move around, but the animals that are given nicotine tend to increase the amount of activity that they exhibit throughout the 7 days, despite not changing the dose. And that's what we refer to as sensitization, where there is an enhanced effect of the drug by giving it repeatedly, right? But importantly, there's no difference between saline and methylphenidate. Another way to sort of assess it is to give animals that have been pretreated with the methylphenidate given different doses. So this is just looking at it sort of on a separate test day. On the next day, we give all the animals a lower dose of nicotine. And this represents animals that are given 0.2 milligrams of nicotine, and this is how much activity they show. Animals that were pre-treated with nicotine tend to have this enhanced effect, kind of like what you see here. It's just another test day, but sort of summarized for an individual day. The point is that there's no differences between saline and methylphenidate exposed animals, right? And so now we see a very selective effect. So methylphenidate enhances the rewarding effect of nicotine, but it doesn't affect all things that nicotine does. It doesn't affect, for example, the locomotor stimulating effects that you see in these animals. And so that's the case for nicotine. We then wanted to test exposure to fluoxetine during adolescence, because remember that for antidepressants, most of the antidepressants are given during adolescence. And so we give animals fluoxetine, which is Prozac, from 35 to 49 days of age, and then, or saline, and then we wait, in this case about 20 days, before they're tested for cocaine condition-place preference, as we've talked about before, where we pair one side with cocaine, the other side with saline, and we see how they respond to the effects of cocaine after 20 days of not having any fluoxetine in their system. And so what we see here is the place preference again. So this is drug side minus saline. So positive scores means that they like the side that was paired with cocaine. Negative scores means they don't like it, across different doses of cocaine. And in brown, you see saline pretreated animals, and in blue, you see the fluoxetine pretreated animals. And so you get two effects here where the effects of fluoxetine enhance the effect of 5 and 10 milligrams of cocaine. And so kind of like what we saw with nicotine, we see a leftward shift in the dose response curve. Now animals that are getting fluoxetine are actually showing an enhanced response to cocaine, even though it's been 20 days since they actually have received that, right? And so what these two studies really summarize for us is that a brief exposure to methylphenidate, right, during a period that's equivalent to preschool-age children, increase the sensitivity to the rewarding effects of nicotine, but importantly doesn't change every effect of nicotine. There was no changes in nicotine-induced sensitization at all, right? We're just affecting the rewarding effects. And in the second study, we saw that fluoxetine exposure during adolescence also increased the sensitivity to the rewarding effects of cocaine. And so many of you may know that fluoxetine or Prozac is actually not very effective in treating depression. In fact, a lot of people, or a large proportion of people that take these medications don't actually feel better at all, even after taking it for 3 or 4 months. And oftentimes they tell you that it will take about 2 to 3 months if you are going to see an effect. And so even in adolescents, you see that about 40% of adolescents who are given these medications don't see a significant reduction in depressive symptoms. And so what's been exciting in the world of antidepressant research is that there are new medications out there that aren't new but have been repurposed. And the first one to be repurposed that became very popular was actually ketamine. Ketamine is an old drug that works in a different way than fluoxetine. It blocks glutamate receptors in the brain, and it's been used as an anesthetic for a long time in drug abuse scenarios. It's also used as a party drug, or it's also abused in lower doses. So lower doses of the drug tend to be abused, and also higher doses tend to produce this anesthesia. But in any case, in 2006, Zarate took basically ketamine and injected it in individuals who were experiencing depression. So on this scale here, you see a measure that basically the higher the level means that the higher depressive symptoms they're reporting, and across time and on the bottom axis, and prior to getting any drug, they were equal in terms of how much they were reporting. And after they received ketamine infusions in white, you can see that about 110 to 230 minutes later, they tended to report less symptoms of depression compared to individuals that were given placebo. And this is in humans. So humans are reporting a dramatic decrease in the symptoms of depression after a single infusion of the drug about 230 minutes afterwards. And in fact, this lasted to about 7 days, right? And there's been a lot of excitement about looking at these new antidepressants. These are like the third generation of antidepressants that are working sort of differently. Ketamine tends to work more postsynaptically and activates a lot of molecular mechanisms in the brain that are different than what the traditional antidepressants do. They tend to cause more changes in neuroplasticity, right? So here again is another drug that how we think it's working is by altering the activity of the brain of these individuals in a much more rapid way. And what we tested was their preference for cocaine. And one thing that is that we examine in this case, because ketamine tends to block the receptors for glutamate. People argue that maybe there'll be changes in their locomotor activity, but there was no changes in locomotor activity in the animals that were pre-treated, because obviously how they explore the box is important, and if you impair their ability to move, then you're going to see different results. But there's no changes. And so here's the results. Again, we're looking at a preference score. Positive values means they like the side pair to cocaine. And remember that where we had seen effects was in the 10 and the 5 milligram dose. That's what we chose here. And again, we see that getting vehicle or during the adolescent period doesn't produce as strong of an effect to the effects of cocaine as getting ketamine during the adolescent period. We see this enhancement again, a leftward shift in dose response curve to the effects of cocaine. And so we basically see that with fluoxetine and with ketamine, we see this enhanced effect to cocaine when the animals were exposed to either fluoxetine or ketamine early in life. And so when we published this study, one of the things that people always ask, well, is there something special about adolescence, right? Like I've argued earlier that there's lots of changes in the brain, a lot of synaptic reorganization, lots of neurogenesis. And so in this next experiment, what we did is we did exactly the same scenario, but we just moved the period. So there's 20 days where they're not getting any ketamine in this example, right? So we basically move the age periods. And so now we start as adults and expose them to the same amount of time to ketamine or vehicle, and then wait 20 days and then test them for cocaine CPP later in life. So we've just shifted the age period at which we expose them to ketamine, right? And now when we look at the effects of 5 and 10 milligrams, there's no difference between the vehicle or ketamine exposed animals. And so what this shows us is that you have to get ketamine in adolescence to see this enhanced effect. If you get ketamine as an adult, you actually don't see this enhanced effect of cocaine, right? That it's specific to this age period that you're going to see an enhancement of the effects of cocaine. And so that was exciting for us. And so we've also tested other drugs like ethanol, and in this study here, we gave animals ketamine or saline during the pre-adolescent period, 21 to 30, and then we tested the effects of ethanol in adolescence. So there's not much time between, there's only 10 days in between the exposure to the adolescents, but we did that because we wanted to examine the effects of ethanol or alcohol, right? And alcohol is what's consumed much more in adolescence compared to adulthood, right? Or at least using alcohol early in life tends to have more problems. And so here we see the same preference score that we've seen before. On the left is animals that are given different doses of ethanol, right? 0.125, 0.5, and 2. And we see a typical pattern that lower doses tend to produce preference compared to saline. But as we increase the dose of ethanol, we see a decrease in the effects of ethanol, right? Because ethanol tends to be sort of aversive at higher doses, as we can see here. What was surprising is that animals that get ketamine actually never showed a preference or any difference compared to the saline controls. In fact, they tended to show even lower preferences compared to animals that were getting vehicle. And so we're seeing sort of the opposite effect, that ketamine actually prevents the effects of the rewarding effects of ethanol. And likely, as we thought about it more and we sort of discussed it in the paper, it has to do with sort of the mechanism of action of how ketamine works in the brain and how alcohol works in the brain. So alcohol tends to enhance the effects of the main inhibitory neurotransmitter in the brain, GABA, and also block the effects of glutamate. Right, so it's a depressant. It decreases the activity of the nervous system, and ketamine also works in glutamate. It blocks the effects of glutamate, and so pre-exposing him to ketamine, we think, is actually changing these receptors, these glutamate receptors, and as a result of this decrease in the receptor activity, then we don't see as much effects of ethanol later in life, right? And so that's sort of our working hypothesis that we are going to be testing, whether there are any changes in the effects. In fact, most of the future directions in our lab is to actually look at what are the changes in dopamine, opioid receptors, GABA receptors, all throughout these circuits where these drugs tend to have their effect. And what I showed you is an animal model that looks at sort of the rewarding effects of drugs, but there are other models that we can use, the self-administration model. In this example, we have a lever that the animals can press, and when they press the lever, it activates a computer to turn on a pump that has a syringe that allows them to get an infusion of the drug intravenously, right? And so the animal has control over how much drug that they're able to take. And in fact, almost every drug that humans tend to self-administer, animals will also self-administer, right? So cocaine, nicotine, and alcohol tend to be self-administered by these animals. Sometimes we don't give the drug intravenously. We can also give the drug through a spout, right? So they can drink the effects of alcohol. And just like in humans, most humans who drink alcohol don't actually, or teenagers don't actually drink pure alcohol. They usually drink these very sugary flavored alcohol drinks, and then eventually sort of are able to try something. And we actually see that with animals too, that when they are given alcohol, they don't like it as much. You have to sweeten it up. Once you sweeten it up for about 10 days, then you can wean them off the sugar, and then they'll drink the alcohol altogether. And so we're interested in examining whether animals will take more drug if they've been exposed to the effects of methylphenidate early in life or ketamine early in life. We've actually done one with cocaine. I didn't include it because I didn't want to have too much time and I wanted to leave time for questions. But we have seen already that cocaine self-administration is enhanced if they're given methylphenidate early in life. And so in terms of the clinical implications, one thing that I always talk about is that we should be careful in our diagnosis of ADHD and depressions, especially in pediatric populations, because we don't want to necessarily prescribe these medications, especially in the preschool age period when it's really difficult to diagnose this ADHD, because we're in essence increasing the vulnerability to drugs of abuse, right? And adolescents are already more vulnerable because they tend to experience the effects of drugs much more intensely, don't experience the aversive effects as much, and they're already a vulnerable population, and giving them these drugs even earlier is going to make that even more problematic, right? Now, that's not to say that you shouldn't treat, kids with medications. I don't argue that either, because in the case of antidepressants, for example, you have to treat people who are depressed because the outcome of not treating is going to be, it could be lead to suicide, right? And so mostly what we argue is that we need to be aware of all the side effects that result from using these medications, right? So it's about increasing knowledge and increasing awareness, more so about not necessarily using these medications altogether, right? Because we don't want to stigmatize the use of medications as being very problematic. We just want to be aware of all the problems that could happen, or all these side effects that could happen as a result of using these medications, right? And so then the last part is that it seems like ketamine may be useful in the treatment of alcohol, right? Just like ketamine is useful to treat depression, it might actually be useful in attenuating or getting people to come off alcohol abuse, right? And so that's one idea that we're hoping to study in the future. And so with that, I want to thank all the students. I mostly work with undergraduate students and master students that most of them have gone on to PhD programs. I've had about 23 that have gone on to PhD programs and about 8 or 9 that have finished their PhD. And most of our funding comes from training grants like the BUILD program and the Mark U Start program that basically are training programs to get these students in labs to actually give them the experience and go into disciplines like neuroscience for their career. And so with that, I'm happy to take questions. And maybe I'll stop sharing slides so that I can see people.
Thank you very much for this important presentation, and accept that what we were discussing yesterday is in line with what our intentions are, especially in the East African region, and more important, Kabaale University and Kenya Methodist University is an important aspect that we are looking forward to doing research with you. And when you talked about a clinic for alcohol, I was excited that we can have some of these clinics spread through our regions here. And I think we need to begin thinking about it. Professor Zahra comes from the University of California, am I right?
Yes, Cal State University, Long Beach.
Very good.
Yeah.
So what our discussions have been very, very interesting throughout the previous day, because we are really interested on this concept of conditioned responses in drug dependence. So your presentation has really emphasized how individuals develop conditioned responses to drug-related cues, which play a significant role in the cycle of addiction. And here in Kenya, we have a place called Maua. Maybe you'll pronounce it at your own time. Maua has a special drug called Miraa, CAT. In fact, as I was discussing with some of the colleagues, they mentioned that there's a special kind of Miraa that when you take it, it impairs the brain and can make you so aggressive. And in fact, before you do an action, or before you say an action, it is already done because of that influence of that drug. So I was thinking that we can be able to do research in that area. We can get samples and do research, and maybe a collaborative research that will give an implication of how this drug can affect specific brain areas within the East African region, and especially reference would be Kabaale and Kenya Methodist University. I'm not so pertinent to these three institutions, but in Maua, and I think maybe one day you should visit this place and see what we are talking about. It has a drug, it is looked at as a drug, but this drug is also a cash crop. So it will be very interesting that this drug impairs the system of the brain. And as you are talking about our attention to adolescent, ketamine exposure and its influence on cocaine preference, you have articulated these aspects very well, and your research has indicated that early exposure to ketamine can alter brain chemistry in ways that increase susceptibility to cocaine addiction later in life. So I want to see some of these influences in terms of these drugs, CAT, looking at different regions in the area. So Prof, I would like you maybe to respond to the following 5 items. 1, how can we better integrate spiritual practices into conventional psychiatric treatments to enhance patient outcomes? Because I'm looking at what you are just suggesting, that further research should be able to be done to do that. So one of my questions is, how can we better integrate spiritual practices into conventional psychiatric treatments to enhance patient outcomes? I want to go to number 2. What strategies can be employed to mitigate the risks associated with adolescent exposure to substances like ketamine? Because in Africa, suicide has been a big issue among students and also among the teaching profession and the medical profession. So suicide is something like a loyal road to the reality. So, question number 3, in what ways can we strengthen interdisciplinary collaboration to address the multifaceted nature of drug dependence? On the road here in Africa, and especially in East Africa, any driver who is going to be seen must be under the influence of a drug. So to say, you'll find that someone driving is chewing something to impair and make him alive or safe during driving. So I would wish that we can be able to strengthen the interdisciplinary collaboration to address some of these multifaceted nature of drug dependence. When you come to Kenya, you'll find they use different drugs, and these drugs impair the brain. Mm-hmm. And as we talked yesterday, we are thinking of a brain bank in East Africa. Question number 4. What role can community-based programs play in supporting mental health and preventing substance abuse among adolescents? I have identified the adolescents because these are the people that congregate in schools, in universities, but I'm not reserving the other population, the academic staff, who some cannot stand before a lecture when they are not under the influence of alcohol, and especially in public universities. Here at Kenya Methodist University is a Christian university, and I think that could be forbidden. But then that's the reason why we're having the conference on the interplay or integration of spirituality, psychiatry, mental health, and psychotherapy. So I would wish to extend this because CAT or MIRA can be accessed through the community. And therefore, I would wish to see the role, what role can community-based programs play in supporting mental health and preventing substance abuse among adolescents. We can extend it to teachers, we can extend it to other professionals. Last but not least, how can we leverage technology to improve access to mental health services and support recovery? I appreciated the experiments that you have demonstrated with animals, exposing them to some alcohol, and then you see how the behavior will be able to change. I would wish that we can have an alternative infrastructure framework that would be able to test some of these behaviors in our institutions of higher learning. One day I studied, I like your biography, I studied in a university called Egerton. During that time of my study at my postgraduate, the university has a number of flower gardens and all that. So I stayed there for about 2 years, but later on I discovered there was a weed which was being planted, only to discover that the students had brought it so that they can be able to use it whenever they have stresses of exams, whenever they have stresses of life. So I would like us to see how we can have a form of technology that can improve access to mental health services and support the recovery. I submit.
Thank you. Those are all very good questions, and I think that I can address some of them. So I'm interested a lot in what I show you today is actually drugs that actually enhance the effects of drugs, right? So that's one end of the spectrum. But you're right that there are actually other ways to approach it, and I didn't talk about those this time. But what other drugs can we use to actually alleviate and attenuate, right? And there's actually interest in the cat plant that you speak of, because there's actually a lot of especially there's a lot of interest now in a lot of the medications that are used in indigenous populations, right? Ibogaine is one of them, especially in the South America, and cat plant are these plants that are reported to actually help with the treatment of addiction, right? And so one idea to actually think about is we can use these animal models that I talked to you about to see if those plants, if we can deliver them in some way, could actually decrease the preferences for these drugs as a way to sort of model it, right? And even using the self-administration model, we can try to model things like relapse, and where one of the biggest problems with addiction is that even after long periods of not using the drug, people still sort of crave and desire the drug, and that's what gets them to go back to using. And what triggers that is actually exposure to cues. You mentioned sort of conditioning factors, right? And being someone who, for example, used heroin and used needles, right, they can go into treatment and get rid of their physical symptoms of addiction, because after 90 days they're no longer going to experience these physical withdrawal symptoms, but then go back to their environment and get exposed to these cues that reminding them of the experience, such as looking at a syringe, right, or looking at even people that they used to use the drug with, and that actually triggers a strong reaction, right, what we call a craving response that makes them want to try the drugs again, right? And so a lot of the focus in addiction has been, well, what kinds of medications can we use, right, that will help lessen the effects of the craving that people experience as a result of these conditioning factors, right? So certainly testing something like CAT, right, or using whatever treatments you think might be working has been sort of the approach. There's a lot of interest right now in the world of addiction on psychedelics. So psychedelics are another very popular, or mushrooms are very popular as ways of treating several conditions, not just addiction, but also even depression. And they're doing now these very controlled studies with therapists and microdosing of psychedelics to actually help people deal with their addiction or deal with their depression, right? So certainly I think any collaboration where you think that there are certain things that might be helpful in alleviating the effects of drugs, you can test them using these models like the CPP to decrease the preference, or looking at the self-administration model would be actually a fairly easy thing to do. As you might expect, you've brought up the idea of the community, and I think that one thing we need to think about when we think about addiction is that it's not just going to be solved by taking medications. It's not going to be solved by simple behavioral. It's a much more complex phenomenon than what we can actually study in humans, right? And what we do know that things that are most effective in helping people deal with addiction is actually a lot of community support, being around people who are going to support them. So having this community engagement and support is important in actually dealing with the addiction itself, right? That you're not going to just find a drug that's magically going to get people to become not dependent on the drug itself, because there's no magic pill that's going to work that way, right? And so I think it's very important to embrace the community and to have sort of spiritual guidance in dealing with addiction, right? It kind of goes back to what you said too in terms of the adolescents. You wanted to talk about how we work with adolescents and prevention of drugs. What has been effective is using community, but that are peers, right? And so oftentimes kids don't listen to adults, right? But they listen to other kids. And so having peer counselors talking to them and basically dispelling misconceptions about drug use and having them being involving also the family and the community is what seems to be the most effective way to prevent people from actually using drugs like alcohol, right? if you just try to use scare tactics, right, like especially in the U.S., you had during the 1980s and 90s, there was a big campaign, the Say No to Drugs campaign, and you would tell people that if you use cocaine once or if you use heroin once, you were addicted for life, right? Trying to scare people into not using drugs, and those scare tactics don't work, right? They don't work because in reality, most people who use cocaine and alcohol don't actually become very dependent on it. It's only a subset of the population that actually becomes very dependent on and becomes addicted to these drugs, right? And so you're misinforming people about the effects of the drug because you are telling them that they're going to be addicted for life if they use it once, and if they tried it and they don't, then they might think they're like Superman or something, right? Because like I must be immune to it. But we do know that the majority of people don't have problem use with alcohol and nicotine and so on. So it's more about letting people know that the continued use of these medications or these drugs actually is what's going to be problematic, right? That we do know. And sort of the main ideas in addiction now is that the longer you use a drug, the more likely it is that you see these brain changes that make people not able to regulate their intake, right? But we don't really have a good understanding as to the switch. When does it switch from not being able to regulate drug intake overall? So in terms of dealing with kids, I think having peers and having honest conversations about the effects of drugs and letting them know that we don't have a good understanding as to how people become sort of dependent, but we do know that the more you use it, the more likely it is that you're going to be dependent on it. And we do know that even early use, the earlier you use medication, the drugs, right, the more likely it is that you're going to develop problems later in life. And so that sort of has been the idea. And I think, you talked about technology. I think, this is one perfect example of how we could use technology to get knowledge about either new approaches, new treatments, is the fact that COVID made things, COVID-19, the only positive thing I think is it has made us even more able to reach and connect with other people. I wouldn't be able to talk to you probably 10 years ago because this technology wasn't around very much. And in fact, I think using telemedicine, right, a lot of times access to professionals is what is it hinders the ability to treat people, right, especially in remote locations. And so I would think that creating these networks and interacting with people online and using things like Zoom to be able to create this bigger support network for people who are dealing with addiction is going to be key. And so, and I see a lot of questions on the chat, and so I'm just going to address a couple of them. In Africa, people are not exposed to depressant drugs, but to antibiotics. Do these drugs exposure? That's actually a good question. We actually don't. I think the antibiotics are very popular, especially in the U.S. Before 10 years of age. But we don't have a lot of understanding of whether antibiotics actually affect the responses to drugs. Partly it has to do with the fact that maybe they don't necessarily cross into the brain, right? And so they might be treating conditions outside the brain, so the peripheral nervous system. But I don't know a lot about antibiotics. I do know that there is a lot of interest now in looking at drugs that are used for anesthesia. And so kids may get exposed to anesthetics early on as a result of dentistry, or a lot of doctors are now that are dentists are using these gases that basically makes the kids unconscious so that they can perform these procedures in the mouth. And but there isn't a lot of research on that, and so there's interest in those medications. I haven't seen anything about antibiotics causing any exposure to later susceptibility to drugs in adulthood. So Would you comment on dopaminergic pathways with regards to your research? And so, yes, so a lot of these drugs that I talked about, so methylphenidate, Ritalin, and cocaine and nicotine, the reason we see these interactions is because they all tend to work on the mesolimbic dopamine pathway. And we know that the mesolimbic dopamine pathway is what's most associated with sort of the rewarding or euphoric effects of drugs. But we've sort of moved beyond dopamine a little bit because we now understand that it's not just the problem of dopamine when people become addicted to drugs. It's actually these other areas that that these drugs tend to affect as well. And so one area, for example, is the prefrontal cortex. And a lot of what the prefrontal cortex does is it actually sends projections to dopaminergic areas, and it allows for regulation of dopamine from the prefrontal cortex. And so when the kids are younger, their prefrontal cortex is not as developed, and so oftentimes they might actually be more impulsive because they don't have that developed frontal cortex to regulate dopaminergic systems. And what we see with people who use drugs in time, and we image the less activity of the prefrontal cortex in those that have been using drugs for a long time. And so not having a good working frontal cortex, which is thought to be associated with things like decision making, impulse control, right? Not having good frontal cortex functioning is going to affect things like decision making and impulse control, and decreases in decision making and increases in impulsiveness are all associated with not being able to regulate the intake of drugs. And so we do see a lot of changes in prefrontal cortex feeding into things like the mesolimbic dopamine pathway, right, to regulate its activity.
Yes. Thank you very much for this presentation. You see, our discourse and dialogue is looking at spirituality. And here in Africa, spirituality is having a feeling of a sense of connection to something greater than oneself. Of course, this can involve religious beliefs, personal growth, and a quest for meaning. So when we are taking these drugs, we want to make sure that we get away from these ecological conditions that really affect us. And that's why we have this dialogue. And we are very excited that conditions that are associated with mental health, of course, where individuals realize their abilities and cope with normal stresses, work productivity, and contribute to their communities by engaging themselves either into those drugs that impairs their brain so as to perform effectively. So that's the reason that we're having what does Christianity or religion play in helping people cope with some of these overwhelming conditions that are psychological? And what is the role of the brain? Really, how does the brain work when these things are really happening? And that's the reason we have this kind of dialogue. And I'm looking forward to further collaborations and talk so that we can be able to come to a lasting resolution on this matter through research. And that's the whole idea that we have, because research has increasingly highlighted the positive impact of spirituality and mental health. And like in Kenya, if you become mad, you are taken to a place called Mathare. Mathare simply means madness. In Uganda, there is a place called Butabika. Butabika means things have really changed. The brain has really been impaired. You are not functioning normally. You can even go on the streets. So we want to try and see how we can demystify some of these conditions. We shall still continue with the dialogue, and therefore...
I just had a question to ask. Two questions. To Professor Eturo. The MRI scans from age of 5 to 18, were these a single subject study, or it was a longitudinal study of 5 to 18 years? Second question, ketamine is a general anesthetic, quite safe. The dosage which were used in the animal model compared to the dosage for general anesthesia and the dosage when ketamine is abused. Could you shed some light on those levels of dosages? Perhaps you were anesthetizing the rats as opposed to making them addicted to the drugs. Thank you.
You know, this is a great question. I'm going to address the second one because it's easier to address. So one thing to keep in mind is that we gave the ketamine when they were adolescents, right? Or we gave the ketamine pretty far away from when we actually tested them for cocaine. And so the effects of ketamine had worn off already. So it wouldn't have affected the response to cocaine because the ketamine had been out of their system for at least 20 days before we actually tested them. But and we also showed that there was no changes in locomotor activity. I don't know if you remember that when we compared the locomotor activity, there was no differences between those that were given ketamine and those that were given vehicle. And so we don't think we affected locomotor activity that way. But you're right that giving high doses of ketamine does tend to produce anesthesia. The doses that we used are sub-threshold to that. And in fact, we first validated the dosage that we use to make sure that it produces an antidepressant effect. So in separate studies, we tested the effects of ketamine on depressive-like behaviors in animal models, and the doses we chose and the regimen that we chose produces an antidepressant effect, right? And so it's much lower than what you would see with anesthesia. So for anesthesia, oftentimes they do 80 to 70 milligrams per kilogram of ketamine. We're using doses of 10 milligrams per kilogram and or 20 milligrams per kilogram in other studies. And so both of those doses are not going to produce changes in locomotor activity. But even so, right, it's the fact that we saw early exposure to ketamine leading to changes in cocaine. And importantly, it was specific to the adolescent period. When we gave ketamine in adults and then tested them as adults later, we didn't see changes in the effects of cocaine. So that addresses, I think, your second question. There's not likely any locomotor activities, but that's something to consider because you're right that giving too high of a dose would make the animals not able to move or anesthetized. And so in regards to the first question, I believe the study was a longitudinal study looking at changes in the activity of the prefrontal cortex, and it wasn't a single subject. It was those kinds of studies are often funded long-term by the government, and so where they're imaging the brains of people for quite some time. And I don't remember if it was from 5 to 18 or if they measured cohorts of people. I would have to look that up, but I can provide that reference for you.
Thank you very much.
Thank you very much. Thank you very much for this observation. Viewers and members, I would like to mention that this conference is being attended by a number of institutions, and these institutions include Kenya Methodist University, Kawa University, McLean Hospital, Mahari Medical College, Makerere University, Methodist University, the World Council for Psychotherapy in Africa, Meru University, Karatina University, Embu University, University of Kinshasa, Umar University, University Muhammadiyah in Malaysia, Kenyatta University, Lira University, Bustima University, Muhimbili University of Health Sciences and Allied Sciences in Tanzania, Mbarara University, Chambogo University, University of Yaoundé in Cameroon. So we are really privileged to have this discourse, and I look forward to Prof. Carol.
Yes, so thank you, Professor Zavala. So just for so everyone knows, it's actually 12:48 in the morning in California, and I know Dr. Zavala had a medical procedure today, so I really appreciate you doing this for us. Thank you again for joining.
No, thank you for the invitation, and it sounds like a very exciting conference. So I'm glad that you are having these discussions, and I wish you a good rest of your day.
Thank you very much. Back to Dr. Mchiri.
Thank
Oh,
you
James.
so much. It is not Dr. Mchiri, but we are together. Now, okay, thank you, Dr. Aturo. Thank you, Dr. Aturo. Thank you, participants. I do believe that we have learned a lot. At this juncture, we shall take our break, and then when we come back, we shall follow the program as indicated. We shall have a session, an opening session, where our chief guest is going to give a speech accompanied by our VC, who will be introduced by our DVC APF. So at this time, I would wish to welcome the chaplaincy so that they can say a short prayer before we break for a cup of tea. Thank you.
Thank you. Let us pray. Loving and gracious God, we want to thank you for who you are to us. And thank you again for gathering us today so that we can continue this discourse. We want to thank you for the tea and snacks that are prepared for us. May you sanctify them for our taking. In Jesus' name we pray. Amen.
Members, we have maximum 20 minutes so that we can be able to cover. Thank you. God bless. And remember to register. Kindly, during the break, remember to register. Go to the conference site. Select day 2, session 1. Select day 2, session 1, and provide your details. As we indicated yesterday, it is only those people who are able to register that will get the certificates. So far, we have 47 who have shown interest in certification. I don't know whether that's all that there is, because we have to close at around 11. So the names that we'll have received by 11, those are the names that we're going to forward. Thank you. See you in 20 minutes.
Okay. Okay.
They had wanted it to be directly on the TV.
Hey.
That was the intention.
So why don't you tell them?
Now they can't use the time is gone past the hour.
Hey.
When they had come here, the timing was direct.
Sorry. Sorry.
That's fine. So now they do the normal.
So I sent you
Now they will welcome.
Bro, yes, how are you, sir?
Thank you. You only
I
talk,
am
but
very happy to see you. Thank you. Okay.
we are glad to have you.
Thank you, sir.
There's something
Ekwiringira university yange.
introduce you.
Kenya Methodist University, taking education to a new realm. The convergence Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. the convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke. Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University, your future is here. Intake ongoing. Call us on 0724-256-162 or 0725-751-878 or log on www.kemu.ac.ke.
Welcome to Kemu. Your future is here.
Kenya Methodist University, taking education to a new realm. The convergence of excellent facilities, friendly learning environment for our scholars, the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economies now and in the future. The Kenya Methodist University.
The doctor is also teaching in college. You know, when you used to be together in Vienna. Do you remember it?
Yes, the librarian. Okay.
Cover.
Hey.
You told me what is the language you really want to hear.
You guys are on air.
You were there for, okay, you will come here. You know, it's inside you.
Professor Baguma, you're on air with your colleague.
Your foe, still your love far from me.
Hello.
So good to me. When I felt no worth, you paid it all for me.
Hello.
Hello.
Being so kind to me.
Hello, are we back? Tea break, is it over? Those of us who had gone for a tea break, please settle down. Those of us who had gone out for tea break, I can see you're back.
You have to make it short, don't make it too long.
And as we continue, we will of course have our guests coming in and continuing the program in a very short while. In the meantime, we want to do one other presentation, short presentation, then so that we can manage time, so that our time is managed. So again, thank you for being here. Thank you for those who are on the online. We appreciate your patience with us, and we believe that by the end of the day, this discourse will have produced very fruitful proceedings. I want to take this opportunity to welcome us to the second session. So this is going to be for us to hear, and I want to invite Dr. Penina Mwenda, who has a presentation, and I will let her tell us more about it in a short while. Dr. Mwenda, if you are set, we can go ahead so that we can take a bit of, we can manage time.
Thank you so much for this opportunity. I am Dr. Penina Mwenda. I come from Multimedia University of Kenya, and we are in collaboration with KEMU in Providence Soul Care International. It's a great honor to present today in this scholarly gathering. I have run a lot, and as I run a lot, also I have.
You may come to the booth if you wish, or you can do it here, whichever that you feel comfortable.
Okay.
Come there. Yeah, you can come here also. Wait, see, it's the same one that you sent me yesterday.
Yes.
The same one.
You can continue. Sorry for the mess up. We are consulting a bit.
Yeah, we're just getting the system set up, so just a minute or two, then we'll be learning.
Okay, we are settling down, and there's no cause of alarm. We shall be sharing our shrines, which will be too brief because of so much which we are doing today. So this is what I have sent. We are doing it with KEMU University, and I'll go through the content as shown below. Our topic of Sunday was psychotherapy and legal perspectives on mental health. I'm privileged to do it with a VC, Reverend Dr. Mary Kinoti, and mental health is an essential commodity of human well-being, as we all know. And in our society, we can attest that depression and anxiety is a societal burden. When you go into various areas, like I'm a practitioner, you'll find that people come with depression so much, and mental health has emerged as an interplay for those who have been seeing of genetics, psychological, social, and lifestyle factors, but I major on environmental exposures, especially extreme climate events. That is where my expertise is. In this case, we will assess an eclectic or blended psychotherapy model of interventions during climate emergencies. And briefly, I shall look at the role of practitioners in advocacy. What is there for us? Now, looking at the major therapies, because we are doing what we call mental health literacy, you find that psychotherapy, in simple terms, is a talk therapy, which was started by Sigmund Freud with his psychoanalytical theoretical model. And this is an early form of psychotherapy. Simply, psychotherapy deals with planning application techniques which are psychologically established and which have been applied in dealing with maladaptive feelings, values, attitudes, and behaviors. And what we do is to make sure that the patients are relieved from symptoms and problems. As I talked with one of us yesterday, we were talking about where does psychotherapy start? Where does counseling start? Where does guidance start as we help us in this life in mental health? And therapists are not only psychiatrists, they are not only psychologists, but we have as a continuum of mental health specialists, where I'm part of them. So I looked at the major, or we looked at the major modern psychotherapies, but there are still modern psychotherapies which I have not gone through, but you'll find that those will be captioned in the journal. So I've talked about psychoanalytic theory, which is psychodynamics, which looks at conscious mind early childhood experiences, and interpersonal relationships to explain the human behavior and treat the maladaptiveness which come with it. We have seen through so many presentations in behaviorism where they are using Pavlov's or other classical conditioning methods to help individuals and learn what maladaptive behaviors they have learned. We usually also use cognitive behavioral therapies where mental processes are looked at in detail because we look at a mind as a computer. And so if the mind is as a computer, it acquires, processes, stores, and utilizes information either maladaptively or if somebody is in his normal state. Besides that, there are motivational theories by Carl Rogers and Abraham Maslow, which are used, and the last one is biological perspective or neuroscience. And in the morning we talked about this, where people are looking at nervous system, genetics, brain and immune system to help the clients which are in our practice, who come to our practice. But you find that this is not usually used in Kenya majorly by the psychotherapists because we do not have labs like the ones we were seeing in the morning, where we have the MRI and PET scans. Now, in simple terms, when we use we have summarized, we usually look at the conscious mind, either superficially or in deep details, or we give a psychoeducation. Sorry for that.
Charles, please mute. Charles Tenanga, please mute. Charles.
Oh, sorry, I didn't know.
Please mute. Okay, thank you.
Oh, sorry. Also, we use individual psychotherapy, group therapies, and family therapies. And also, we use it according to if we are supporting or we are re-educating, or there is what we call reconstruction therapy. Going forward, you find that in the research I did on mental health and climate change, I saw that there is psychotherapy is gaining traction in middle and low-income countries. That is why we have such kind of dialogues continuing. And comparing to the other developed countries, we find that we are lagging behind a bit because the availability and accessibility is quite low, because our people have not understood what is this mental health we are talking about. Now, the domains of mental health, as we have seen through, it consists of all that spectrum, and the practitioners in biopsychosocial operate in silos in our country. We have not been able to use a manager to manage all of us so that we can offer the best practice in our practices where we do our counseling, or we offer psychotherapy, or we do our clinical psychology. You find that we operate in silos, and we are using unstandardized and unclear interventions. Besides that, in the research I did, I have found that there is significant policy shifts towards evidence-based continuum of interventions and how they overlap, and how we support the patient. Now, in my methodology, I
we have used systematic data review and meta-analysis of the present, but I've also incorporated my 7 years research on synthesis of psychotherapy policies, roles, gaps, where I looked at, there was also a survey of 288 focused group discussions, and I think around protocols, because if you have to analyze policy, then you have to go and talk with who is who in the government. That is what we call think around protocols. The expertise interviews were carried for almost 2 years, and we gained insight on the current proposed and existing policies and frameworks on mental health intervention strategies. And an effective monitoring responsive evaluation was carried out according to my journals and my thesis, which is in the repository of Nairobi, if you wish to see it in detail. The results. This is super sensitive. The legal frameworks, which are very much outlined in my there's a problem with this. It's very sensitive to the touch. Sorry for that. Okay. That there are existing, sorry, even if I am not touching, it's moving. There is some legal framework which act as a basis of helping us make sure that we are implementing mental health in a particular way, and that was elucidated yesterday through the discussions which we have been having. Oh, what? Now, number one, we have comprehensive mental health action plan of 2013-2020. This is Kenya Now perspective. We also have African Union Agenda 2063. The Constitution of Kenya talks about universal health care, and also Kenya Vision 20. All these are in our websites. We can be able to check them so that they help us implement mental health, not only in Kenya, other countries can be able to borrow a riff. I didn't put like APA, that is American Psychological Association, the Code of Ethics, it is there. We also have what we call Kenya Counselors and Psychologists Bill 2014, which is very detailed on how we are able to implement mental health. But in regard to my study, I've also looked at the details of disaster management bill. Act, it has become an act, which helps us realize that the major custodian of implementing the disaster related with mental health in Kenya is the administration of, I can call them the county government and the national government. It is supposed to do it in unison. We also looked at interactive styles of psychotherapy, and we saw that if you have to pick a psychotherapy and help go to detail on how to use each one of them, then you pick out a particular psychotherapy. And for example, what we call behavioral psychotherapy. There is user-friendly, use of systematic desensitization. For example, if people are involved in hazard or a disaster, then we can use systematic desensitization or rerunning what they have already seen so that the trauma goes. I have also said that the therapy's usage depends on severity of symptoms and treatment planned and developed by coordinating therapists. I would like to have this one go further in my research. That is why I've contacted Wellcome Trust, so that we can see how this continuum of all these eclectic therapies can be used, so that we help this person who is undergoing traumatic experiences of friend or traumatic experiences of drought or what we call hazards. Now, this is in my research, and it is shown that there is a lot of gaps which need to be dealt with. I was doing research in Isiolo, and you can see how deficient we are. We only have one referral hospital giving treatment and rehabilitation. That is Isiolo Referral Hospital. There is no psychoeducation being done. There is no social support or rehabilitation activities continuing. And besides, advocacy is very low. There was no psychiatrist, no psychologist, or no doctors. We only had what we called nurse psychiatrists. That is one thing which we noted. Besides, through literature review, there are so many gaps which I won't repeat. They have been elucidated again and again, but there is early prevention before or at the onset of mental health disorders need to be improved so that we have improved outcomes. And climate change still is devastating. It is having devastating effect. And there's clear link between climate-related events. For example, the eco-anxiety. I was wondering, people who are seeing the Rift Valley, there is the extension, there is those valleys which are coming because of the Rift Valley, which is becoming a very, I can call it, the cracks are being seen and they are going through their homes. The anxiety, the depression, or the other uncertainties which are bringing forth the mental health, and therefore prioritizing mental health care and during disasters is very critical, as we elucidated. Let me go to very fast because I was given very few minutes. I have heard people asking about what we are calling indications and counter. What do you look at? What do you look at to know someone has mental illness? Psychosomatic illnesses. We have seen alcoholism becoming a major problem in our society. Drug addiction, sexual deviation. So those are indications. But when we have to use psychotherapy, we don't go into detail. We only do it in a level where we are supposed to, because we should know that in the continuum of helping, we cannot be able as psychotherapists to do severe psychotic illness. And another day, somebody with psychotic illness, and I saw how she's getting a problem with drugs which she was using, and she was becoming she had suicidal ideations, and I thought this is not my domain. Regardless, therefore I need to do what we call referral to a psychiatrist. So this is to say, any intervention considered inappropriate or inadvisable is based on unique factors of our situation, and therefore we should know when something is out of our control so that we can give to the next person who is in the lineup of helping. So in simple terms, in continuum of helping, we look at indications and contra-indications. As I go to discussion, we have seen the legal frameworks which have not gone through in details because of what has been done. And there are policies, plans, and strategies which have been put forth for us to be able to use. This is because there is significant global unmet needs for mental health in prevention and treatment interventions. But that is undermined by mental health financial gap. In low and middle income countries, you find that 80% of people are not diagnosed and they are not treated. And 7% of global mental health research funding is directed to prevention. Counseling, guidance, counseling and psychotherapy are supposed to deal with prevention. We are not supposed to go in deep management and care. And so prevention is number one, because if we don't prevent mental health, dealing with mental health, mental illness or mental disorders is very expensive. It is important we nip the bud and we deal with mental health problem before it becomes mental illness or mental disorder. That is the first finding we have picked. We have also found that there are practical solutions at institution and community level. There is clear evidence that advocacy is core to improvement of mental health. But what are we doing? Like now we are amplifying voices through campaigns and the use of lived experiences for more feasible, efficient programs and projects. The mental health advocacy impairment is under-resourced and mostly focus is usually in high-income countries. I have been in the field, but you find that those countries which are presented, you found out they are in the wraps. And therefore, these gaps have to be addressed. Information, reading networks of mental health professional advocates and civil society organizations. That's why I have one referred to as Providence OK International. This will bring diverse voices of expertise as we are here now, and lived experiences from low and middle income countries to the global stage, because now we are on the global stage, so that we are able to make better decisions and activate change which has global priorities and cascaded to regional and local governments. As we are here now, I know the Regional and local government are represented, and therefore we need a strategy which will help the advocates use these legal frameworks to help our population. This was a developed framework, including all the county government and MDAs, ministries, agencies, and all who are required to be there. I hope you are able to see it, because it includes Ministry of Environment, Climate Change, and Forestry. It also involves the Ministry of Health. It also involves Ministry of Health, including now the major player who are the special programs. Special programs are supposed to coordinate all the ministries so that they are able to help the individual from better health resilient community. That was a framework which we developed. Recommendation number 1, impact of climate change, disaster risk on mental health is very important so that we can be able to improve related frameworks for delivery of mental health services. GIS mapping, which I did in the area of Isiolo, to monitor climate hazards and vulnerabilities so that we advise policy actions. The nexus of climate change and mental health requires diagnostic procedures, and we quantify the prevalence of mental health, which was definitely not there when we did the research. Stabilization centers at the community level is very important, and this has been emphasized again and again. We need the mainstreaming and involving the academia, CSOs in climate agenda, because that is according to the SDGs and Paris Agreement. With that, I say thank you so much. God bless you.
Thank you very much, Dr. Penina. Let's applaud Dr. Penina, please. Thank you for continuing this discussion. Do we have any quick question for Dr. Penina? Anybody who has a question, comment? Yeah, please mute if you're not asking a question. Somebody put up their hand. You can use those online. I want to give you the chance first. We do not want you to be spectators. We want you to participate. Online, anybody with a question? I'm looking to see whether there is any hand that is that's up. Okay, those present here, as the online team decides. Any question, any comment on the presentation that I just ended?
A comment.
Yeah, please go ahead. Introduce, tell us who you are, then proceed.
Sorry, my name is Sylvian Tamunja, and I'm a student here at Kenya Methodist University. So I'd love to say thank you for the great presentation, and it strikes a nerve because of something I was thinking about, that yes, we have the environmental crisis every day in our countries and in the globe, and I think it's a very important aspect to venture into, to just think on how to support people during the crisis. And maybe just a comment was, we could also think of how best to support our communities even before crisis. How can we have the crisis preparedness in terms of mental health? We've been having a lot of projects on preparing for pandemic preparedness. So I think that an important aspect is to include mental health in terms of climate, not climate, but rather pandemic preparedness. So thank you so much for that. And I look forward to seeing how best we can even inculcate that and involve students. Thank you.
Thank you very much. Any other comment or question? Yes, Wajiro, do you want to go ahead and ask your question?
Thank you, Chair. My question to the good doctor is, from her study, what was the key thing? Was it a deficit of expertise or a deficit of psychotherapeutic interventions? Thank you.
The good doctor is not answering.
Okay. Oh, I thought there was someone else asking a question, so that I answered them all. But according to the study, the deficit was on the psychotherapists. I said that there was only two in our whole county, 2 nurse psychiatrists, 2. And even to today, they have not handed, and therefore it's a deficit of psychotherapists. And you can hear there was no psychotherapist, by the way.
Please mute, and we are not hearing the mic, please, use the mic. Please mute if you are not the one responding. There are quite a number of people who are muted. Bwana Yambo, please mute. Damaris, please mute. Please mute your mics.
Thank you. So I was saying that the deficit is there are no psychotherapists. But besides that, you find that I said that even if we have psychotherapists, you find that there are people who are saying they're using modern way of psychotherapy. They call themselves positive psychologists. That is humanistic psychology. Okay? There are others who say, I will use cognitive behavioral therapy. Okay, so we are working in zeros. We have not been able to integrate all the psychotherapists so that we work as one. Because if we are assisting an individual, we should be able to assist this individual in, because we look at 3 areas: the feelings, the behavior, and the action. So all that should be inclusive in one continuum. And so the deficit in several areas, but that is why we are proposing to see whether we can do more research on integrative model so that we are able to have even the tools simplified, because mostly we use tools from the Western world. We have not developed our own tools to be able to help our people or our client. Thank you.
Thank you. Any other question? All right. If I'm checking to see whether there's anybody who's putting their hand up. Yes, Dr. Mwamisi, please proceed.
Thank you. Why don't we, Daktari, why don't we have tools? You know, why should we always use tools that are made or developed or designed elsewhere or outside? Can't we have some, or don't we have some capacity in having our own tools? Maybe our own tools would be more appropriate. Thank you.
Thank you, Dr. Mwamisi. As a practitioner, I have been able to develop some, But when we go to different centers where psychotherapists are giving up their practice, you find that we have no one common. I think because we have Kenya Counselors and Psychologists Association, that is a center where we can be able to get our knowledge so that we are able to use 1-2 as a country. But that is work on progress. Thank you.
Thank you. Thank you, Dr. Penina, for your presentation. We are happy that you are able. Let's applaud Dr. Penina one more time. Thank you very much. So we will proceed to the next presentation.
The next. So who are they?
This one, call for Elizabeth. This is the latest, eh?
Yes.
Dr. Elizabeth Geshimo, are you available?
Yes, I am.
I'll also ask you another one thing, Dr. Geshimo, before you present. If you go to your website, to your line, if you go to your computer, where you have the list of attendance, can you see the list of attendance?
List of attendance.
Yeah, the names where you have the people who are attending, participants. You can
yes.
You can see that icon. Click on it.
The green icon for share.
No, not for sharing. The participants. I want you to go to the list of the participants. Have you got?
Yes, for participants. Yes.
You're on the list of the participants.
Yes.
Now, under the list of participants, you will see that you are listed as the host. And that is where we have a challenge of muting people. So what you need to do is go to where Mushiri is. You see the name Mushiri? You will see some three buttons somewhere. Can you click on those 3 buttons? If you point at Mushiri.
Yes, Dr. John Mushiri.
Yes, when you point to that Dr. Mushiri, do you see some 3 buttons?
Yes.
Now,
so I make him host?
Make him host. That would be very kind.
All right.
So that we are able to mute people when they are whatever. Thank you very much, Dr. Geshimo. And this is your chance now to present.
All right, thank you. So let me just pass from my screen. So I hope my screen is legible to everybody.
Yes, we can see it. We can see your slides.
Okay, great. So my name is Dr. Elizabeth Geshimo. I'm the school counselor, rather the university counselor at Riara University, and my background is in clinical psychology. So my presentation is on understanding the intersection of spirituality and mental health. And the work we did, Dr. Stephen Asatsa is the head of department of psychology at Catholic University. So this will generally be what I will be going into. Basically, I'll start with a brief background, then go on to the objectives of what the work was on. Just highlight briefly on what methodology we used, what our findings were. Then a conclusion, and there we also discuss a little bit on the theoretical framework that came up as a result of our findings, and finally recommendation. So when we think about mental health and spirituality, basically, what we see is that in the West, what was dominant at some point is that the church was what was responsible for addressing issues as far as mental health is concerned. And the paradigm at the time was that it's when you have a mental illness, you're demon possessed, and it followed then the modality for treatment was exorcism. But now with Freud analytic framework, that we see a shift from now looking at mental illness or mental health issues from a spiritual perspective, and now adapting a psychological perspective. And now again we see the aspect of spirituality completely added, and now the paradigm now focusing on a psychological framework. But when we come to Africa, one of the dominant theologians we have, Professor Mbiti, said that the African is notoriously religious, and it follows that most of how we see things is from a spiritual perspective. And even with the introduction of Christianity, most of it taking over the paradigms of African spirituality, we still see, especially where mental health is still concerned, the dominant paradigm is spirituality. So how the African thinks about mental illness, the mind, it first starts from a spiritual, and rarely have we taken up any other paradigms, despite there being even a shift as far as even our understanding of how the body works and so on is concerned. And therefore, these were the three objectives that guided how we went about doing this work. One was to explore what are the markers of mental health. Then the other thing was to find out what are the levels of spirituality. And finally, to see how does spirituality impact on mental health. And the methodology that we utilized was fairly systematic literature review, and 20 articles were reviewed. And most of the ones that we went through, most of them had utilized a quantitative approach to research, but we had a few that had interviews. And from the findings, these were the things that were emerging on the markers of mental health. These were the key markers, so that are the key things that emerged as far as markers of mental health is concerned. One was the ability to be present. And what does that mean? That is someone being in touch in terms of time, place, and person. Then the other one was resilience, how fast does one bounce back from adversity. And the third one was the ability to perform functions, and this was from both physiological as well as social point of view. So then on the aspect of levels of spirituality, so like I mentioned, majority of the works we reviewed used quantitative, and they employed this specific spirituality assessment scale. And therefore, these were the four areas that emerged as being key in terms of measuring levels of spirituality. So that is purpose and meaning in life. The second one is inner resources. The third one was unifying interconnectedness, and the fourth one transcendence. So depending on how one scored in either one of these, then that would determine how whether one is highly spiritual or one's level of spirituality is low. Now, in regard to the third objective, which was how spirituality impacts on mental health. So what came out is that when one scores high in spirituality, you will find an intersect of both positivity and negativity as far as mental health is concerned. On the positive aspect, you find that people who are highly spiritual tend to be very resilient as far as when they're going through challenges and difficulties. they have hope. Therefore, it means their way of recovering from challenges is quite fast. Another positive thing is that they tend, because they're living or looking at something that is higher than themselves. When it comes to actually being helpful, contributing positive to society, they tend to fare quite well. But then now on the negative side, what we saw is that people, again, who tend to be highly spiritual to some extent, again, are one susceptible to suggestibility and can be victims of cults. I think the most recent one we have seen in the country is the issues around the Shakahola and the tragedy that came out of that. And then the other thing, as far as the negative aspect is concerned, is again that tendency to what is said or called spiritually bypass, meaning just looking at everything through the eyes of spirituality and refusing to engage a bit with reality. So that is one other aspect of negativity for those who may be scored quite highly in spirituality. So then the other thing that came out is that people, again, who score very highly in spirituality tend to cope better in the face of emotional turbulence, as well as also, like I think I mentioned earlier on, tend to fare quite well as far as even outlook. If they're going through challenges, it could be a medical issue, it could be maybe even they are dealing with a disaster of one form or the other. In terms of how they cope, they seem to fare much better. And therefore, then, from that, what is our conclusion? One, we see or we come to the conclusion that, as we have seen, when a paradigm takes precedence, like, for example, in the West, where they tend to discarded the spiritual and then now paid focus on one, and now we are seeing there are a lot of things that are emerging that demand of us to not look at an issue from one perspective, and especially where mental health is concerned, there is an interconnectedness of different facets. That's the biological, the psychological, the social, and the spiritual. And therefore, now that we have an understanding that all these aspects are important, none is better than the other one. There is a need then to have an approach whereby we are actually focusing on how do we get information on how to integrate, and specifically the spirituality, because I feel there's been a lot of focus on this other aspect, but on the spirituality now is when we are to coming up to show us where is the place of spirituality. So there's more, again, that needs to go into publishing, and also especially from us here in Africa, we need to put out more information on how spirituality are relevant when as we understand and conceptualize mental health. And then also we need to come up with ways of assessing spirituality. Even as we do mental assessment, how do we come up with for that? And that then it also informs the way we go about doing interventions. And therefore, in the part of our recommendation is that there, of course, needs to be a multidisciplinary approach of addressing mental health. But beyond just that, in our trainings, we maybe just focus with what our specialties are. For example, as a psychologist, maybe as a clinical psychologist, there was a bit of biological information. You're taught how the brain works and so on and so forth. But then you find that with these other specialties, for example, if someone goes to train as a spiritualist, are they given information on biology? Are they given information on, say, psychology? The medics, yes, there's a lot of training on the biological aspect, but are they given information on psychology, on spirituality? So even as we're talking about a multidisciplinary approach, how do our curriculums look like? Do we incorporate facets, all these other facets of what goes to make who we are, so that when you're talking about reaching out and working as a team and coordinating, so I know that if I'm working with this person, I need to call upon a spiritual guide to come in. I need to call upon a medic, because I have understanding what their needs are and what it is, or have information to understand what they can be able to see that I can miss. And importantly, again, even as we do that, then know what are our limits to competence. Where does my competency end and another person's competency come in? So that way, then we are able to coordinate and give the best treatment to those who come to us for help. So with that, thank you. That's the end of my presentation. I welcome questions and comments. Thank you.
Thank you very much, Dr. Kishimo. Let's applaud Dr. Kishimo together. Appreciate her presentation. She has made effort to bring it to us. We, of course, like you said, she want to invite a question. Professor Baguma, your hand has been up. I was just not sure whether to ask. Now you have a chance. You can ask Dr. Kishimo a question, but you can also bring your comment. And of course, I want to invite others now to also raise questions. Any questions, members online? Dr. Harris, who else want to raise a question? Yeah. Reverend Karanja, Dr. Some. Let's have those ones. Online, anybody who wants to ask questions, I want to see your hands up as we listen to these ones, as we record. And take note, Dr. Kishimo, you'll respond. We'll start with Dr. Harris.
Thank you very much. I want to really thank Dr. Kishimo for that wonderful presentation that has brought again on board issues that we were grappling with last evening as we closed the session. And I am particularly impressed by your conclusion that this issue needs to be addressed from a perspective of multidisciplinary. And you recommend that training, I think training needs to be relooked at. As I listened, I was just wondering, because personally I have the background of theology all through, and looking at our community, these people who have mental issues, I think the first person they encounter is the pastor and the teachers. So these people that encounter these challenges, most of the times, and I think it is true, that they are not trained on that. And so even as we want to work together, to collaborate and address this issue together, is it that we are now recommending, Daktari, that maybe every person who is involved need to do basic training on the same? Because seriously, looking at the religious part of it, we have a lot of damage happening around because of not, I think, looking at the limits that each one of us need to go. So I couldn't address a mental health from a spiritual background, and I started exercising because it happened in the Bible and it happens even today. So what is the limit? What is the recommendation? How can we work together so that actually we do not make some of the mistakes that we are making, sometimes not because we want, but because we have no knowledge and probably exposure. Thank you.
Thank you, Reverend Karanja. Please take note of the questions, Dr. Kishimo.
Thank you. Sorry, thank you so much. I think the bishop has mentioned some of part of what I really wanted to say, because I was trying to think aloud about this issue of training and the limits of especially pastors, because I don't know whether there is any policy on anywhere about how you become one and how you go about practicing out there and how you work with others. It is something that is open. Now, how can you even begin to think of training some of them? Because we know in African Tradition Society there was a kind of a worldview where there was that equilibrium and issues that had to do with if you interfere, there are lectures and trying to ensure that there is harmony on everything. Now we are talking about spirituality and syncretism, kind of hybrid borrowed from all over, and people doing what they think or what they believe is right, and even the kind of advice they give to the people going by what they are going through. So there's no uniformity. Now, how do we streamline this kind of training, this kind of information out there, especially in the area of spirituality? How do we also ensure that whatever we call the pastors or the reverends are accountable to one another? They are able to really take care of those extremes so that we don't have the repeat of Shakahola. People who probably we think probably mentally they were not okay and did a lot of damage because there is no control. You can say something, and the moment you say something, somebody on the other side believes it and acts on it in a very weird way. So that was my concern. Thank you.
Thank you, Dr. Some. And then I have one other person online, Dr. Kenanga.
Thank you very much. Mine is observation and comment related to the presentation that was made and perhaps many other presentations in this conference. We are using the word community, but when it comes to mental health, it may not be appropriate. I would think that the most appropriate terminology would be settings. And in my experience, as a public health practitioner, there are about 10 settings that we are all exposed. The primary setting everyone is exposed is home, school, and a workplace. At any one time on any day, you are in these primary settings. Then we have tertiary settings, which are not compulsory, but they are part of your life. The first of these, therefore, is a worship setting, where you choose to go and express your spirituality. The second is entertainment, where you go to enjoy, to feel good. The third is a travel setting. Many of us, when they travel, they are exposed to new things, new food, new cultures, new friends, new people. And if you are not steady, you can be influenced. The fourth are temporary setting, like when you make a visit, when you tour a place, or you participate in sports. These are short period settings. You can pick something out of it very quickly. And then tertiary settings are settings that are beyond your control. There are three. The first are confinements. You can be confined to a hospital, not because you like it. You can be confined to a prison, not because you like it. And in those confinement periods, you are likely to be stressed, you're likely to pick out issues that you really didn't want. The second of the three are the displacement settings. If people are internally displaced, either because of a disaster or fighting or war, like in Kenya when we had the post-election violence in 2007, 2008, I had one of my PhD students who looked at the effects of that violence 10 years later. People were still having feelings of helplessness. They see the person who killed their father, and the person has never been arrested, and they are walking around. So the final setting is special settings. If you are in the military, if you are in the police, and I will also say there are other settings that are undefined. So this, to me, 10 settings, mental health need to be addressed at home, at workplace, in education. Those are primary. For the tertiary, secondary, worship places, entertainment places, traveling, the temporary visits we make or tours or sports, and the third settings, those who are in confinement, prison or in hospital, they also need to be reached. Those who are displaced, ITBs, internally displaced persons or refugees. And finally, people who are in special settings like the police, the military, and other types of special service. So when we use the terminology community, where I look at it from a mental health point of view and psychosocial, actually it is the settings that affect us most. They are people who are affected to a hostile, dysfunctional families, and they have never recovered that even in their education, in their workplace, even when they go to church, they may not have opened up. I'm very sure you all know great preachers like Miles Myers, the lady. You know what happened to her when she was young. So let's dialogue and say, what would be the best approach? Do we talk about community or we talk of settings when we are talking about mental health? Thank you.
Thank you very much, Dr. Some. I will ask for one other question from the online, then we can have Dr. Geshimo respond briefly. Charles, you had a hand up. Charles, did you hear me? You had a hand up. All right, Dr. Geshimo, please proceed and respond.
All right, so thank you very much for the questions and the comments. Indeed, just maybe start backwards from Professor Some's remarks. Even when we are doing our own kind of assessments, what we are usually actually narrowing down to is the environment. And those facets that you have pointed out and in the name of settings, I feel it's just more or less talking or going deeper into narrowing it down to what is the space that goes to actually impact or affect people. And I think when we are talking about mental health, of course, community, I think when we talk of community, we are usually, yes, referencing what is the specific or what is the nearest access to an individual that we know can give them support. But I appreciate actually the remarks that you have made in trying to help us, to and be a bit more specific. What are we referencing? Who are we talking about? And I think the term community might be a bit broad, but how you have broken it down makes it a bit more specific and helps us to actually conceptualize what we want to do in a much more meaningful way. So I appreciate that. As for Dr. Alice, on your question, and as well, I think more or less what you asked, and the next question on how spiritual leaders can come in and avoid making the mistakes. Do not want a repeat of Shakahola. And I think if we were to even maybe break down the Shakahola issue, I think it's beyond even even this specific presentation, because I think when we study what makes people susceptible to being indoctrinated and so on and so forth, I think we would also have to again go back to education, and again we start from developmentally. How have these minds been shaped? For example, because again, if we are able to go deeper into issues of cults and so on and so forth, you will find that even people who we think should be better, people who we think because they have a higher education, still end up falling into these categories. But then now to bring it back to how we make sure that we don't go or we don't go to a territory that is beyond us. And like you rightly, one of you pointed out, the people who have access, majority of the population, is the teachers, is the pastors. Most people, when they're going through challenge, their homes be eating them. The first setup, I think, to just go from Professor Somi, actually approach is the pastor or the schools, the teacher, the principal, and so on. And for the most part, of course, I think again, like one person pointed out, not majority of them are even trained theologically. And even for those of us who are trained theologically, the focus is more on spiritual training than anything else. And that's part of why I think one of the recommendations is, even as we think about curriculums that go into training these people, do we want to introduce, other concepts, other elements that go to helping people, not just narrowing it down to what we are going to teach people. But then for those of us who are ready, so of course, one of the things is we do not want to belabor the importance of spirituality. It has its place, but how we can ensure that at least we remain within the bounds of what we know. And I think attending a conference like this is important because we get equipped with information and knowledge to understand there's more than one way to look at a human being. Yes, there is a spiritual angle, but then sometimes when we listen and we work with people, we can see there's that which often have the of other specialists, and therefore I think one of the ways actually to avoid to cause harm or to do that which is beyond our capacity, I feel is in terms of, again, it goes just back to equipping ourselves with information. And my experience has been a lot of, especially spiritual leaders and even the field of psychology, you find a lot of people who actually come to on the training on higher levels, master's level, PhD levels. You find these people even who have backgrounds. And why is that? It's because of the...
You have basically concluded. You can make your last statement so that we can then salute you.
All right, so thank you. So I think maybe my final remarks is this, and I think this is a conversation that is continue, and I feel there's more that we can come up with in terms of solution. Nobody is a monopoly of knowledge, and nobody is a monopoly on a report. But I think when we all come together, we can come up with a solution way forward. Thank you.
Thank you very much. That's a proud Dr. Geshimo for that presentation.
We wait to be online.
Recording in progress.
Thank you. We are back online. The next session is a very brief session of officially inviting our VC who will make a few comments and invite the chair of the University Council. Ladies and gentlemen, it's my privilege to invite the Acting Vice Chancellor to make a few remarks and invite the chair of the University Council. Welcome.
Ladies and gentlemen, I am honored this afternoon to once again welcome you for this conference that has been going on the last 2 days. It is a conversation by very brilliant minds on mental health, and specifically integrating psychiatry, psychotherapeutic, spiritual approaches, and legal perspectives for enhanced mental health. Here at Kenya Methodist University, we have the pleasure of hosting this second international conference on mental health. We recognize the importance of integrating approaches in mental health, and particularly in the era where mental health challenges are becoming increasingly prevalent in our society. And therefore, this international dialogue is a most needed conversation, and it underscores the necessity of collaborations across comprehensive mental well-being. We recognize the role of psychiatry and psychotherapy. We acknowledge the approaches, particularly the psychiatric approaches, that emphasize on the importance of accurate diagnosis and medical treatment, and psychotherapeutic approaches that highlight on the value of therapeutic relationships and interventions. As a Christian university and having the privilege of hosting this conference, we stand on the pillar of the spiritual approaches as we integrate all, acknowledging that spirituality plays a pivotal role in people's lives and can be a powerful resource for coping with mental health issues, and therefore integrating spirituality and mental health treatment converges together towards a holistic approach to addressing the issues of mental health, particularly in spiritual care, in practice, and in research. We are cognizant of the role that is played by legal fraternity, and particularly bringing out clear legal perspectives on mental health that are backed by legal frameworks, such as rights for the patients, and advocacy and policy development. We want to recognize the need for this international dialogue and collaboration as universities and as key players in the field of mental health. And particularly, we are bringing to this platform a round-table conversation on sharing of knowledge, experiences, and best practices across borders on global perspectives and collaborative research fields. Kenya Methodist University is dedicated to academic excellence and community service, and is deeply entrenched in the field of mental health and committed to advancing mental health through education, research, and practical interventions. Specifically, we are highlighting 3 key areas where we are deeply entrenched. One is in education programs, research initiatives, and community engagements. And this comes in handy. This international conference comes in handy as we expand our partnerships and collaborations, because we recognize the importance of building strong partnerships to enhance our impact on mental health. And to this end, we are very excited that we have universities such as Kabale University on board. We don't take for granted this coming on board by Kabale, because this visit aims to explore new opportunities for collaborations and partnerships, and further strengthening our commitment to mental health approaches. Professor Bantu. The purpose of this particular collaboration with Kabale, one is to establish and enhance collaborative initiatives in mental health research, education, and community outreach. Our expected outcomes are joint research projects, exchange programs, and shared resources that will benefit both institutions and all other institutions that will come on board, and the broader community. We recognize the participation and the commitment of Professor Carlo from Harvard, and we are so grateful. And your commitment and your presence here means everything to us in terms of your commitment to walk the journey with us. As I conclude, let me say that this conference represents a significant step forward in our collaborative efforts to enhance mental health care through integrated interdisciplinary approaches. This will be achieved by combining psychiatry, psychotherapy, spiritual care, legal perspectives, and we can develop more effective, compassionate, and holistic mental health strategies. And with these few remarks, allow me now to recognize and introduce the chairman, the chairperson of the Kenya Methodist University Council, Reverend Dr. Catherine Mutua, who is a professional in this particular field, in this particular discipline of mental health, and who has demonstrated a lot of commitment and innovation in initiating the formation, the implementation, and the running of a church-based mental health rehabilitation and treatment center, the Methodist Treatment and Rehabilitation Center. So, ladies and gentlemen, allow me to welcome her to give us her keynote remarks. Let's get ready to give an applause, a factorial 5. Thank you. 1 to go. We can also give it online.
Thank you very much. Our acting VC, Dr. Mary Kinoti, distinguished guests like Professor Carol from Harvard. Thank you so much for coming all the way because you strongly believe in this initiative. We feel honored as a university. And also the esteemed organizers like my professor, Professor Bantu. He was actually my professor when I was here doing undergraduate studies. And so I'm so honored to be seated here today with you. And respected colleagues, and when I say respected colleagues, I honestly respect you because I have sat in your classes. Most of you have been my professors. You have tutored me from undergraduate to the level I am today. And so I highly respect you. Ladies and gentlemen, I thank God for this wonderful opportunity that we have. Like our VC have said, I am a mental health champion. I started a rehabilitation center when I was working as a synod bishop for the Methodist Church in Kenya, Kaaga Synod, in 2018, because I realized the gap that was actually in the mental health and how to include spirituality and science. I am a strong advocate of both, not either or, but I strongly believe in spirituality and also science, whereby we bring other disciplinarians like psychiatry doctors, physicians, psychologists, and of course, the pastors. So in the institution where I'm working, I play the role of a psychologist and also a spiritual oversight authority. I am the only pastor there. So it is my profound honor and privilege to address you today as we gather for this significant conference on integrating spirituality, psychiatry, and mental health and psychotherapy, which is actually hosted by the Kenya Methodist University. This event, scheduled for the 21st and 22nd of May 2021, marks May 2024, marks a crucial milestone in our collective efforts to enhance mental health care through a holistic approach that incorporates spiritual and psychiatric dimensions. First and foremost, I wish to extend my heartfelt gratitude to the organizers of this conference. Your dedication and meticulous planning have brought us together to explore and advance this vital interdisciplinary dialogue. I also want to acknowledge our esteemed partners, like I have said before, and that have been mentioned earlier by the previous speakers, whose collaborations and support have been instrumental in making this event a reality. Your contributions are invaluable, and we are deeply appreciative. In recent years, the importance of addressing mental health issues comprehensively has become increasingly evident. We recognize that mental health is not merely the absence of mental illness, but a state of overall well-being that encompasses emotional, psychological, and social dimensions. Integrating spirituality in psychiatric care and psychotherapy is an innovative and necessary approach that acknowledges the full spectrum of human experience. Allow me to share a philosophical quote that underscores the essence of our conference. That is, the unexamined life is not worthy living, according to Socrates. This profound statement by Socrates reminds us of the importance of self-awareness and introspection in achieving true well-being. It encourages us to look beyond the surface and to seek deeper understanding and meaning in our lives. Furthermore, I would like to share a religious quote that aligns with our theme. Peace I leave with you. My peace I give to you. Not as the world gives, do I give to you. Let not your hearts be troubled, neither let them be afraid. According to John 14, verse 27. These words from the Gospel of John speak to the inner peace and comfort that spirituality can provide, which is an essential component of mental health. As we embark on this day 2 journey of learning, sharing, and collaboration, let us remain committed to our shared goal of improving mental health care. Let us engage in meaningful discussions, share our insights, and develop innovative solutions that will benefit individuals and communities alike. I am confident that this conference will not only deepen our understanding of the integration of spirituality, psychiatry, and psychotherapy, but also inspire new approaches and partnerships that will enhance mental health. With great enthusiasm and optimism for the impactful work ahead, I hereby declare the conference on integrating spirituality, psychiatry, and mental health and psychotherapy officially open. Thank you, and may we have a productive and enlightening conference. Thank you so much. Asante.
Thank you very much, Dr. Catherine, for that insightful statement of opening this conference. And we take it not for granted that you found time to come with us. And this is an expression of your commitment to the same field, which you have testified that even as in your ministry, you championed that specific element that we needed integration on spirituality and mental health, and we take not for granted that commitment. Thank you very much. Do we have any person who want to respond? It's an rare opportunity to have our chair of the University Council. She is a researcher herself, but it's also a chance to raise a question regarding this field. I want to give an opportunity for a quick response, or even to our acting Vice Chancellor. I'm looking to see a hand, or even in here or online. I want to give you a chance. This is the highest commitment as a university. When you see our chair of council being here, it's a sign of the highest commitment in the Kenya Methodist University. Yes, we want to give you a chance. And then Dr. Kinanga, your hand is also up. So good, Dr. Kinanga, then the person here. Let's give the online people a chance so that they don't feel like we are on ourselves.
Greetings once again. My name is Sylventa Mwinja, and I'm a student here at Kenya Methodist University. It's a great privilege and honor to see the commitment of the university. Thank you so much, Dr. Ri. And I'd put this as a question, and just to all of us in the room to advise me on how best we can take this up as a university. And so let me put it as this. As students, we really go through a lot of mental health issues. I think the students here can agree with me that most of us, I believe, not that I've done the research, but I believe that at least 5 over 10 are having either anxiety, stress, or depression. That one from even personal experience, I'd say that. And so I was thinking of something about social responsibility to bring students together. That one gives you a sense of you're living for something, because it reaches a point where students think that there's no hope, you know, when everything doesn't make sense financially, maybe academically. So a point of bringing social responsibility, like maybe through community outreaches for students, but then in the long run, it's aimed at promoting mental health, where you bring them students together. Because right now, if you give us a mental health talk, very few students will come up. Like when you say we are talking about mental health, not many would anticipate. But what if you bring them together in terms of social responsibility? Let's go take care of our environment. Let's go take care or maybe feed people at the community level. So I was suggesting and bringing this forward to the university, if we could have social responsibility activities to bring students together, but through this ensure that we talk about the mental health challenges we are having as students and see a way of resolving this. And in addition to that, As a medical student from the School of Medicine, I've seen how many of us are going through a lot of stress and depression, especially when it comes to examination. And so I was suggesting and requesting if you could look into this as a university, where we could have support groups for the students, at least 10 to 15 students, maybe with peer counselors, so that they can have a follow-up and ensure that people finish school and we don't have the cases of extremes like suicide and all that that could happen if the mental stress is not in check. So yeah, thank you so much, and I look forward to seeing this implemented.
Thank you. That's a good contribution. Let's hear from Charles.
Hello?
Yeah.
Can I be heard?
Yes, you can. Please proceed.
Well, mine is appreciation really very much for Dr. Catherine and Professor Mary. We have a very special relation with these two. Their work should be my spiritual leaders before, and I have a special regard for them. And thank you. They have articulated the issues very well. And I want to pick it from where the person before me left it. And I'm just thinking, especially a challenge to Catherine. The issue we are having now is how can we form collaborative engagements, especially in the spiritual space. Most of the questions I've had being asked today and yesterday towards the end were about how do we make the spiritual space effective in service delivery so that we can get rid of those instances where, again, the spiritual space becomes an enemy rather than a friend. And I'm thinking with her experience, and I have known her leadership skills, together with even Mary, there are people who are able to steer this forward and see how we can collaborate, maybe between spirituality and psychology, to come up with even a tool. Maybe we need to have a tool where all people claiming to want to enter into the spiritual field are tested in order to, and constantly tested, maybe on an annual, biannual basis, to ensure that their mental capabilities are in order for them to continue practicing. That's just an opinion, a suggestion I'm making, and a challenge I'm giving to both Professor Mary and Dr. Catherine. Thank you so much.
All right, I will give them a chance to respond. The ball is in your court.
Yeah, thank you very much. I really appreciate the two speakers, and thank you very much, Bwana Inanga, for the compliments. I take it very, very kindly. Without going into much details, allow me to say that that discussion has already begun. We have had series of meetings here in this same auditorium. And this discussion has been towards the questions that are being raised today. So we are seeking to know how we can make mental health, spirituality a reality for the university students, because the students actually are our core business. So maybe at a later date, we are going to announce, we have Dr. Mary, who is the acting VC, and Dr. Some has also been part of that discussion, so that we are going to come up with a concrete way forward, where we were thinking of integrating the Methodist Treatment and Rehabilitation Center and this university, so that we have all of us as active players, and have the lecturers here who are in psychology, who are also pastors, who are doctors and nurses. We all work together as a team, and I believe that is when we shall come up with the social community programs like our student has requested, so that we have a lot of outreach programs, because we agree that outreach programs will make the students more active, and they'll feel a lot better in terms of participating into this journey, because it's a journey. But for the long term, I believe the university management will come up with a program, and we are all going to support it moving forward. And thank you very much for bringing it out. It's something that is seriously being thought of and something that is seriously being considered. Asante sana. Maybe the VC can add.
The chair has responded adequately. We will say that just what she has said is what we are doing. We are forming families for the students, so that each new student coming in will belong to a family, a support group, that we will be able to work with them through their journey. And again, the issues of integration, partnership, and conversations around the spiritual space, the chair has responded very adequately to that. Thank you, Charles, and thank you very much, Tawija.
Thank you. Is there any last question? I'm checking. Maybe people have now been, so that I don't deny you an opportunity. Yes, you can introduce yourself and put close the question you want to ask as we conclude that session.
Yes, thank you very much. I'm Elvis Karani, a student in this university. I also have one question that I want to pose regarding the mental health as far as is concerned, mostly for us as students. I will also add something to do, mostly it's just an addition to what has been put across, is that we as students, if you can be created an awareness or a room for us to improve, for example, come up with an application systems. For example, in IT, we can desire to come up with an application system that can be useful in improving mental health in students. As far as, for example, we have some students who cannot raise some issues to do with them in regarding mental health, and sometimes it becomes a hard task for us to spot out some of those students. So therefore, if you can have an application whereby the students or someone individually can able to access and point out issues that are affecting him or her, so that it can be put across to many or other people who are around, so that we can have an easier way to help out. So is just a platform for us to support that. For example, when you are doing that, we can come up with a system that can be able to improve that. For example, we had a student in University of Nairobi last year who came up with a system that helped to reduce the issues with domestic violence, which has been a helpful and a very simplest way to reduce issues with domestic violence, whereby some people cannot raise out issues to them. Therefore, they can use the applications to put out their points and their issues, and whereby supportive agents can have an easier task to step in. Thank you very much.
Thank you very much. The student speaking, very intelligent, has authored books, has done innovations, and I want Professor Ban to respond to one of the questions that the students have raised.
Thank you very much. What's your name?
I'm Elvis Karani.
Oh, Elvis Karani, it's a pleasure to meet you, and thank you for coming for this meeting. Actually, what we are talking about is looking for an application where students can be able to access the services of psychotherapy, a one-on-one kind of conversation. In the book of John chapter 3, there is a story of one of the learned people that came to Jesus in the middle of the night in the name of Nicodemus. Is it the name of Nicodemus? Eh? Yeah, so Nicodemus had a lot of issues that he couldn't share with anyone. And during that time, he secured a time that was very unique for him, and they had a one-on-one talk with Jesus. And actually, as they talked, they shared quite a lot of issues. So along with the initiative that we want to put in place here at Kenya Methodist University, we are trying to have a digital platform, and my brother James and Collins and also Jenu, who are experts in ICT, we are coming up with an application where students can be able to share their ideas in relation to mental health issues. Actually, I applied for a Fulbright scholarship on a digital mental health, leveraging an opportunity where we can even have a curriculum where students can be able to secure services of counseling and be able to share. So Karani, I want to urge you and encourage you that in the meantime we have our contacts. You can easily be able to contact us. Kenya Methodist University has a well-established dean of students equipped with a number of staff. Even the Faculty of Education, they have some staff that have basic skills. So meanwhile, before the app is operationalized, do not keep to yourself. Be like Nicodemus, who went and sought for assistance. In fact, the Bible is so broad that it gives a lot of experiences of people who are lonely, alone, depressed and stressed. But when they stood up, they were able to get assistance. So if you are a Bible scholar, I would still encourage you to have the Bible with you and read some of those ones. Like in John chapter 4, it talks about a woman who was doing things alone, depressed, but had an opportunity to get in touch with Jesus, and they talked one-on-one. John chapter 5, a man was maimed and had been there had been just seated there while the members were getting solutions to their problems. But he had to pick up his hand and be able to I'm going to ask Professor Carol to add on what I've mentioned.
So just to address first Sylvia. So Sylvia, one idea, I think something right before you brought it up, we just had a meeting about this, about how can we best support our students. So the administration is actively thinking about these issues. And one idea it was for you to, and because a lot of times what we see is that students suffering through this actually peer-peer mentorship helps, like peer-and-peer support, sharing the same experiences with someone else actually does help. So having some type of like a support group where you can meet with, you can have, you can get other KEMU students, and they don't have to be suffering from mental health challenges. It could just be talking about stress about school, stress about their relationships with their parents, and then you all sit down and have what we call group therapy or sharing, and there could be also a common knowledge that information that is shared in that group, it's a safe space, cannot be taken out. So that's something that I've seen implemented and something we were talking about right before you came with the VC and the head of the council. The other issue that another student brought up is the digital mental health. It's very interesting you brought that up because we just submitted with KEMU, and we just submitted a big grant that is specific for Kenya on digital mental health. And the reason why we did that is because We know that, I'll read you, it's a 7-page grant report that we just submitted for funding, but I'll read you exactly what we wrote so far. We propose to undertake a project that aims to revolutionize the health landscape in East Africa by developing a system in digital mental health and utilizing cutting-edge digital technology to overcome barriers to care, reduce stigma, and promote accessibility and culturally relevant support. The urgency of this endeavor cannot be overstated as the region deals resources, pervasive stigma, and scarcity of reliable information that is regulated by actual professionals. And this critical situation necessitates innovative interventions, and digital mental health solutions hold immense potential to bridge the significant gaps in care provision and empower individuals to seek help without fear of judgment or discrimination. So we wrote, actually James and I, and other faculty members here, we've been working actively on how to develop this. So in a lot of that, it's not just about developing an app, it's also having someone that can control the platform and make sure there's the information that is being shared is accurate and it's medically supported. So we're thinking, and we also want to protect people's information. So that's also a big emphasis for KEMU, is to protect patient information or anyone, because of the we don't want anyone to feel like they can't share or seek help. So they've been actively thinking of that, and so I really appreciate it. And hopefully, if this is it's a big, because we don't actually, in the U.S., what we have right now, it's mostly like telepsychiatry or crisis hotlines. So the digital mental health in East Africa is a pioneering project that they would be taking on that no other East African institution has. So this is where the innovation comes in. The other part of it too is the fact that this is not just by random people. These are by actual professors that know about the research. We realize that we have to be culturally competent and understand the faith-based organizations. Because KEMU is a faith-based organization, it lends itself to be the leader for this. So I really appreciate for you bringing that up, because that is something that they've already thought about and talked with us. So I'm also a neuroscientist at McLean Hospital, is the #1 psychiatric hospital in the U.S. And so they've been actively working with us and like we've been sharing what's been working for us on the other side. And they've been strongly trying to, many ways, try to implement this. So they have been thinking about this, and I'm really glad that you brought it up, because it just shows the relevance, more relevance to the...
Attend to some of these things that we are talking about. My next presentation, I think when that time comes, is talking about rendering.
And as a university, we have a chance to champion. We have, for example, in common university courses, and this is one way of trying to integrate something that could be part of the university, so that it is now disseminated even through that platform. Thank you very much. I'm sure the Vice Chancellor has taken into consideration that comment, and we shall take it forward.
We are aligning all our curriculums to CBC, and that's one of the things that will also be considered for all the programs, because mental health affects everyone. In fact, we are looking forward to being very innovative. And the chair of the council was challenging Prof. Bantu this afternoon that as we end this conference, we need to come up with a slogan that is born now and homegrown, and that we shall run with, even as we establish the institute, that indicates that we are all open to mental health. We are all open to zero tolerance for stigma. We are all open to educating, researching, and embracing good practices to promote mental health and wellness. I'm sure Prof will lead us by the end of the day in coming up with such a slogan.
Actually, Professor Carol, as we were talking, she had already come up with a slogan as mental hygiene and well-being, something like that. So I think we shall be able to embrace that, and we shall have some of these ones posted everywhere. I don't know that Professor Carol, are you in agreement with that slogan that we...
Yes. Yes, I think mental hygiene is important for everyone, not just anyone suffering from mental health challenges, but for just everyone. Talking about sleep habits, diet habits, ways to process information, grieving process. These are all mental hygiene that are just necessary tools for all of us to talk about and to start the conversation. That's how you have people who are actually suffering in silence, then they will open up. If we normalize, we need to normalize mental health. It has to be something that it has to be in everyone's everyday language. We all have to talk about this. We have to talk about stress. You know, stress leads to substance abuse. Stress leads to domestic violence. Stress leads to a whole platform. Even, you know, it causes inflammation, and we see from the research that it exacerbates cancer. So stress is a huge factor, and it affects everyone, even animals. So it's something that having mental hygiene and talking about coping ways, the best, you know, coping mechanisms, or what works for someone may work for the other. So this is something we want to approach. So this way, everyone is invited to the table. It's not just a selective few so that they stand out, rather than this is an everybody issue. From children all the way to the top, and like I said, even pets get stressed. So the stress is a big issue, and we know it's a big factor, it's a big culprit for a lot of the other diseases and cardiovascular, heart attacks. It's all stress related. So these are things that we want to promote, mental wellness, and have it be a dialogue for everyone, and not just people who are suffering from mental health challenges. Thank you.
Thank you very much. Let's applaud the team that has presented, our VC, our chair of council, and the comment and conversation that has arisen from that. Thank you very much. I'm looking at the clock because our lunch break is in a few minutes from now, and I'm going to ask one short presentation from Pastor Dr. John Yambo. Then we will be breaking for lunch. Not yet lunch, so hold it. Just hold it. Pastor Dr. John Yambo, if you are available, and you can do your presentation in the next 10 minutes.
Facilitator, before we go for lunch, I have an announcement, a short announcement to make.
Okay, no problem. Dr. Yambo, are you available? Did he make anything on the platform? Okay, if Dr. Yambo isn't there, Professor Baguma, I give you the 10 minutes. Professor, are you available? Are you hearing me?
Yes, I'm available.
Very good. If you can set it up, then we can give you the chance. Just adjust your screen so that we see the full you. We are seeing more of the president. Yeah, there, right there. We can see a little bit of the president, which is good, but we also need to see you. Thank you very much, Professor. Karibu, you have your 10 minutes plus 5 of question time. That's good. Professor, we can't hear you. Are you still hearing us? Professor Baguma, you've been thrown out of the network or something?
cannot hear him at all.
Yeah, he was thrown. I think the network wasn't very kind. To consider that it might have gone out for lunch. Let's see whether it comes back. Yeah, thank you, Prof. You're back. We missed you a little bit. Thank you. You are able to, can you unmute? Unmute so that we can follow you. Go ahead, make a word. Let's know that you're here.
Yes, I'm happy to be here or there. Good afternoon, everybody. Can you hear me?
Yes, we can hear you. Please proceed. Thank you, Prof, and welcome.
Yeah, thank you very much. Thank you, the moderator. You are doing a good job. My name is Professor Peter Waguma from Makerere University. The topic has changed slightly a bit. It is now mental health among veteran soldiers and the necessary psychosocial interventions. Because I didn't want to look at PTSD only. I wanted to be all inclusive, and that's why the topic is like that. And those who would want to work with me, you can see my email there. So I'm not going to define mental health and other concepts because these concepts have been properly defined several times, so we are comfortable with those definitions. I start by highlighting why. Why is mental health so important among veteran soldiers or among soldiers in general? It's because soldiers work under difficult conditions, very difficult conditions. Even when they go for missions abroad, the conditions of work are so stressful, so demanding, and so traumatizing that many of them are likely to come back home having developed a number of psychosocial problems. The problem is that, especially in Africa, this idea that soldiers can easily suffer from mental health problems is not well known. They think they just let soldiers go abroad and just come and receive them and they rest. That is all. But now, there are efforts trying to focus on that, try to help soldiers before they go for missions, and when they come back from the missions. And in Uganda, I'm precisely involved in that. Actually, yesterday I was receiving over 1,000 soldiers from Somalia, and I wanted to share my observations regarding these mental health conditions. So I wanted to highlight on the common mental health problems among veterans, and also to identify different ways of helping the veterans. So I'll quickly delve, because I don't have enough time, I'll quickly delve into some of those common mental health challenges that have been noted here in Uganda and elsewhere on the globe. One of the most common is lack of discipline, or what we might call indiscipline. And sometimes when soldiers come from the missions, they are so tired and they don't want to listen to anybody. So lack of discipline or discipline is one of those conditions that we could focus on. Another condition is post-mission anxiety. All these conditions are post-mission. Yeah, post-mission anxiety. I don't want to go into details of defining some of these, which they have been already defined by some of you speakers. Then there is phobia, post-mission phobia, and phobia is fear of specific places, things, or situations. Panic attack is also another common condition. There is also depression among soldiers coming from missions. There is also emotional disturbance. Some of them report hopelessness, despair, anger, hostility, frustration, unmet expectations, lack of love, and other emotional disturbance. Actually, recently, one of the soldiers here shot a member of parliament, and we assessed it as lack of anger control. Having lack of control of anger, having not able to manage anger. Then stress. Many of them report a lot of stress, as has already been discussed. Returning soldiers, they have a lot of stress. And this stress comes from three areas. There's what we call combat stress, because they're involved in many battles. There is also what we call operational stress, because while abroad, they involve in many operations. Then the other third type of stress, which is very serious and also common, is called PTSD, post-traumatic stress disorder. And because of those difficult conditions under which they work, actually most of those conditions are life-threatening. Because they are life-threatening, they are likely to lead to PTSD. And this PTSD disturbs the soldiers quite a lot. Then suicide. Suicide is not very common, but it also takes place. Actually, what is a bit slightly more common is the addictions. Addictions to pleasurable things. Addictions like sexual addiction, alcohol and drug addiction, gambling and betting. These addictions have been noted among the veterans. Then community problems. When these veterans go back into the community, some of them don't behave well. Apart from having conditions, mental health conditions, which could be triggering, they think that they are the masters. They have a gun, they think they have power, and they start disturbing the community. Some of them turn into village thieves, others involved in shootings. Another mental health problems observed is the family problems. Some people have already, speakers have already alluded to this. Family problems, there is a lot of violence, intimate partner violence, violence against children, and so forth. There is also a possibility of sexual problems, but this has already been highlighted above as one of the addictions that we should be careful about. And also alcoholism has also been noted. So those are some of the common problems that have been noted among returning soldiers or veterans, both here and also abroad. Many studies about mental health problems among veterans have been conducted in the US, and those studies confirm that actually that these are some of the most common mental health challenges. Now, some of you have been talking about mental health. I mean, we have been talking about psychotherapy. So what did we do with these soldiers who are affected? And as usual, psychologists, we are called upon to help those affected soldiers. And normally when we are called upon, we institute some sort of counseling or some sort of psychotherapy. And for us, we don't have drugs like doctors. And as one of the speakers already said, we use words to heal these soldiers. And so we offer services to these soldiers, and there are a number of counseling or therapeutic techniques that and approaches that have been suggested, and we can approach it using about 11 approaches. The first one is the use of drugs, which we normally call pharmacotherapy. Use of drugs, especially PTSD, is so heavy, very serious. We can put them on drugs first, and when they leave, then we can institute psychotherapy. Yeah, so sometimes we combine both drugs and psychotherapy, which we call psychopharmacology. Then the use of CBT, cognitive behavioral therapy, has been applied, where you are focusing on the thinking and beliefs of these veterans, but also focusing on how they behave. And we also have another tool, which we call narrative exposure, where an affected soldier is encouraged to talk about their condition through a variety of ways. There are many ways of doing narrative exposure. It can be through writing. It can be through talk. There are so many approaches there. Then we also have the possibility of family therapy, where the soldier is going to be treated, but as part of a family. Part of the family, the counselors, psychologists visit the family, they talk with the parents and the children, and they discuss these problems and offer solutions. Very common is also the stress management techniques. As you know, viewers and listeners, there are a number of stress management techniques that people are using these days. And many people in the community, I see them enjoying these approaches. The use of music, dance, drama, breathing techniques, progressive muscle relaxation, good eating, and other approaches could be used, and strategies could be used to treat the soldiers, the veterans that are suffering from stress. We also teach them about coping. Somebody has already talked about coping. We teach them how to cope. Good enough, the psychologists have a big repertoire of coping and coping techniques and approaches. So normally we train these soldiers on how to cope. And when they cope very well, then they are on the road towards developing resilience, so that next time they meet similar conditions, they will not crumble down and suffer stress. Another technique is EMDR, eye movement desensitization and reprocessing therapy, where the soldier is encouraged to follow the movement of a finger or any other object. And through this eye movement, we know that memories can be held. And what is very common on these approaches is the treatment of addictions. Psychologists have a number of techniques that they use to treat addictions. Sexual addictions can be treated using CBT, drugs, and psychoeducation. Gambling can also be treated using similar techniques. Alcoholism can also be treated using similar techniques, in addition to the use of chemical or pharmacological approaches. And catharsis is also being exploited. Catharsis is encouraging the soldier or any other person to spend energy in more acceptable ways. For example, when you feel anger, you are encouraged to go and play sports or to go and dance. In that way, you spend that aggressive energy in a more acceptable manner. So I think that those areas should be further exploited. I think they are promising, and they will help us. Then there is also the physical and psychological rehabilitation. If there are soldiers, veterans that have suffered losses, then they can be rehabilitated both physically and psychologically. Then very important is the community support. Community support, I think Dr. Carroll talked about peer support and community support, putting into a system in the community where these soldiers can be supported. So can be supported to make sure that their integration and adjustment is well done. And lastly, listeners and viewers, we are talking about referral. Referral, sometimes we might not have all the skills, all the knowledge and competences that are necessary, that are needed by some of these veterans and clients. So in that case, we make sure that we refer them the appropriate help. We refer them and they go there. We make sure they have the correct addresses, the correct contacts, so that they can go and get competent help where it is found. Thank you very much, and thank you for listening to me. I hope I have taken not too much of your time.
Thank you very much, Professor. Let's applaud Professor together. He has done a good job. Please applaud him. You will get a little more, you get more lunch if you applaud him better. Please applaud him better. Yeah, thank you very much, Prof. Thank you for that very educative process of learning how to handle stresses that are related with the people who have served in military and other forces. And I'm sure there will be lessons taken from that, even for our other regular processes. Like I like the catharsis part, where you tell people to spend energy in other ways, rather than just misuse it or use it in the wrong way. Thank you very much. That's good. Let's now get a chance to interact with the prof's work in 1 or 2, 3 questions, and then we can go. I can see Eric's hand is up. Who says online team? I want to be cognizant that you are present, so I don't want to ignore you. Eric is in here. Who else? I want to pick the questions so that once we are done with those, then people do not feel like I'm holding you captive. I want to let you go out for have your meal. Any other? Eric only? That's the only question? Okay, Eric, please go.
Yeah.
We'll see somebody else online? Okay, and Eric, go. Please go on.
Okay, thank you, Prof, for that wonderful presentation. And it's quite a concern, even as we talk about these returnee soldiers, if I can call them that. My question is, I don't know whether you've encountered issues, when you're talking about issues now, stress, not only not to the soldiers, but now their families. And what are you doing so that now you're able to help the families now, help the soldiers cope with the stress? Thank you.
Thank you. There's a question online. I can see Charles Kenanga has raised his hand.
Can I go quickly, Dr. Mushiri?
Please go. We give you a chance.
Mine is just about the difference. Whether Professor Wanguma can tell us whether there was any difference in terms of this between lady and all female and male soldiers. Was there any is there any significant differentiation in terms of how they present this post-mission mental disorder, mental health concerns?
That's a good question. And perhaps also to add to it, is there age? There are issues that are related to age.
Yes.
Younger versus a little older, you know, these issues. Professor Baguma, you may want to respond to that.
Thank you very much for those 2 educative questions. Eric, I think, is wonderful. The question from Eric is wonderful. And he's talking about the families. Very good observation. Because when the soldiers go abroad, they leave the families behind. And so far research indicates that the families sometimes suffer from the same conditions that the soldiers themselves suffer from. They develop stress, they develop PTSD, they develop worry, anxiety, they are depressed. So, because the family head is not there. So, they suffer from the same mental health conditions like the soldier who has gone abroad and who is coming back now. So, that's a good observation. So, that's why family therapy is very important. That we should not focus only on the soldier, the returnee, but we should also focus on their families to give them psychological support when the family head is not there. So that is very, very important. The second question was about the prevalence of mental health conditions between male and female soldiers, and also between different ages. So this one I cannot say that I will give you a competent answer, because as you notice, we are just beginning. What I have presented is just observations that I have made, and also what I have read in the literature. So we are just beginning the studies, and the studies are the ones which are going to give us concrete answers. I'm sure there are going to be differences. There will be differences between the different genders, and there are also likely to be differences between age categories. But let's wait a bit. We have just started our studies. Actually, we are still gathering data. We are in the data collection phase. And the next conference, I will present a more concrete position. By the way, when I'm doing this, I do normally work with Professor Bantu there. So we are doing this work together. So thank you, Professor Bantu, and thank you, everybody. I wish you a good lunch.
Thank you very much, Prof. We are glad that you were able to present that, and a comment on online saying that your presentation was precise and to the point. So a compliment from one of the persons who listened in. So thank you very much. That's a good observation. Maybe you will explore also the element of whether the duration of service may also contribute. Yes. I'm sure you will see all this in your study, and we look forward to the outcomes, which will obviously inform many other programs that are taken for these returning soldiers. Thank you. Let's applaud Professor one more time.
We're good.
Asante sana.
Asante.
I want to invite Dr. Mwamisi. Yes, Dr. Mwamisi, to say grace for the meal, and then we let you free. Yeah, there was an announcement to be made. Sorry, sorry, I'm sorry for that. DVC, you have an announcement to make.
Thank you. This is for KEMU participants here, and those who may be online. So our international participants, forgive us for that. I did send out an email last night and also a WhatsApp message for KEMU research teams. There are a few I did not have their emails, and I said please forward and share with them. So at the end of our conference, we would like to have a consultative meeting with our partners. So members, bear with us for just 1 hour after the end of the conference. So we touch base on the best way forward. It's related to the research areas that were identified. Thank you very much. Thank you, moderator.
Just before he comes on board, Dr. Mwamisi, just before you say the prayer, we have further announcements to make. Members, you're encouraged. This is the last call. Before you have your meal, ensure that you have registered. We are picking the information now and forwarding it. If you have not registered for this session or yesterday's session, then your name may be missing. That is all what I wanted to add. I also wish to thank all the presenters. I want to thank all the panelists. I want to thank everyone who has participated, and even those ones who are planning to come. Kindly do join us at now we'll give you only maybe 30 minutes to 40 minutes. Yeah, 40 minutes from now, so that we can be able to cover the afternoon session. Thank you. God bless. Dr. Mwamisi, please.
Father, we thank you for your blessings, especially this time as we take out a health break. We pray that the blessings of the Lord shall be upon the foods and the drinks that we are taking to strengthen us, Lord, that we may be able to navigate through this wonderful conference. We bless you and honor you in Jesus' name. Amen.
All right, you're free to take your break, your lunch break. Those online, please be back, I think 2:30. Yeah, please proceed.
Sambuli, Mr. Sambuli, if anybody can find him, wherever he is, I need him. You have 30 minutes to take your lunch, so you'd rather hurry.
Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be a trailblazer in the academic landscape. Call us today or visit www.kemu.ac.ke to enroll for May and September 2024 intakes. KEMU, the future is here. Imagine a university that inspires change, a university that offers ultimate campus experience. Welcome to Kenya Methodist University. Over the years, we've grown to be a global brand in higher education, with students from over 34 countries. With our strong Christian values and commitment to excellence, we continue to be
Shout Jesus from the mountains, Jesus in the streets, Jesus in the darkness over every enemy, Jesus for my family, I speak the holy name, Jesus. Oh, oh, and shout Jesus from the mountains, Jesus in the streets, Jesus in the darkness over every enemy, Jesus for my family, I speak the holy name. to speak the name of Jesus over every heart and every mind. 'Cause I know there is peace within your presence. I speak Jesus. I need you.
this grace, Lord, I'll sing out your praise forever. Remember love, remember mercy. Christ before me, Christ behind me. Your love and kindness has never failed me. Christ before me, Christ behind me.
have about 3 minutes before we resume the program. Please settle down. 3 minutes before we resume the program. About 3 minutes to resume the program. Please get set.
Hosanna,
Thank you very much. We should be getting back to ourselves, and I want to check, is Dr. Frederick Dede within? Okay, if Dr. Dede is not here, as we wait for his coming to run the afternoon session, I want to check whether whether we have Dr. Yambo. Are you back? Dr. Yambo? Dr. Yambo? If Dr. Yambo isn't there, I want to go to Dr. Tarsila. Is Dr. Tarsila available? These are people who should have presented before lunch. That's why I'm calling their names. Is Severina? Are you the one doing on that slot? Yeah, I'm just checking. The session that was for you and Dr. Kebara. Are you all set? Yes, I am. Okay, so we can have your presentation, and I'm hoping that by then Dr. Dede will be back so that he can learn this. So after.
Yeah, I'm sorry. Just a quick one.
Yes,
if
yes.
we could make an order of presentation so that at least we are able to organize ourselves.
Okay, after Dr. Severina, who is doing it at the slot, and Dr. Kebara, then we'll have Dr. Odhiambo. Dr. Odhiambo Roslyn, are you available? She's here. Okay. Thank you, Dr. Odhiambo. Sorry, we should have had you. Okay. So we have you immediately after Dr. Severina. Sasa. Then we will go to Dr. Anastasia. Anastasia, you will be next after that.
I'm present.
Yeah, very good. And then, of course, by that time, we'll see whether Dr. Kebara has come back. Dr. Frederick Dende, this is your session. You'll drive it. I've just started the car. Dr. Severina is there. But be sure that you can take the ride as we go. Since Dr. Severina is coming, then Dr. Odhiambo, Anastasia Mureithi, and then we shall proceed. Asante sana. We are allowing 15 minutes, and this time we'll be a little more strict on time so that people can all present. We don't have another day of conference, so we'll have to manage time. So, Dr. Dende, please take charge.
Thank you, Dr. Mshiri. Just as it has been said, we want to keep time because there are so many presentations to be given. And so I'm kindly requesting every presenter to observe time. If you can do your presentation in 10 minutes, and then the next 5 minutes will be for discussions, it will be okay. And I welcome everybody on board, especially those people who are online. This is not just a KEMU issue, it's an international issue. We need to share from wherever you are. Dr. Severina, if you are ready, you can start. 15 minutes.
Okay, good afternoon, everyone. Let me take this privilege to share this paper with this international community, and it is on bridging the gap, influencing change leadership and management. It's a paper which is a review paper. I want to start with the introduction. And we note that there is a distinction between change leadership and change management. As per the title, where we want to see how the change leadership and management can be integrated to bridge the gap for the mental health of individuals. So there is a distinction between change leadership and change management, which has been a topic of significant discussion within institutional studies. While change leadership focuses on vision, inspiration, and driving transformation, change management is concerned with the processes, tools, and techniques that facilitate change. This paper argues that bridging the gap between these two approaches is essential for successful change initiatives. By aligning leadership and management practices, organizations can better navigate the uncertainties of change and achieve desired outcomes. The relationship between change leadership, change management, and mental health is another critical area of focus in organizational studies, as we are going to see in this paper. Change initiatives, while essential for institutional success, can significantly impact the mental health of employees. This paper further explores how integrating change leadership and change management practices can support mental health within organizations, leading to more resilient and sustainable transformations. Organizations that prioritize mental health in their change strategies are more likely to achieve sustainable change and long-term success. Let's look a bit of literature review, because we are learning from it, being a paper on a review of literature. Change leadership is characterized by its emphasis on vision, inspiration, and the ability to influence others toward a shared goal. Let's look at key attributes of effective change leaders. They include visionary thinking, emotional intelligence, strong communication skills, ability to inspire and motivate, strategic agility, among others. And we also recognize that effective change leaders play a crucial role in supporting mental health by the following. 1, visionary thinking and clarity. Providing a clear and compelling vision reduces uncertainty, which can alleviate anxiety and stress among employees. Then we have emotional intelligence. Leaders with high emotional intelligence are better equipped to recognize and address the emotional needs of their teams for a supportive environment. Then we have strong communication skills. Transparent and consistent communication helps mitigate fears and rumors, creating a sense of security and trust within the organization. You also have inspiration and motivation. Inspiring and motivating employees can enhance their sense of purpose and belonging, which are essential for mental well-being. Let's also look at change management. Change management involves a systematic approach to dealing with the change, both from the perspective of an institution or organization and on the individual level. And it includes planning and implementing change initiatives, managing stakeholder engagement, monitoring and controlling change processes, ensuring sustained change, among others. Let's look at effective change management practices, how they support mental health. Structured planning and implementation helps when there is effective change management in supporting mental health. With clear plans and structured implementation, it reduces uncertainty and helps employees understand their roles within the change process, hence reducing stress. Then we have stakeholder engagement. Engaging stakeholders and involving employees in the change process increases their sense of control and reduces feelings of helplessness. Then we also have monitoring and control. Regular monitoring and feedback mechanisms allow for the early identification of stressors and mental health issues, enabling timely interventions. Because we should not wait until the problem has developed, we should aim at prevention. Let's look at integrating change leadership and change management for mental health. Integrating change leadership and change management practices can create a holistic approach to supporting mental health during organizational change. For example, vision and strategy alignment. What impact does it have on mental health? Aligning vision and strategy provides clarity and purpose, which can reduce anxiety and improve mental well-being. There has to be action steps which may include develop and communicate a clear vision to reduce uncertainty. Also ensure alignment between vision and operational goals to provide stability. Let's also look briefly at collaborative leadership and management and its impact on mental health. Collaboration and shared ownership of change initiatives can enhance social support and reduce stress. What action steps do we need? They may include establish cross-functional teams to foster a sense of belonging, provide training on mental health awareness and resilience. What about the stakeholder engagement and communication? What impact? Engaging stakeholders and maintaining open communication can reduce feelings of isolation and anxiety. What are the action steps? Develop comprehensive engagement plans that include mental health support. Use multiple communication channels to provide regular updates and support. What about monitoring and adaptation? What impact does it have on the mental health? Continuous monitoring and the ability to adapt based on feedback can prevent burnout and identify mental health issues early. What action steps do we need? Implement systems for monitoring employee well-being. Use data to inform mental health interventions and support strategies. Bridging the gap. The literature we have gone through highlights the need for an integrated approach that leverages the strengths of both change leadership and change management. And the key themes include the complementary nature of leadership and management, the importance of a unified strategy, the role of communication in bridging the gap, the impact of institutional culture. This paper has also provided a framework for integration, and the framework proposed here for integrating change leadership and change management focuses on 4 key areas. The first area is vision and strategy alignment. Effective change requires a clear and compelling vision that aligns with the organization's strategic objectives. Leaders must articulate this vision while managers develop detailed plans to achieve it. What are the action steps? Develop a shared vision and strategic plan. Ensure alignment between vision and operational goals. Communicate the vision consistently across the organization or institution. The second key area is collaborative leadership and management. Collaboration between leaders and managers is essential for effective change. Leaders should empower managers to take ownership of change initiatives, fostering a sense of shared responsibility. What are the action steps? Establish cross-functional teams to drive change, foster a culture of collaboration and accountability, and provide training and development for both the leaders and the managers. Remember, when we are talking of leaders and managers, at every level we have leaders and the managers. The third key area is stakeholder engagement and communication. Effective change relies on the engagement of all stakeholders. Leaders must inspire and motivate, or managers must ensure clear and consistent communication. Action steps include develop a comprehensive stakeholder engagement plan. Use multiple communication channels to reach diverse audiences. Provide regular updates and feedback opportunities. The fourth key area is monitoring and adaptation. Change initiatives must be monitored and adapted based on feedback and changing conditions. This requires a combination of leadership, insight, and management rigor. What are the action steps? Implement robust monitoring and evaluation systems. Use data to inform decision making. Be prepared to adapt strategies in response to new information. That's the framework, integrated framework. A message has been passed to me that I have only 5 minutes. What I'll do, I will leave some information that I wanted to share with you on case studies. We will have no time to look at this, but I will just highlight a few things that I wanted to pass across through these case studies. Through these case studies, the case study number 1, global technology company, it is highlighting how what we have gone through, the integrated framework, after making use of it, the results of the integrated leadership and the management changes. So that's about that case study, which according to the time I'm being given will not work. But there is something I will highlight at the end of the case studies. There is also a case study 2, which I will also not share with you, about change leadership at Healthcare Plus, where the results of integrating change management and change leadership bore very good fruits. But I want to say that both case studies, they had their focus on mental health. For example, the Healthcare Plus, the stakeholder engagement, the organization actively engaged healthcare providers in the change process, addressing their concerns and stressors. There was also regular communication, as we had earlier indicated. It's very important. And in conclusion, bridging the gap between change leadership and change management is critical for navigating the complexities of today's institutional environment. By integrating these two approaches, organizations can enhance their resilience, drive sustainable change, and achieve long-term success without compromising the mental health of the stakeholders. And thus bridging the gap between change leadership and change management is very essential for both organizational success and employee well-being. By integrating these approaches and prioritizing mental health, Organizations can create a supportive environment that fosters resilience, reduces stress, and enhances overall performance. Hence, working in a healthy organizational or institutional environment. Thank you. I hope I've kept time as I was really being directed.
Thank you, Dr. Severina. Thank you for a job well done. Can we clap for her? Yeah, that's very good. We have kept time and actually on the dot. I will just give some few minutes for reaction. Anybody with a comment, a question? Can I get to see whoever wants to do that? You are allowed to do so. Any questions, reactions from within and from online participants?
Yeah, hello.
Yes, please.
Yeah, thank you. And thank you, the presenter. The presenter is emphasizing organizational change and management, which I feel is very, very important, because sometimes the organizations are the ones which reduce mental well-being. So, if those organizations are well managed and there is emphasis on mental health and proper organizational practices and leadership, I think it will be a way of reducing mental health problems. So thank you very much.
Thank you for good comments. Anybody else?
Yes, Dr. Dede.
Yes. Yeah.
Okay. Thank you, Dr. Severina, for that presentation. My name is Flora Mutwiri. I'm also in leadership and management. My question to my good friend, Dr. Severina, is you have provided a very good framework for managing change. And my question is, can the same framework be used in our social institutions, such as the family and the financial institutions? And I want to give an example from the family level. Maybe where the husband is expecting to eat some mugari for supper, and the wife comes with some chapati, and then it becomes a source of conflict. How can we use the same framework that you have provided? We also find that the financial institutions today are other sources of stresses. Chama cha wanawake, for example, where the interest rate, for example, as raised, and then maybe it was not communicated. So can the same framework that you have provided then become a good whatever change strategy? Thank you.
Thank you. Yes. Other comments? Yes.
Okay, thank you. Thank you for the presentation. I think mine probably is an observation, because I tend to join it as a task, maybe not as an organization, but we have also leadership and management styles also plays a very key role, especially the autocratic one, or what we can call bureaucratic or a dictatorship. These are people who take the role like of a god. Their word is final and it is the truth. We have seen that one really even in spiritual institutions and all other institutions, including political. Has your paper also considered that? And then there is also the principle of continuity and discontinuity, which is a big issue, especially in the political arena or even institutions where now people are not ready to give up their role, or there is fear and there is stress when there is a change of leadership or management. I was wondering whether also that one you have dealt with that particular aspect. Thank you.
Thank you.
Thank you very much. And made, we can clearly note that for a presentation, according to the presentation, a member of an organization relates to the common goals and feels that they have been heard and understood. So my question today is that how can this change be implemented in a digital manner that can influence technological advancements in an organization to enhance effectivity in it? Thank you.
Thank you, Sabrina. You can now react.
Okay, thank you very much. Let me start with the first observation. That was acknowledgement of the importance of the paper. Thank you very much. The second one is from Dr. Flora about if the framework can be utilized for other institutions or other areas of social importance. I want to confirm that this framework can be used at any level and by any institution, because although the emphasis was so much of on organization or institution, families are a form of institution. And you can see there was a lot of emphasis on communication. The paper picked very major and key aspects of leadership and management that cut across at all levels of social frameworks and even all kinds of organizations, institutions, so including even the financial institutions. So the framework is applicable at any level and for any kind of institution. Let me go to the other parts on observation, where it has been observed that was leadership styles, were they captured, or did the paper think about them? There is also other aspects that are not captured. Yes, leadership and management is very wide, and this paper looked at the specific, very key areas that may support mental health. And although not mentioning the leadership styles, all the kinds of styles were in the mind of the author of the paper by picking the important skills or the important attributes of a good leader and a good manager. By doing so, that's why we talked about good communication, planning, involving the stakeholders. And when you look at these attributes of these leaders, they don't point to, for example, leadership style that works against the stakeholders. For example, the autocratic. The attributes that were cited in this paper are majorly for transformative leadership. So that was factored, although the terms like leadership styles were not used here. However, the paper can be improved by specifically pointing out some of the leadership styles that can be recommended for good leadership that will not stress workforce and other stakeholders. And we realize in the leadership and the management, as per this paper, in an institution, whether it's family institution, church institution, or even an institution like where we are meeting physically at Kenya Methodist University, an institution is an institution, and leadership is leadership and management at whatever level. And if the leaders and managers are not keen, they can stress everyone. They can stress themselves, stress the workforce, stress the customers, and cause the mental health issues that this conference has been discussing.
Thank you, Dr. Severina. Questions will still keep on coming. I think it is important that we have the next presenter. Thank you.
Okay, thank you so much.
Yes, thank you, Dr. Severina, for that. Our next presenter, please, Dr. Roslyn.
You can use this.
Let me have it this side. Okay.
Then niletea karibu.
Niletea karibu kiasi.
Ondoa simu.
Okay. I can actually even use that.
Can even use this. But nataka mtolee hii. Okay. Iache kukaa very easy.
Okay. Good afternoon, everyone. My name is Odhiambo Roslyn, and I'm here to participate in this very educative conference. And today I want to take you to a different direction. Let's cross over to the midwifery world. Let's cross over to the reproductive health world. And we want to look at mental health issues concerning tailoring it to reproductive health midwifery. And the title is Awareness of Risk Factors. on postpartum depression among postnatal mothers, and this study was done in Nyeri County Referral Hospital, and this is Kenya. Okay. So let's get to understand what postpartum depression is, and we know very well that DSM-5 will define this. I would like us to look keenly on the definition for postpartum depression in the sense that we are focusing on a pregnant woman, and it states that it's a major depressive episode with the peripartum onset. When we talk about peripartum, it simply means the time duration from pregnancy all the way when this woman is going to deliver and afterwards. But from the word postpartum, most of the time we realize this is the time where we experience depression or psychosis for women after they give birth. And that depends on very many reasons. And from a few researches that have been done, we are seeing that they could be like lack of support, information, history of depression. These women could have suffered depression previously, and that is why they are actually having depressive episodes even after they deliver their children or their babies. Unfavorable obstetric outcomes. Sometimes they do have very unfriendly experiences when they go to give birth to their children, and that's why, due to that frustration, they end up having depression. You will hear other people calling this condition postpartum blues. All right, so postpartum blues, postpartum depression, that is one and the same thing. Domestic violence as well, low income status and advanced maternal age, lack of information, negative attitude. So for those who think that they have not probably been treated well or they have not been handled well in the facility, and they may actually just end up saying, this is not something I want to go into, I will not go to the facility. So it actually affects even the attendance into the ANC. And then, of course, we are saying the prevalence is quite significant. We are seeing in developed countries 10% to 20%, and while in low-income countries, 20%, and in developed countries 10%. While in sub-Saharan Africa, this is part of in the larger part where we are in, we are seeing the percentage being quite high at 30%, and we are also seeing that part of the problem statement that there are quite a number of researches that have been done in Kenya, but aside from that, we are still seeing that from the global report. So globally, we are also seeing this being a problem, and in developing countries, we are seeing it to be having a rise from 5.2% to 74%, and in developed countries, in developing countries, 1.9 to 82.1%, and in developed countries, all the way to 74%. And in Kenya, we are seeing quite a number of studies have been done, and still it's a burden. You're seeing a study from KNH that was done, and we are seeing the percentage to be at around 10.6%. Another one in Kariobangi North. These are familiar places in Kenya. We may know Kariobangi Health Center, where we are seeing the percentage also to be at 13%. Another one in Madare and Mbagathi at 18%. Then we are seeing also in Nakuru, another study was done, and we are seeing that prevalence still being at 11.3%. In Nyeri County, where the study was done, we are seeing a rise from 16% to 24%. So this really creates a gap that needs to be addressed. And then, of course, these were the objectives. Basically, we'll be looking at the knowledge and also the attitudes, and we are saying it's important for us to do this study. It was there was need because we are seeing that the information and education levels, there was a gap that was existing whereby women did not really understand, and we are going to look at that when we are talking about the results. Methodology, I may not delve into that so much, but of course, this study was carried out on postpartum women. These are women who have just delivered, so in their postnatal wards, this is where they were found, and of course that is just part of the analysis and ethical considerations. I may not go so much into that. Then of course for the results, strikingly the findings, majority of these women, 40%, were not knowledgeable at all about information pertaining postpartum depression, and that is why most of them seemingly look like this was a very new concept to them, and you will actually realize that for these women, most of them actually did not know they have this because they did not understand what symptoms are there. You get a woman is withdrawn, is sad, having emotional issues, mood swings, but they really don't understand what is happening to them. Down, we are understanding even the causes. So even these women, 47% of them did not understand what the causes are and even the symptoms to this condition. And 86.7%, and this was actually a major issue, we are seeing most of them admitted to have had unplanned pregnancies. From this study, this was something that was very striking, because you'll realize that anyone who is having an unplanned pregnancy, and by the way, even married people can have unplanned pregnancy. We are not safe from that. And you realize this tells us a lot even about the young people who actually fall into this bracket. The reproductive age bracket is 15 years to 49 years. So you can actually see that this actually is an issue that affects. And probably even education for these young people is important. But as we continue, we are also seeing that those who had history of mental illnesses, that was actually a report that was given from those women. Spousal support, we are seeing that most women reported to have had very busy schedules. They don't have time to stay with their women, to give them moral support, financial support, and you see those are now just sources of stress. Those are sources of stress for these women. And then, of course, as part of looking at the attitudes, we realize that most of these women, 16.7%, confusion, sleep problems, and you see these are the initial signs you'll be able to see in someone who is actually most likely having symptoms of mental illness. Anxiety, crying, could be crying for no reason, but you don't know actually that you're getting depressed. Irritability, and actually something else that came out very vividly is these women would not seek help. Despite seeing some of these symptoms, they would not still seek help, and that was a very big percentage coming from this. And part of the discussion, we are saying that from what we are saying about the knowledge, that was our first objective. We are realizing that there was a problem with psychological preparedness. There was a problem with understanding the causes, the symptoms, and of course this agrees to quite a bit of researches that have been done before. Stigma. Yesterday we had a very interesting conversation about stigma, and you'll realize that this is a big problem. Yes, I have depression. I will be isolated, I will be treated differently from other people, and it's like a disease. We even have had experiences and testimonies from other people in various countries. And also attitudes, confusion, sleep problems, crying, all this agrees to some of the studies that have been done. So inability to recognize these symptoms and acknowledge need to seek help will prevent prompt interventions. So we will not be quick to come in on time. At the end of the day, we realize we lose some of these women to mental illnesses. And as I conclude, women lack knowledge. Women lack knowledge on the risk factors for postpartum depression, and they also lack information. And because they lack this information, then they will not be able to prevent. They will not be able to take measures to prevent, and prevention comes from different levels. From the time you're meeting this woman in the preconception, during the preconception period, she has not even gotten pregnant. She's coming to ask you, I want to get pregnant, what can I do? From that time until when she gets pregnant, someone should be working with this woman, and therefore that simply means that interferes with their health-seeking behavior, and of course affects their attitudes. Inadequate knowledge and practices towards the prevention of risk factors for postpartum depression will contribute to an increased incidence of postpartum depression. Recommendations, because this study was carried out in Nyeri County, we are saying that we need Nyeri County as a dissemination process to help us to get education forums, and we are seeing that there are actually policy guidelines that are there. When you look at the National Postnatal Care Guideline that is existing, and we are trying to see if it's possible to actually improve implementation, and at the end of the day also improve on referral systems. Sometimes you have a woman who is presenting with symptoms, but no one is willing and ready to help this woman. So at the end of the day, the symptoms continue to grow, and the symptoms continue to become even worse. So this woman ends up having the real disease. And we are saying that even commonly we have psychosis as well. And the county government can also take part in making sure that there is awareness created. We have community outreaches. Most women, I was in Sudan some time back, South Sudan, and we realized that where I was doing that training for maternal and child health issues, there were particular women who were coming to the facility. And what I observed was that when they were walking in, they were already bleeding. So when we take history for these women, they tell you see, when you go to Sudan, there is this community called the rebels. I think they are the rebels, and then the ones who now stay in the cities. There was a problem with those people who stayed out for them coming to the cities to get help. So they stayed in fear, they stayed in, they did not want, the stress levels were too much. They didn't know how to help themselves. Even the pregnant women, when they came out, they might have labored in the bush for such a long time. By the time they're coming, they already have uterine rupture. So a good percentage of clients I saw in South Sudan during that period of time died from uterine rupture. So you can see where the problem is coming from. And also for mothers, I want to insist so much on male involvement, men in the house. Hello, men in the house, we are fathers, we could be boyfriends. Oh, but we are a bit old here, so I don't think, we could have boyfriends, yeah. But I don't want to talk to boyfriends today because you are part of our problem, so we want to solve your problem. So the men in the house, I think it's high time that we actually help out. How do you help out? By becoming more visible, we need to hear you, we need to see you, we need to feel these men, giving these women supportive, care and providing for them, and not being part of the problems of STIs and all that. So they need to come out. So male involvement, we need to reach out to more men. In the clinics, we need to see more men helping the women carry umbrellas and come on board and help them with services. Implication for practice, therefore, because we have low degree of understanding for postpartum depression, therefore we want to look out to the MOH, we want to look out to the NGOs, and I will proudly say that I am the CEO for a very interesting community services program called Ultimate Maternal Insights. It's still a baby. We have the Meru chapter. It was rolled out not long ago, and I'm glad to be part of the implementation and the change so that you can reach out. Actually, this month we are rolling out school girl health education. So, and I'm saying that we need to hold awareness campaigns. Mental health screenings is important. Healthy development, to enhance healthy development of both the baby and the mothers. Otherwise, thank you.
Thank you, Dr. Odhiambo. Can we clap for her? That's very, very, very interesting presentation. Thank you. And trying to involve men is a great thing. When it comes to providers, I think there's something which is still lacking. I'm just talking as a reproductive health specialist. There's something which is still lacking within the system. We need institutions to think of mental health in reproductive health that will incorporate how we rear our children during the time of adolescence. A girl who is getting periods for the first time may get scared, may have some issues. It also affects people who during their menstrual time, a lot of psychological problems are involved there. Pregnancy itself may be exciting, but may also cause a problem. There may be so many issues, and these are some of the places that we really need to check on. And more so after pregnancy, what you have described is very real. So if it were possible, mental health should be incorporated in the training of reproductive health at all times, so that we end up with people who know what to do. It may not necessarily just be medical treatment, but it may also involve psychotherapy and sociology. Psychosocial scientists may also be involved here. So there's a lot to think about when it comes to mental health. So any reactions from anybody? Questions? Yes, sir.
Yeah, thank you very much, Chair. My question to the speaker, Roslyn. You have said that you are the CEO of an organization that is still a baby, yes, and that is coming up with this implementation. There's something that also normally happens. For example, a new couple in a town that has just received a baby and they don't know how the process of taking care of a baby and all those things. When this, for example, even if we look at it in a boyfriend way, but even just a couple that has been married, part of the problem is this woman doesn't know how to take care of the children the first time, and they don't have people who tell them how to do that. Yes. So what is your organization doing when it comes to that, and what would you recommend if there would be more organizations as much as that is concerned? Thank you.
Thank you. Any other question? Yes.
Thank you very much. I'm Muteti Mutunga, a student in Kenya Methodist University. A question to Dr. Roslyn about in bit of your conclusion, you said women lack knowledge on risks for postpartum depression. Do we have a certain ratio or it's all women? Maybe I'd like to understand that bit. Then number 2 question, in your case study, do you find maybe mothers who have special needs, and how was the response according to your case study? Thank you. I submit.
Anybody online? Yes, there is a hand. Wanjiru? You have to.
Thank you very much. Dr. Roslyn, thank you very much for a wonderful presentation. My question is based on your findings and the prevalence of postpartum depression amongst that population, and whether in any of those sites there were psychotherapeutic interventions to manage the depression, or if psychosocial support was offered. Thank you.
Thank you. Dr. Who? I can't see that one. There's another hand from...
I wanted to comment on something.
Yes.
Hello?
Yes. John, just continue.
Okay. First, Dr. John Yambo of Kisii University. First of all, I want to appreciate what Dr. Jambo has presented. Now, there is a great need for men to help women during the time of pregnancy, because it is a collective responsibility. And in most cases, women are left alone by men, which is not good. And therefore, the government is also working very hard to give something which you call paternity leave, where men are supposed to utilize that time to give women moral support so that they reduce their level of stress. And you find that some men don't use that leave effectively, purposely to help the wife. They use it elsewhere, which should really be addressed. And another thing, I hear there is, I don't know, I've never attended, but I hear there is something called men's conference. I don't know whether it's existing or it is just a saying. If it is at all it is existing, that is the forum where men are supposed to be told some few facts on what to do. Thank you very much.
Thank you, Reverend Onyango, and you will be the next presenter after she has reacted to all those questions and concerns.
There's a hand here.
Thank you, Wilson, for that very good presentation. Hello.
Yes. You are muted.
Okay.
Okay.
Thank you for that presentation. My quick one is the postpartum depression is obviously related to women, but I'm wondering whether there's a possibility that that period could also lead to depression in men, and has anybody considered that? The same people you want them to support.
I think in view of time, we'll just leave those. the reactions there for Roslyn to say something. There are so many presentations.
Yes.
No. Let's just keep time, otherwise we'll drag on and on and on. Roslyn, those are enough.
Okay, thank you. Wow. All right, so let me start with the first one, the new couple in town and whether the organization can take care of them. Yes, reproductive health is very, very crucial, and there are different stages we would like to see any kind of family, any kind of woman. You've said, I live alone boyfriend, so I've left them alone. Okay, a boyfriend comes with a girl, okay, fine. You want to seek help, or whether or not you don't know. Now, I talked about preconception care. There are different levels we see these women and men. And preconception care is the time where we advise them. Oh, I want to get pregnant. What can I do? Are you a smoker? Stop smoking. Are you taking alcohol? You need to stop. Are you in any family planning method? We need to stop you on that so that you can start the journey of preparing for pregnancy. And this period will last from 3 months to 1 year. You can actually start preparing for your pregnancy as early as 3 months to 1 year. So at that level where we are meeting you, we can even do genetic. There's a lot that happens during the preconception period. And that is the time where now we prepare you. Okay? And this, I will say, is the time period that is missed by 98% of all of us. Most people you'll hear, oh, I got pregnant. I didn't know how I got pregnant. And it's normally accidental for most people. So we need to see you the time you're preparing. And then after that, now when you get pregnant, we need to see you in the antenatal clinic. Come, we talk to you. We advise you. There are a series of services we'll offer. Preventive, counseling, PMTCT. There is a lot we do during the NC. Then we walk with you the journey until you're ready to deliver. When you're ready to deliver, we are ready to advise you how to take up the challenge and how to cope during childbirth. And then finally, after you deliver, we now have a new baby and new mommy and daddy. Then we are able to take care of you. What I have just described is taken care of by the organization, the baby organization, Ultimate Maternal Insights. You can just come and see me after this. I will explain everything to you. Secondly, from the question from this side, so you are talking about the conclusion, the ratio, you're asking if it's all women. Okay, that was just a conclusion whereby majority of women were lacking the knowledge. It's majority of the women, not all of them. So a very small percentage had something, they knew something small about this postpartum depression. So it's not all women, but we are seeing majority of them. And then you're asking if we were able to meet women with special needs. Yes, there is this group of people in reproductive health. We call them. It's a group that are vulnerable populations. And it comes all the way from people living in poverty-stricken, environments or areas. So we were able to meet the disabled people, talk about people who LGBTQ. One day you meet a client who comes and tells you, okay, fine, sister, they call us sister, when you are in the clinic, this is my husband, yeah? I'm being wrapped up, okay, fine. Looks like I'll not answer everything, but yes, we were able to meet them. And then there's another question for psychotherapy and also intervention, psychosocial support, yes. And that's why we are saying, because we have a problem in identifying some of these symptoms and helping these women doing so, once we do that, we need proper referral mechanisms. So yes, we do refer them so that they can get help from psychiatrists or psychologists or counselors. So we do refer these clients. And then men, yes, men, we cannot overemphasize the role of men. Yes, and maybe you and I will carry out a men's conference. I hope we will all attend. And finally, PPD, depression in men, yes. We call it, there's something we call a ripple effect. So men can actually get depressed. Thank you.
Thank you, Dr. Roslyn, for that. As Dr. Nyango prepares himself for the next presentation, I just want to share something small with you. That as a young doctor in Machakos Hospital, I was once confronted by somebody who brought his wife for treatment. By then I was the medical officer in charge of psychiatric ward. And after asking the question, asking the man, what is the problem? Before he answered anything, it is the woman who shot up and said, no, she was the one who had brought the husband because he was messing up in the compound, doing so many bad things. And the idea is to find out what the patient has done. And the man just reacted and says, Doc, I don't know what's wrong with this lady. I'm the one who brought her because she's the one who is unwell. What are the allegations? He said many bad things about what the woman had done at home. And we asked them, we got surprised. Now we didn't know who is telling us the truth. We told them to go out a bit. We called them one by one. Then we asked, is that true, what you have said about your husband? We asked the husband, is that true? He said, yes, that's true, because she's the one who is bothering me. We asked the woman, whatever your husband has said, is it true about you? Yes, because he's a problem to me. That's when we discovered that one of them had become depressed, was unwell, and that made the spouse to be depressed also. Now they were behaving abnormally because of that. So thank you for that. Dr. Onyango, please can you give us your presentation? Onyango Yambo.
Thank you very much. I'm called Onyango Yambo, as you have said. And my presentation is about supportive role of faith in fostering mental health resilience in the contemporary society. Now, we have discussed, I'm talking from faith background. I'm an ordained pastor, and I'm talking from also theological point of view. We find that spirituality is very important, and religion, and they give opportunity, and when directed well, they really help and give proper spiritual direction and give good nurture to people. We also find that when religion is focused on sacred, it becomes distinguishable from spirituality. And for that matter, we find that most studies have positive association between religiosity and spirituality, and that is where most people go wrong, because they concentrate on the other, yet they're supposed to move together. This one brings a higher life integrated portion. Now, spirituality has recently been considered to be a more personal, subjective experience that often includes a connection to the transcendent, that is the relationship to God, and therefore connectedness to one another is very important for those who are feeling, getting the issues of religion. Now, religion is a very good therapy in the society. It is significant because it has a therapeutic approach to mental health that should not be underrated. So religion has brought stability
Pastor Yambo,
in health. Yes.
Could you kindly close your blinds? That is the curtains. There is a lot of light so that we are able to see you properly.
Oh, okay.
Thank you.
Now, is it okay now?
That is better, far much better. Thanks.
Oh, okay, thank you. Has brought stability in health and well-being because it consoles, it soothes even those who are sick. Sometimes we go to the hospital, we talk to them, we counsel them, and you find that even some good soothing music is also becoming therapeutic, which is a part of religion. And we also discover that the role of faith is really important, and the therapeutic nature cannot be ignored, as I've said. Now, occasionally, there has been experiences where people do not realize that even religion should go with the lifestyle. There's a particular way that a religious person should conduct and lead his or her lifestyle in a way that is becoming even more healthy. Because sometimes the way we conduct our lifestyle is different from the way we conduct our faith, and that one is making us be affected. So faith and resilience are significant in mental health matters, because according to David and other people, they said that even though resilience may be thought of as defense mechanism, to overcome adversity, it also can be viewed in terms of mental health promotion. It promotes mental health so that it alleviates the negativity that might be there. So resilience, therefore, goes beyond coping and managing stressors to overcome challenges and formulating protection against negative life events. And for that matter, someone who is religious should really avoid negatives, because so much negatives contribute to a lot of fatigue, and the fatigue, when they are too much, they bring stress, and stress leads to depression, and that one is affecting us mentally. Now, family support is equally important. Family support has and role of faith, according to Sharim, has been useful in building resilience. So parents who are there, just as Dr. Diamba has talked about pregnancy, after pregnancy, a child grows. After growing, now a family is there. The parents should really bring up family members in a way that will make them to have peace in a home. So family support is very important. And in some developed world, we find that sometimes family support alone can even make someone who was unwell become okay. Now, this study was anchored by intergroup threat therapy, which was proposed by Stephen, Oscar, and Kimberly. Now, in this regard, they look at some threats which are coming in caused by groups. You know, it suggested that most humans are tribal in nature. So they are really together in groups that has to share similar elements for identity formation. Now, these groups tend to anticipate threats from other out groups. And by so doing, the theory is particularly concerned with the perceived threats, regardless of whether they are real or not, because even perceived threats can lead to real consequences. So the propagators proposed two types of perceived threats. One, the realistic threats, that is threats to physical, social, political welfare, and symbolic threats, threats to identify values. So all those are making people to become more worked up. So a combination of spirituality and religion makes resilience. So we find that spirituality, which is borrowed from a British Arctic explorer, who said that one day he described the stories of his experience, the importance of beliefs and resilience on faith to survive in expedition. So faith made the person to survive in the expedition. Faith is very important. In theological, we say faith is a belief of what you have not even received, but you are positive.
Sorry, there's a disconnection. Okay, continue. You are back.
Oh, okay. Thank you. Now, when dealing with the role of religion and spirituality in line with mental health, we find that there is a relationship between religiosity and well-being which has long been established. So more recent studies have employed religiosity as a predictor of variable trend towards supporting this multidimensional conceptualization of religiosity. So psychological effects of religion are found to be frequent in attendance of religious gatherings, which has lowered the risk of depression. In fact, this is why preachers and pastors like me, we encourage members to attend church. As much as during the time of Corona, people were attending their services online, which is was also circumstantial, but it is better if members come together. When they come together, there is that kind of fellowship, there's that kind of warmth, and that one reduces depression to an extent, because it is placing faith on spiritual values. So when people come together, they share a lot and they learn from one another. Now, on the other hand, we also find that belief in the existence of divine leads to increased resilience in individuals, hence promotes resilience. So, at least if you are a Christian or a believer for that matter, whatever religion, but you believe in it, that belief should give you some divine power which leads to increased resilience in individuals. Therefore, this will promote good health. Now, when examining relationship between religiosity and life satisfaction, Biggen and others who looked at religion affiliation and private religious devotion found that the former, that is religious affiliation, have a strong relationship with life satisfaction. So when you are really religiously affiliated properly, then you see life positively. And when one sees life positively, he becomes satisfied in whatever he or she is doing, as opposed to someone who is seeing life negatively. Now, religion often yields psychological impact on individuals. And the psychological impact here can be negative or positive. And that is why in the earlier presentation in the morning, I can't remember who said, but someone said there should be a need to re-educate or to reorganize the curriculum in the theological schools so that we capture current situation things, such that when pastors and priests come out of seminaries or theological colleges, they should really amalgamate religion and psychology, which has impact on individuals, so as to expel mostly negative energy, which people accumulate and eventually make us become have even mental ill health. So it is important that we embrace the positivity in our religious issues and we do away with the negative emotions which religion sometimes bring. Okay, most religions, well, as I conclude, most religions responded in their mental health problems were at least reduced when they were talked to positively and guided well. And we find that having the image of God in someone's life and the positive issues will really alleviate negativity. So we encourage that religion should be taken seriously and should be taken carefully so as to avoid extremes, because some extremism is coming in which are not explained, and extremism is also negative in nature. Thank you for listening.
Let's clap for him. Very good presentation, Pastor. Thank you so much. Can we have reactions? Yes, Dr. Charles Kinanga. Charles, your hand is up. Please, can you give your comment?
Am I clear now?
Very clear.
Yes.
Please continue.
Much appreciation for the well-researched and presented and articulated presented by Dr. Onyango. just one question, okay, a question kind of, something that you can help us to grapple with, is this issue of religion. I keep on saying we want to focus on the religious space. Now, one of the things that was said that ecumenism can help us to have a united stand on how to come up with a common approach and to deal with certain issues that affect society, one of them being mental health concerns. However, ecumenism is becoming such a difficult thing to achieve, to the extent that some churches just don't want to associate to it, to have that interchurch collaboration. You feel maybe they are not of the same faith, they don't have similar, what you were calling symbolic, something. How do you think we can bridge this gap so that we can have maybe a common, so that, here I'm not even talking about interreligious, I'm even talking about interfaith, okay, maybe it's like within Christianity itself, we have the Catholics, we have the SEDs, that level. Before when we start talking about other religions, within Christianity itself, how can we preach this gap? And perhaps when we get a solution, we will also now apply that to other relations between Christianity and other religion. I don't know, Dr. Onyango, if you can comment on this kindly.
Any other before he comments? Yes, Pastor Karani.
Thank you very much, Dr. Onyango, for that presentation. Briefly, I don't know what's your take concerning, because if you remember also from the Bible, Christians are in this world and not of this world. And they use much of their time every day outside the church gathering confines. And there is always a gap that is in between when they gather and when they scatter to those other various places that they stay in during their daily lives. Now, there has also been that we call escapist theology or escapist. I'm not getting you well. Are you getting me now, Dr. Onyango?
I'm not hearing.
Yes.
Yes, Dr. Karani, endelea.
Yes, sir. You get now. Let me briefly state my statement. Hope you're getting me now. I'm saying there is that text in the Bible that the believers are in the world and not of this world. And I'm saying that also many Christians, they spend much of their time outside the church confines. And there is always that gap between when they gather and when they scatter to those other various endeavors of their daily living. But also there is that we call escapist eschatology, where the believers believe that they are not of, they have another home that they are going, so they don't want to take care of this, life so much. Now, my question is, what's your take? What could be your take about this gap? What could be your take about this gap of when people gather and when they scatter, they are different people, and where they're staying much of their time is beyond or outside the church confines? And especially now also on your take concerning the highly commercialized and mechanized religion, that's Christianity or church. What's your take about this? Because when we talk about positive thinking positively, it can also be affected by where we stay many hours of the day.
Thank you. The last comment will come from Dr. Gordon Ambayo. Ambayo is a psychiatrist. Gordon, can you ask your question?
Thank you very much, Dr. Ndede. My name is Dr. Gordon Ambayo. I'm a consultant psychiatrist and the chairman of Department of Psychiatry in Kenya Methodist University. Now, mine is a comment, not a question. I would like us to have this conference has produced some fruit not just we just talk in the conference and there's nothing on the ground. I'm urging the religious leaders in Kenya and in Meru to form visitation groups in their churches, or if they have, mobilize these groups to come and visit mentally ill patients in Meru Level 5 Hospital. In other hospitals in Nairobi, I see religious leaders and even church members who are not religious leaders coming to visit these patients and pray for them. But I've never seen, I've been in Kenya for 5 years, I've never seen anybody come to pray for these patients. So can we at least have a starting point? Even if you don't have counseling psychology knowledge, the fact that you have come to pray for a patient can uplift the spirit of that patient. Thank you.
Thank you, Gordon. Thank you. Can we, Dr. Yambo, can you now react to?
Okay, thank you very much. Let me start with Dr. Bayo's comment. I heard him very well when he's talking about the role of leaders in maybe church leadership in visiting the people who need visits. Now, there is every church or every church organization has got a chaplaincy department, chaplaincy. And these days, there are those even in the theological colleges, they are majoring in chaplaincy per se. Not, as much as they will be dealing with the flock, but their orientation is purely chaplaincy. So we have so many chaplains who are trained, and in the chaplaincy units, which sometimes I also teach, we teach them.
Continue.
We teach them how to handle the patients, and even if they have to sing, there are some particular songs which are to be sung, not any song anywhere. So chaplaincy should be really emphasized. Then I didn't get Dr. Karani very well, but he talked about, I think, something with the church conflicts. Now, these church conflicts are becoming administrative in nature, but not really spiritual. So they should also be, some of them should be handled administratively. And when they're handled administratively, then the church conflicts can be done very well. Finally, Professor Bagoma talked of ecumenism. Now, in theological circles, ecumenism is a big elephant, because it is a way of trying to bring all churches under maybe one kind of leadership. And yet, these churches, or denominations for that matter, they don't. The Bible is one, yes. God is one, yes. The heaven we are going to is one, yes. But people differ in doctrines. There is what we call higher ground and lower ground, difference in faith. This is what is making ecumenism a reality. But if at all the churches can have one ground where they subscribe to the way the Bible is doing it, then all can be well. But when we take different stands, for example, some believe in infant and they believe in it, and it is not, for example, it is not biblical. There is no biblical support to that. So for you to be in the same table with someone who believes in something is not biblical is becoming a tall order. And that is why ecumenism is really becoming hard. Otherwise, I would have talked much, but because of time, let me end it there. Thank you very much.
Thank you, Pastor. Can we clap for him? That was very interesting. Thank you so much. At this juncture, I want to call Wanjiru Murithi, Zibora Karia, and Joe Space. I can see Wanjiru's name appearing there. Are you the one presenting? It's your time to present. Yes, yeah, please do so. 10 minutes, 5 minutes for discussion, please.
Hey.
You see it now? You see it? You see it? Yeah. Yes, I'll do that. I'll do that just now.
So thank you very much, Chairman, and good afternoon.
Hold on,
Good evening.
Wanjiru. I would like to know whether Ovampe Barga Guy Bertrand is within. Is he available now? Dr. Ovambe Barga Guy Bertrand. Are you around? Are you available? So, is not in. Wanjiru, continue.
Thank you very much. Good evening. My name is Wanjiru Muredi. My co-investigators are Dr. Zipporah Kari and Dr. Job Mapesa. I am a doctoral student, and we investigated social demographic and clinical predictors of psychosocial distress in women with breast cancer in Nairobi County. And I'll take you quickly through the outline of this presentation. That what this presentation is about is that we want to, what is the state of breast cancer in Kenya? What is psychosocial distress in breast cancer? Is psychosocial distress incorporated in treatment? What theoretical underpinnings influence the study? Do social-demographic and clinical factors predict psychosocial distress? And what were the study's key findings, and what conclusions and suggestions did these findings lead to? The situation of breast cancer in Kenya is, as you can see from our pie chart, that in Kenya, breast cancer is the most commonly diagnosed cancer amongst women, and in fact, even amongst all cancers in Kenya, it's the most frequent diagnosed. It was the most frequent diagnosed cancer in 2022, according to Globocan 2022. And breast cancer accounts for 25% of all cancers diagnosed amongst women. And so that is the state of cancer, the breast cancer in Kenya. And our next question is, what is psychosocial distress? And psychosocial distress is, according to the National Comprehensive Cancer Care, came up with a definition that psychosocial distress is a multifaceted and pleasant experience of psychologic, that is combining emotional, cognitive, and behavioral, and also social and spiritual, and even the physical aspects of a woman, and which may affect their ability to cope with the disease and its physical symptoms and treatments. So put simply is that the outcome of all this is that psychosocial distress encompasses emotional vulnerabilities like worry, fear, and sadness, as well as clinically significant anxiety and depression. The reason why the NCCN opted for distress was to remove the stigma that comes with psychiatric labels. And we have said that when it comes to mental health issues, stigma is the elephant in the room. And whilst breast cancer treatment is improving in Kenya, it's only the disease aspects, the physical aspects of the disease that are taken care of. Psychosocial distress, which is a known consequence of a breast cancer diagnosis, is ignored in treatment. And therefore, we embarked on investigating whether there was a correlation between sociodemographic and clinical characteristics and psychosocial distress. The justification for what makes this study worthwhile is that since psychosocial distress is not incorporated in breast cancer treatment, then we are hoping that our findings will shed insights on the needs to incorporate psychosocial distress as a sixth vital sign in breast cancer to facilitate identification, management, and monitoring distress along the disease continuum. And we also hope that the findings will be convincing to instigate the adoption of a holistic approach, a holistic and person-centered approach to breast cancer treatment. The theoretical underpinnings that informed our study, there are three theories, but because of time, I will only concentrate on two of those theories, and because they're the ones which really explain psychosocial distress, and this is the Palin et al. 1981 stress process model, and this model helped us to explain the stress proliferation, or how a breast cancer diagnosis is a stressful event that triggers other stresses along the continuum, along the disease continuum, and chronic strains on our breast cancer's body, finances, relationships, and emotional well-being, and hence psychosocial distress. And also the Link and Phelan's 1995 fundamental cause theory, which adduces that the biomedical model that we are using to treat cancer, not just breast cancer, but cancer and all the other chronic lifestyle diseases in this country, presupposes that or prioritizes the disease's proximate aspects. That is the physical aspects of the disease, while ignoring what is perceived as distal factors like psychosocial issues throughout treatment. Yeah, and yet psychosocial issues have an equal effect on the patient as a person, and other researchers, for example, Carlson et al. 2019 found that psychosocial distress could interfere with the immune system, and therefore the ability of the patient to cope with the disease and its treatment side effects, and therefore interfere with prognostic outcomes and quality of life. So those were the two theoretical underpinnings that helped us to bolster our argument for incorporating psychosocial distress in treatment. So our findings, we find that indeed psychosocial distress is common, and it's not just common, it's also prevalent amongst breast cancer patients, and 63% of them, when we measured using the distress thermometer whose cutoff is 4, 63% of them had severe distress, and 23% had clinically significant distress, meaning that this is distress that needed some attention, and the severe distress, meaning that really some intervention was needed. So this tool has a problem checklist that helps us to see what were the most distressing aspects. And we found that finances, 91% of the women had financial distress. And therefore, our findings supported Zafar and Bateni's assertion that financial distress is akin to chemotherapy toxicity in terms of the amount of distress it generates in breast cancer patients. Then we went on to see if psychosocial distress is not mitigated, might it transition to clinically significant anxiety, depression, and even the two conditions comorbid. And we found again that yes, that anxiety amongst this group, that 30, just a minute, sorry. Just a minute. We found that, oops, sorry. We found that 33% had borderline anxiety and 40% had symptoms that met clinical anxiety criteria. Equally, we found that 9% had borderline depression and 36% met the criteria for clinical caseness. Combining the two conditions, we found that emotional distress, which is anxiety comorbid with depression, 75% of them had met the criteria for clinical caseness. So that was the state of psychosocial distress and clinically significant anxiety and depression, and the two conditions comorbid. And so when we looked at the social demography of our sample, we found that majority, the youngest person in this population was 25 years and the oldest was 70 years. 38% were below the age of 44 years, which is the childbearing age, and this is worrisome, an indication that increasingly younger women are being diagnosed with breast cancer, going against the norm where it was common amongst postmenopausal women. And also we found that 75% had primary education or lower, and this had implications on communication. Half were married, and this had implication on access to insurance, health insurance. That is what the qualitative findings found out, that the married women had access to 2 insurance covers, whereas the ones who didn't have spouses had only access to 1. 62% were unemployed. The qualitative findings indicated that post-breast cancer, most women either lost their jobs or lost their businesses as a result of cancer-associated absenteeism from work or from their businesses. And we also found that 63% had no source of income at all. And this was concerning, and another 25 and below 20,000 per month. So this was concerning, considering the nature of breast cancer treatment, which is expensive. And also the inability to earn an income could lead to dependence and loss of autonomy, and for some women, purpose and meaning, which contributed to distress.
Wanjiru, you have only 4 minutes.
Wow. So the stage of diagnosis, 51% were diagnosed early, 49% were diagnosed late. When we checked to see whether the clinical and social demographic characteristics predicted psychosocial distress, our study only found that it's only age and marital status and education did not emerge as predictors of psychosocial distress. However, income and early diagnosis emerged as predictors of psychosocial distress, with early diagnosis having an inverse relationship with psychosocial distress. And equally, we found that income, again, predicted depression and early diagnosis, whereas it did not predict borderline depression, it predicted clinical depression in this population. Interestingly, all the social demographic characteristics we measured did not predict anxiety. It's only income that predicted anxiety in this population. So in conclusion, amongst this group of breast cancer patients, income and stage of diagnosis emerged as psychosocial distress predictors. That psychosocial distress was common and severe, that both proximate and distal aspects of the disease were critical to psychosocial distress, and they influence prognosis and quality of life, and that if distress is left untreated, it could transition into clinically significant anxiety and depression, or the two conditions comorbid. So we recommend a multidisciplinary biopsychosocial person-centered approach to breast cancer treatment, and we recommend that oncology facilities should incorporate distress screening as an additional vital sign indicator. We recommend financial counseling and psychotherapeutic interventions for distress, anxiety, and depression as part of treatment strategies. And we recommend that the national insurance, I think SHIF, should cover consultation fee and all the diagnostic fees, so that patients don't miss therapies as a result of the coverage gaps. Thank you very much for your time.
Thank you, Angel, for keeping time. Can we clap for her? That's a good presentation. And we give Sarah Akiru a chance to comment. Sarah?
Yes.
Can you go ahead? Sarah, you raised your hand. I think your hand is down then.
Yes. I'm saying.
Yes.
Hello?
Yes, we are hearing you. Can you continue?
Okay. I'm saying I really appreciate the presentation on this breast cancer. It is true, we really need to know the areas that cause the depression. And I've just picked the point that we need to counsel these patients financially and also psychologically. They usually go down financially, and even to afford chemotherapy, radiotherapy, and all this is a problem. I think I appreciate and I hope that this shall come forward on the completion of the study, so it can be implemented, shared and be implemented in healthcare facilities that provide the care on oncology. Thank you.
Thank you. Anybody else? Any other comments, reactions, questions? Yes, Professor Bantu.
Thank you very much for that presentation. I think a diagnosis of any cancers, especially the one for breast cancer, stigmatizes, and of course we needed to put in place mechanisms and structures of how we can help people cope with the stigma associated with the diagnosis. And one of the mitigation strategies that we can be able to put in place is to help the individuals to get out of self-handicapping. Self-handicapping means that the person will begin to think that is the end of life. But we need to try now to destigmatize the impression that someone has been diagnosed with cancer and that is the end of the person. So the community needs to be sensitized and also provided with the basic skills on how to help the person suffering or having been identified with that condition. And the reason why we are here is to provide the full support for such persons, and especially if the person is coming from a community, a culturally diverse community, which labels and the labeling stigmatizes the person. So I think this kind of study is good. We need to do further studies within the counties, because this one is done in Nairobi, I believe so. And we need to incorporate other counties like Meru and maybe Mombasa counties to get baseline information about the epidemiology, the type, and also the treatments that have been put in place. Thank you for that presentation.
Thank you, Prof. Bantu. Without closing anybody out, well, I don't see any other reaction. Our next presenter is Dr. Reverend Kibara Tasila. Oh, there are two hands.
Yes, I'm here.
Just a moment. Let me hear from. Yes. Can you?
Thank you very much for the presentation. I'm Eunice. I'm a clinical psychologist and a nurse. Out of observation, some people suffer from cancer, from psychiatry. They suffer from denial, and it makes it very difficult for the care provider to give care. My question is, how can we assist them to accept reality so that they don't continue suffering denial? Because those who accept, they live a happier life and a healthier life.
Yeah, may I go?
Yes. Comment.
Thank you very much for that question. And it's true that some patients experience denial, and actually denial was one of the reasons that was given for late diagnosis when we listened to their stories. And this is why we argue for incorporation of psychotherapy as part of the treatment strategies, because then at the very beginning, if the person is supported and there are specific psychotherapeutic interventions to help with denial. So if the person is supported right from at the stage of diagnosis and treatment planning, to accept the diagnosis, that would help a great deal. And it's the absence of this that sustains the struggle with adjusting to the diagnosis. Thank you.
Thank you for your comments. I think in view of time, let's hear Reverend Dr. Tasila.
Okay, thank you so much, Dr. Dede, our moderator. So I am Reverend Dr. Tasila Kibara from Kenya Methodist University, School of Education and Social Sciences. I have a lot of interest in mental health issues, though I'm not a psychologist. I'm an educationist, a teacher in a profession. But looking around, mental health has become really a concern for all of us, because it is right in our doorposts. You get out of your gate, you meet a mental health case. Within the family circles, I'm sure we cannot say any one of us is spared. You go to institutions, to the churches, you find issues of mental health. So to me, this conference is very, very vital and is critical, and I have to come in and do my contribution. As an educationist who is a specialist in curriculum studies and instruction, I felt there was a need for me to look at integrating mental health education into the national curriculum, which I say is a further way to holistic well-being. So I have said significance of integrating mental health education, what I'm looking at from my abstract, challenges and strategies, comprehensive approach, and empowering students and communities. In as far as integrating this mental health in curricula is concerned, we need to understand what is the significance of integrating mental health education. What are the challenges and strategies? What is the comprehensive approach which can be used in this particular integration? And how can we empower our students and communities? Now, introduction. Importance of mental health education. What is so important in mental health education? What are the current gaps in educational systems? And then we have objectives of the paper. I start with the importance of mental health education. There is a need to have holistic student development. So you find when mental health is integrated in education, in all the curriculums, then we are likely going to have a student product who is holistically developed. We are going also to be able to equip students for the future, because students who are suffering mental health, you cannot back on them in as far as the transforming the future is concerned. We also want to understand it is important, because we shall be overlooked, we shall be addressing an overlooked aspect of our human well-being. Now, challenges in addressing mental health. As much has been discussed here, that the stigma and the misconceptions are challenges. Limited resources and the training in the institution is a challenge. Compartmentalization of mental health is also a challenge, which will need to be addressed if integrating mental health in school curricula is going to be successful. Then, how does the stigma affect students? What are the barriers in seeking help, like what many of us have actually tried to look at here? Are some of the issues which need to be addressed in this curriculum. Now, strategies for integration. In the strategies, according to my research, we will need to have multifaceted approach, psychotherapeutic, spiritual, and legal perspectives to be looked at. Then mental health literacy programs. We shall need to have modules on understanding mental health, of course, with the various subtopics at various levels, because all the students in various levels of education are not at the same level. Recognizing also signs of stress, strategies for self-care, and peer support. Teacher training programs also will be vital in as far as this integration is concerned. Modules on mental health education for teacher training, so that they are trained on how to come back to the schools, both basic education, higher education, and understand how to address the curriculum. Tools and resources also for educators will be critical in this integration. There will be need for collaborative app support, involvement of mental health professionals, law of community organizations, also in sensitizing them about this integration, and also involvement of mental health professionals. Now, what are the benefits of integrating mental health education? When we integrate mental health education, according to my research, we find that we shall have improved academic performance and also output in workplace, enhanced emotional and social skills, and also reduce the stigma, because the learner will be able to understand issues of mental health early enough, all the way from basic education to higher education, and even when encountered with mental health issues in their places of work at home, then they will be able to address them with the reduced stigma and accept even mental health patients. Now, case studies of successful integration. We have examples from other countries, like for example, America, USA, have a good rate of integration in the curriculum, and this one has given them very good results when it comes to holistic well-being of human beings. Then also I found in Europe there has been a good extent of integration, but when we come to African countries, we find integration of mental health into school curriculum is very, very minimal. Here in Kenya, we talk of mental health education only in as far as the Department of Psychology is concerned, or even in in health sciences. But when we come, we look at the curriculum, really we may not talk about integration, which is critical today. How it comes and best practices, we have found that, in the places where mental health has been integrated, the outcome is really very positive, and the stigma is reduced, and the people are able to cope better, and even the students in the schools. Now, addressing stigma surrounding mental illness, there is need for educational campaigns. Many of us have asked that question through the media, through the churches, educational campaigns, through even other forums and administrative forums in addressing the mental health stigma. There is need also for open discussions and dialogues like what we are doing today, and also ensuring that the places where people are being also attended, they are safe. There is a need also to destigmatize the names of the centers where people are treated, like in Mathare. When you call a name, a place where treatment is going to take place, and the name itself denotes stigmatization, what do you expect? And also the practices, the way sometimes you have the testimonies of people in the rehabilitation centers, treatment centers, of how they are mishandled, and the kind of also the drugs they are given sometimes may make them feel so useless, because if they are induced to sleep and to make them become very inactive, then also it becomes a practice which makes them feel like actually they are very highly stigmatized and they are not wanted. So some of these things may need to be addressed and be changed. Comprehensive mental health literacy programs, there is a need to have comprehensive mental health literacy programs to instill knowledge, skills and attitudes to people, and integration also into the current subject. Equipping educators with the training and resources is critical. We realize our centers where mental health cases are being handled, the resources are minimal, and there is the little which the people handling the mental health cases can be able to do if they don't have adequate and the right resources to use. So creating supportive environments, both at home, in the hospitals, like one of us has said in Meru, Dr. Ambayo is calling upon pastors to provide support, spiritual therapy, go and pray for them, come and greet them, come and tell them they matter. Supportive environment, even at home. Professional development. In most cases, in supportive environment, we find when somebody is suffering mental health, the family would want to be far away and not be associated with such a person. And you are even told, the person can be locked in. Even if you find that person on the way, you do not want to be say, I am the brother or the sister. So supportive environment and also professional development. Holistic support systems for students.
You have 3 minutes.
Yes, there is a need for a collaboration with the mental health professionals, especially for students, and the community involvement. I am about to finish. Policy recommendations, prioritizing mental health education, which we feel it is not really given the priority it deserves. funding, and then also resource allocation. Future directions in mental health education, we need continued research and evaluation. We need also to keep on expanding programs and the research. Conclusion, importance of holistic well-being cannot be overemphasized. We need to ensure that people's mental health is up to date. Empowering students and communities, we need to ensure our students are empowered in knowledge and skills and approaches and practices to handle mental health. Call to action for all the stakeholders to see to it that, mental health is an aspect of importance and is given the weight it deserves. Thank you so much, and God bless.
Thank you, Reverend. Thank you so much for keeping time and giving us a very good presentation. It's time now for reactions. Yes, please.
My name is Dr. Mwenda from the Science Department. Yes, a lot has been talked about, and world over. And I think Carol should give us a direction here, or Professor Bantu. Do we have any opportunity for a common screening for all of us? Because we have been having days for screening, free clinic for other things, free clinic for cancer, free clinic for the other. Do we have a free clinic for mental health, especially for people who are working like us, people in the whole community? Do we have that? If there is, how do we handle the issue of stigma? Because again, if it is there, the stigma is there. You are going for a free clinic for mental health. Somebody will ask you, hey Mwenda, where did you get manned that you are going for this? How do we handle stigma? But I'm saying it is important to have a free clinic for such. Thank you.
Thank you for a very difficult question, but I know it will be answered. Prof. Bantu, can you respond?
Thank you very much for that question.
Too many devices are on.
I want to thank you for that observation. As earlier on mentioned, is that mental illness
We can't hear. I don't know whether I'm the only one who's not hearing.
Sorry.
Even me, I can't hear. I think we have lost Dr. Bantu, Professor Bantu.
Hello?
Try again, you're almost there.
Very good. We have said that mental illness is not a condition that you can always have someone show those symptoms unless there's a proper diagnosis. But I mentioned that if you get malaria or if you suffer from malaria, you are able to get symptoms like high temperatures, a headache, you can feel it, and also lack of appetite, Although some of these conditions have similar symptoms, more or less like mental illnesses or mental conditions. So, per se in this conference, we are saying how do we diagnose, how do we get these conditions? And what Bwana Nicholas is suggesting is that there has been systematic systems where once you get this, you get free clinics, you can go there and do the assessment, but still there remains the condition of stigma. And now his observation is that, can we have some of these clinics in schools? Can we have these in the educational setup? Can we make recommendations to the Cabinet Secretary in charge of education, I think the Honorable Machogu, can we recommend in this conference that there should be clinics? Because I am aware that now with the promulgation of counseling facilities and programs in counseling psychology, it's now a requirement that every institution now should have a counselor. So can we at the same time be able to recommend the ministry to have these facilities in place? I would say yes, because mental health is a key to everything. Yes, because you have now identified the problem. I can say yes, people are not willing to come out because of the stigma associated with that. So in the education curriculum, first of all, we need to infuse some aspects of spirituality, mental health, and psychotherapy, so that now this course of study can be useful for people to identify themselves and the conditions that they have. So to me, I would still feel that we can begin with KEMU. Kenya Methodist University is the starting point, because when we have a facility here, then other institutions will learn from Kenya Methodist University, and then it will be spread to other universities or countries. So that's what I think, Bwana Odhiambo, that is possible.
Thank you, Prof.
Thank you.
Gordon's hand is up. Gordon, and then DVC will crown it all. Gordon, can you go ahead?
Okay, first I would like to start by thanking Dr. Kibara for a very good presentation, which if implemented can go a long way in fighting the stigma we are talking about. You cannot fight stigma without educating the masses on issues of mental health, illness and mental health. Another thing, mental health has a very serious shortage of personnel. So the issues of free clinics may not be very easy to implement, but once personnel is there and those in authority are willing, those clinics can be there. For a long time, the government has not recognized the role of psychologists. So we have so many qualified psychologists in this country, and they are not employed. So we need to convince the health authorities and the government, both at national and county level, on the importance of having psychologists. We don't have a psychologist even in Meru level 5, and we cannot treat mental illness without teaming up with a psychologist. Mental illness you cannot just treat with medication alone. Now, for the medical students of KEMU, treatment at Meru level 5 is only 500 shillings. For consultation, which I think is quite low. So I think they can afford to have treated so many students coming there for treatment. And the issue sometimes is confidentiality. I've told those who are shy to be seen at Meru level 5, I can see them free of charge in an arranged place where there's confidentiality. So that's my comment.
Thank you, Gordon. Dr. Some, can you have a chance?
Thank you, participants. I want to respond to the question asked by Dr. Mwenda about stigma at the population level. This conference is interdisciplinary. I'm a medical doctor by training and a public health epidemiologist. once an issue has been framed and defined and studied and evidence produced in terms of incidence, prevalence, determinants, all of you, those of you who are epidemiologists will know that's the definition of epidemiology, the study of occurrence, distribution, and determinants of a condition, and using those findings to control it. From a public health point of view, there are very many models to address an issue at population level. I'll take a very simple one, which is community mobilization. And it has several stages. This is very well documented. There is the very early person who recognizes the problem. And this person recruits people of similar mind. And they become the task force that drives this and approaches as many people as they can. And once you win that group of people, you form a working group. Now the working group will analyze the problem to identify all the dimensions of the problem and then develop teams for each of those dimensions. From a community health point of view, we say there should be as many groups as there are people of interest, so that the police will have their part, the pastors will have their part, the health workers will have their part, their psychologists will have their part. Once you have this like group, now you recruit community level groups. Each of those groups go to the police stations, the churches, the other places. Still, the steering body is there, the working group is there, monitoring it, and actually seeing that the implementation is done. Finally, you have a movement, a whole nation movement. I was privileged personally as a regional director for medical assistance program when HIV/AIDS was diagnosed globally, and the church denied it. I worked specifically with religious organizations to start that initial, and we said HIV is in the church. Pastor has the HIV. Bishop has HIV. And from that moment on, we got a movement and a momentum. I remember one day we hold the National AIDS Day at KICC, and I was the master of ceremony for that national event. When you reach that level where you have the movement and now you have champions, then stigma will be out of this country. When, I don't mind mentioning it here, when the CS, the lady from Kiambu who said I have bipolar, does anybody know? What's her name? Okay. She was a CS, and then she said, I want my president to know that I have moods, up and down moods. So when he deploys me as a cabinet secretary, I want him to know that I have a mental disorder, that I fluctuate. And she said in the national television of 6 months, she was in the depressive mood. So I believe stigma starts exactly, fighting stigma starts as we have done here. Today we recruit many of you to think alike. Tomorrow we go out, as Dr. Ambayo said, can the church begin to act? Then we have the police, can they check? There are so many mentally challenged persons arrested by police every day. And they are subjected even to worse situations. So I believe our Global Salama Institute and all the programs and the leadership it will provide, once we identify stigma and discrimination as the key issues, then we are going to fight this animal. You call it the animal in the room. It's always there, this animal. We will fight it. Thank you.
Thank you, Dr. Some. I think we'll hear the next presenter, and at this juncture I just want to request us to be patient, and so that we can finish. We have only 2 presenters to go. You remember we also started very late. The next presenter is Mr. James Muthe. Muthe, can you give a presentation? Please, let's save time. Let's save time.
Good afternoon, ladies and gentlemen. I wish to extend a presentation that was made earlier this afternoon by one Dr. Severina. So mine will just actually be adding to whatever she had presented by exploring the stages of grief in organizational change.
Is your microphone on?
Can I be heard? Okay, thank you. Now, in 1969, Rose Kubler wrote a book on death and dying. So possibly we are asking ourselves, what has organization change got to do with the death and dying? But then later on it was discovered that when there is a change in an organization, members of that organization actually go through the same process as the process of grieving. And that is the topic that we're going to look at today. I won't go through everything, apart from the fact that empirical studies have been done, although they are limited, very limited, they are not very many. And that means that we have room in this area actually to go and do research and find out whether this model actually is applicable, whether it can be expanded, and how it can be implemented. Let us understand organizational change, which is inevitable. Change, they say that change is the most common aspect in an organization. So change is always there. And I've given a few examples of change, including mergers and acquisitions, where as businesses are either growing or contracting, there is a chance that they will go through mergers when one business swallows another one, or a business can buy another business. And that changes the environment for the employees. There is restructuring. We've been hearing about restructuring every day, especially due to economic and downturns. Then there is the issue of new leadership. In management, all the time we are expecting to have new leaders, and the new leaders come with new ways of doing things, and this one can also impact either positively or negatively because it is changing the environment. We have technology implementation. We are in an area of rapid technological change. So if tomorrow we decided that we are going to implement AI in a certain organization, the way people work will change. The environment will change drastically in such a way that people will start having certain symptoms akin to grieving. Then we have cultural transformations, where organizations seek to change their culture to align with new values. You might either change your strategic plan and the strategic objectives, and that might come up with a new values, goals, or even the market demands might force you to change the way culturally you behave as an organization. Then downsizing or right sizing, that is something that all of us understand. Whether you are decreasing the number of people that are working for whatever reason. We have expansion or diversification. When you are either growing or you're introducing new products, as we are like an education organization, you'll be introducing new programs, new departments, and so on and so forth. That is in diversification. Or expansion, you're introducing new campuses in new areas, and you are sending employees who are, say, for example, in one region to another region, and that also might impact them negatively, as we'll see soon. There is a process improvement initiatives, strategic shifts, workplace flexibility initiatives, especially nowadays when a lot of us work online. So there is that work-life balance, and also it affects people. Now, all these changes have, the list goes on and on and on. And all these changes have a psychological impact. And most often than not, this psychological impact affects the sense of identity. Yeah, the employees are not very sure of who they are or what to identify with, belonging, because the culture might change and you may not fit anymore, and they lose control. They are also not very sure about the future. They may fear loss of jobs, and also there is a disruption to routine. And this one can contribute to stress. And we know stress is a mental issue. Anxiety is a mental issue. And changes in roles or responsibilities, like either you are being, like when you are downsizing, this might challenge the individual's professional identities. When you introduce new systems and you are not trained in that area, new people are being employed who have been trained in that area, it might impair you. And sometimes it might impact your sense of competence. Now, employees may experience a range of emotions, including, we have said, uncertainty, anxiety, or even loss, as they adapt to the new roles, processes, and expectations. So let us explore now the journey of an employee or a group of employees through the lens of stages of grief, with a focus on mental health considerations. First of all, we need to understand the 5 stages of grief. And the first one is denial. The first one is denial. When there is a change, most often than not, you'll find that the people will be shocked. They do not believe, and they deny that actually it is going to happen. And you resist the knowledge that this one, they are just rumors and it is not likely to happen. And you might, as an employee, you might downplay the significance of the proposed changes, or you believe they won't affect you personally. It is likely to affect other people. It is a defense mechanism. You do not, you say, that might affect Department A, it might affect Branch X, but not me. So you deny. And usually this one can lead to increased stress, usually. And it hinders effective communication because people do not want to open their eyes. They don't want to believe that it is going to happen. And usually it provides a temporary defense mechanism, but to no avail, because change is imminent and it will happen. The next one is anger. Now, at this stage, the individual realizes that the denial cannot continue. This one is happening. And now the individual becomes angry with the situation, feels that it is unjust, and that they have been betrayed. There is the issue of fairness, and now the blame game. Why is it happening? It is happening because so and so did not do their work well. It is happening because of this and this. So you start blaming even the environment. And sometimes this anger might be directed towards the leadership. There is a lot of aggression, and we have a specialist in aggression in this conference today. And this aggression might be emanating from changes within the organization. And you'll find that the anger is directed towards leadership, colleagues, or other organization, or even the organization itself. They might want to harm either themselves, or they might want to harm the leadership or the other colleagues, or even the organization. And unaddressed anger can lead to workplace conflict, decreased morale, and reduced productivity. Now, the next stage, the first stage, remember, was denial, when we were saying that nothing is going to happen. The second one, we have seen that it will happen. We start now blaming everybody, and we are very, very annoyed at everybody and at everything. Now, the next one is bargaining. And this one involves the hope that the individual can somehow postpone or delay the change. So you start negotiating. You attempt to regain the sense of control by negotiating or seeking compromises. The employees might make deals with the management. They can also form alliances or groups with co-workers to try and prevent the change that is going to come, or express willingness to accept the changes under certain conditions. They say it is okay as long as this and this and this happens. However, bargaining can prolong the transition period and delay acceptance. So as you are bargaining, you are also delaying acceptance. You are holding back. Now the next one is depression. At this stage, the employee begins to understand the certainty of the change, that there is nothing that can be done, this change will happen. And there is nothing that will be done to avert it. As a result, the individual may become silent, disconnected, and may spend a lot of time alone. This one is a depressed state. And it can even present as a clinical problem. You go to hospital, you are sick, and the doctor cannot be able to find out what is wrong with you. Simply because there is something at the workplace that is happening, and nobody can actually be able to link the two. So depression sets in when employees confront the full impact of the changes, and they feel overwhelmed or powerless. And the symptoms may include sadness, anxiety, apathy, and a decreased motivation. All these ones are mental issues, and they can present clinically. And the depression can significantly impair job performance and increase absenteeism. These people will not even be coming to work because they are depressed. Now, the last stage is acceptance. And in this last stage, the individual begins to come to terms with their mortality and the events that must occur as a necessity. It must happen. And acceptance marks the final stage of the grief, where employees come to terms with the changes, and they may develop a positive outlook, find ways to thrive in the new environment, and contribute to organization's success. Acceptance doesn't mean complete agreement with the changes, but rather a willingness to move forward. So you accept to move forward. Now, these stages are not linear. Although we have covered them in a linear sequence, they are not linear. They don't say that you start with, say, for example, denial, then you move to anger. You might jump anger and you move to depression straight. You start with denial and you move to depression. From depression, you can come back to anger. Some people might spend the entire, a long time on this one, while others might move through it very quickly. Some might even jump some of the steps. But it has been observed. Now, this is the sequence that people go through when they are grieving. Now, how can they be supported? How can the employees be supported during organization change? The first one is to recognize the emotional impact of change. Anytime that if it is a new CEO that is being changed, if you are bringing in new software, you need to understand that this one can emotionally impact negatively or positively on the employees. Here we are more or less looking at the negative impact. And then there is need to provide opportunities for employees to express their concerns, ask questions, and they participate in decision-making processes so that they can be able to move quicker through the grieving process. You need to offer access to mental health resources like counseling, support groups, and stress management workshops. And there is need to encourage a culture of resilience and adaptability by acknowledging employees' efforts and celebrating milestones. I'll go quickly through other coping mechanisms as I round up my presentation. So the first one, as my former presenter said, I talked about open communication. There is a need to keep on communicating. The changes that are coming, you communicate before, during, and even after. Then there is the issue of providing timely and accurate information and the offering of support services. The managers and leaders need to be trained early enough so that they can be able to help others to move through the grieving process, even the managers themselves. But remember, during the anger stage, the managers don't take it personally. And then there is the fostering of employee engagement, and you need to encourage flexibility and adaptability. Work-life balance needs to be promoted, celebrating milestones, monitoring and evaluating the impact of the changes, whether they are intended or whether you have actually started working on them, and also leading by example. You need to demonstrate a leadership commitment to employees' well-being, mind-boggling self-care practices, and prioritizing their mental health. In conclusion, we have seen that organization change, especially when it is perceived negative or unacceptable. It doesn't have to be bad, but it is the perception. When people feel that it is undesirable, why are you changing a team that is already working, can be upsetting to employees, and in some cases can lead to the feeling of uncertainty, and we have seen even loss. And during this period of grieving, organization's performance is negatively affected. And if it takes too long, it means that the organization might actually be brought down on its knees. And organizations could implement strategies to create a support and resilient environment that helps employees navigate the challenges of organizational change while safeguarding their mental health and well-being. And finally, it is essential for organizations to recognize and validate these emotional responses, acknowledging the human side of change and fostering culture of psychological support. Thank you for
Thank you, James. Thank you. Can we clap for him? And that was very good. Things which we rarely talk about. But when people talk, then it becomes possible, easier to go through them. All right. Any reactions? Yes, Prof. Bantu.
Very much for this good presentation. I like the aspect of grieving and grieving processes. And in this context, there are needed particular skills that can be used during the process of grieving. And while I'm trying to pose a few questions to the presenter, I wanted to underscore the fact that what the presenter is presenting is really important, because when there are changes, there is some form of stigma associated with the person coming, the person going, and also people grieve. And that's why he started talking about grief and grieving experience. So in the depression stage, for example, a significant number of employees feel demotivated and disengaged after the announcement of job cuts, for example, and restructuring, which leads to a noticeable drop in productivity. So, my question to the presenter is, how are you coping with the recent changes in the organization? It's unfortunate or a blessing to me during my period that I've been here as a visiting professor from the Inter-University Council for East Africa. I've witnessed a number of changes, especially within the Methodist University. And these changes have an impact on productivity, as what Bwana James has mentioned. What aspects of your job are you finding most challenging right now? And what support or resources do you need to help you feel more engaged and motivated? I may not need an answer to these questions, but I would like to provide an intervention One of the interventions is mental health intervention and support. Since we are beginning a global institute of mental health and psychology lab, this is the beginning, because this mental health support will provide access to mental health resources such as counseling services or stress management workshops. When I came here, the first workshop I witnessed was the training of the support staff and administrative staff. So that could be the first step. And then also having motivation programs. Like now we are talking about establishing a brain bank facility at Kenya Methodist University so that we can be able to take a snapshot. It's called a mental status examination on every staff and also on students, because these changes do not only affect the staff, they also affect the students that are under care. I'm interested in the acceptance stage because as changes settle in, employees begin to accept the new reality and look for ways to adopt and thrive within the new structure. So some of the questions that you may ask yourself would be, how do you feel about the changes now that some time has passed? Because I believe that you have a lot of anticipation, you have a lot of expectation, and these expectations are not being realized in a short term. So the plans of intervention are long term, and that's why we are saying in terms of implementing a global health support system is supposed to take a period of time, and the beginning is just about 1 year for people to begin settling down. However, we need to look at the positive aspects that are going to put the teams together. So as you ponder on some of those questions that I've just mentioned, I'm going to rest my case, but I don't know whether you have any reactions on those observations that I've made. And more important now, Bwana James, you can respond to this about anger, because anger is something that affects the people. What specific aspects of the changes are most frustrating for you? And how do you feel these changes will impact on your role and responsibilities? Do you need support, or what type of support do you think would help you manage some of these feelings that you have that may make you better?
Thank you, Professor Bantu. I do believe that that was not a question that was directed to me, but it was directed to the people who are seated in this particular room, which means I may not be in a position to address all the areas. The first question is, how are we coping with the recent changes in the organization? Now, he is bringing it home. And he did not specifically talk about what change, because we, at the departmental level, there could be changes, which I'm unaware of and he might be aware of. At the organizational level, there could be changes, so it wasn't very specific, but there is one change that we know for a fact, because all of us, we've been communicating about that one, and it's the change of our CEO. That one, all of us have been communicating. So I think that is what he was alluding, was asking now, as a group, as a university, as an institution, as employees, how are we dealing with it? How are we coping with the recent? Are we in denial, or we are past that? Yes, how many people are still in denial? How many people are saying, this one is not going to happen? Maybe something is likely to happen between now and the next week when you're supposed to come or something like that. There could be some people, and there are others who might be very annoyed. They are angry, and they could be blaming. They could be blaming maybe the previous. Yeah, they could be saying, if the previous did not do X, Y, Z, this could not be happening. Of course, there could be others who have already accepted. We can be having a few people who are really depressed. So if you go around the offices and you find people who are absent in their offices, we know that is one sign of depression. There are those ones who have already accepted. There are others who are already making deals. Yeah, they are bargaining, they are making deals, they have formed groups and maybe they are, and so on and so forth. For this one, I am going to invite the DVC in charge of administration and finance. He is here so that he can tell us what support he has provided, because he is the person who handles that area. What support he has provided for us so that we do not become mentally ill during this process of grieving. Thank you.
Could you repeat your question, please? So I understand what I'm supposed to comment on.
Okay. I just pinged the question that I was asked to you, because he asked, how are you coping with the recent changes in the organization?
That's a very good question.
What the organization is doing to assist the employees possibly mentally process and cope with the changes, either anticipated or whether they have happened. Thank you.
Thank you very much. I will answer in 2 points. The first one is preparedness. We have announced that there has been a final selection of a VC. We have his names. That is Reverend Professor John Kobia Attaya, who was previously in this university as a Deputy Vice Chancellor in charge of academic affairs, I believe 2011 to some time there. So those of us who are here longer already know him. All right. Number 2, he has been given about a month from the time of his appointment to receive briefings on the status of the university, and he has already met with the senior management team, and he will also be meeting with the senior management team and others this Friday, and then on Monday. In that process, we'll be bringing him up to speed. Now, for the rest of the staff members, there is always that anxiety of what we call the fear of the unknown. Cats are very good on that. They approach very cautiously, and once they become familiar, they play with it. From an organizational point of view, we are going to go through 4 stages, and all of you need to be aware of that. Those of you who have organizational psychology, you know this. Every time a new team member arrives, we go through the 4 stages of team formation. And he has clearly indicated that he's going to review our programs. He will review how we have organized ourselves. When a new manager takes over any team, they always study and then bring in his or desired changes. So we do expect that. I have already provided him with information that he has required of the organization. So, team formation. The next and the most important is team storming. We are going to have some storming stages where we learn each other, how we work, and that we hope we will embrace it. You may not like Dr. Some's style, but now he is confirmed and you will be with him for 3 years. So you might as well learn the best way to work with him. So we will be learning also the new VC and the way he works, what he likes, what he doesn't like. As I've always said, the higher the monkey climbs, the more the behinds are exposed. Our job is to cover the behinds of our leaders. So when you see the weaknesses of the incoming VC, please, let's not make fun of it. Or any other person in leadership, we should cover them because they are our leaders. By the authority of the scripture, we are told to pray and to honor those who are in power over us. Once we are through with this storming stage, we will do norming. Norming is agreeing on the way we shall work. We are very grateful we have completed the quality management system, QMS, and all of you who are owners of some processes, you will follow it even with the new VC. I want to announce here that the new council, the new POT also have gone through all these stages. 4 things have emerged which they want. Number 1, policies. All our policies will be up to date. Number 2, procedures. Our QMS is there. Number 3, decision tracking. Every time a decision is made, they want a decision tracking metrics. These are the norms we are going to play with. And number 4, implementation metrics. Every time a decision is made, how it will be implemented, we'll have a metric showing exactly who will be responsible. With that norming, we will go to number 4 stage, and that is team performing. Now, from administrative point of view, we also have counselors. And we are encouraging our staff, should they encounter any uncomfortable situation. I've been making a lot of notes here myself, and in my closing remarks, I'm going to mention a few of those. The first one I would mention is that all of us should have a sense of connectedness to KEMO in a very special way. So, counselors, students and staff, those who go through stress or uncomfortable situation, I hope they can open up and you will help. Thank you very much.
Thank you, Dr. Somi. I think that covers everything. And
I needed a redirect, and which is that we are at different stages of the process, and you can actually identify wherever you are. You can be able to identify exactly where you are. I will wish to thank all of you who have listened to our presentations, not mine only. There is one more presentation that will be made to cap everything. Thank you. God bless.
Thank you. Thank you. The next presenter is Professor Bantu. This will be the last presentation. We still have our hands. Not in a bad faith. It was prolonged. Yes. So we are almost there with the presentations. This is going to be the last presentation. Good afternoon to you.
You can hear me?
No, we can't hear you.
Not yet? You can hear me? Very good. This is the last presentation for our conference that has been ready for presentation. I want to thank the viewers and also thank for all of you that have been patient up to this time that we are ending. My subject of presentation is lending a hand to healing. Lending a hand to healing, breaking the stigma, and promoting mental wellness. I'm aware that stigma is an issue. We have what is called self-stigma, and we have social stigma. In whatever circumstances that you find yourself in, it's a very, very interesting scenario, because in self-stigma, you will notice that when you are under stress or depression or anxiety or phobia or panic attack or PTSD that was spoken a little bit earlier by Professor Peter Baguma, or gambling or suicidal ideation, all these can affect you. And therefore, people need a baseline research that can be able to be helpful to help people to heal from those psychological conditions. And as you can note, not everyone is willing to come out and say, I need help. The structures which are there are intentioned so that people can be able to get help. But sometimes it's difficult for someone to come out and say, I need help. And when this happens, we need now to break the stigma and promote mental wellness. Mental health stigma is a pervasive issue that impeds individuals from seeking the help they need and contributes to worsening of symptoms. So this presentation will provide the nature and impact of mental health stigma, which will emphasize the need for comprehensive strategies to break stigma and promote mental wellness. And by examining the initiatives in education, in media, representation, community engagement, policy advocacy, and support for accessible mental health services, we shall draw a map for fostering an environment where mental health is openly discussed and adequately supported. That's why we are thinking of a global Salama mental health facility, not only in Kenya Methodist University, but it's a need so that people can openly discuss these mental issues. So the ultimate goal is to create a society that values mental wellness and actively works to eliminate the stigma. A number of us, when we suffer from any frustration caused by the environment or caused by anything that interferes with our life, then it becomes difficult to cope. And we develop attitudes towards ourselves and attitude towards others. Just like the former presenter indicated, that when there are changes either in administration or changes in any other form, it affects us, and this can impact on productivity. So my presentation is that mental health is a critical component of overall well-being, yet it remains a topic surrounded by stigma and misunderstanding. So breaking this stigma and promoting mental wellness requires a multifaceted approach involving education, advocacy, and systematic change. So we are trying to see how we can be able to dissect the current landscape of mental health stigma and its impact on individuals, communities, professionals, and the diverse groups. And of course, we'll be able to provide actionable strategies to foster a more accepting and supportive environment for mental health. You can imagine self-stigma, which occurs when individuals internalize this stigma, leading to feelings of shame. They internalize societal stigma, leading to feelings of shame, low self-esteem, and reluctance to seek help. So many times you say, do I really need to go for counseling? Do I really need a doctor? Do I need to be prayed for? So you have issues that you are not able to resolve by yourself, and eventually you keep to yourself. There are a number of effects on the human condition. One of these effects of not coming out affects treatment, because there is always fear of judgment or discrimination, which of course prevent individuals from seeking professional help. Other people, because of that stigma, they isolate themselves from others, they withdraw away from others, and they always have an attitude of negative judgment. This worsens the symptoms because you are not getting healing. And stigma also affects opportunities in education, opportunities in employment, and housing, limiting an individual's ability to lead a fulfilling life. There are a number of strategies that can be used to break this kind of stigma. One of them is education and awareness. This is done through this kind of dialogue that we are having. Then we need to be able to launch campaigns to educate the public about mental health conditions, emphasizing their commonality and treatability. Earlier on, I mentioned that most of these psychological conditions are still foreign to us. I mentioned we don't even know them in our local language, so that it is easier for us to label them well. So in order for us to get out of these conditions, we need to make public education campaigns in schools, and even using social media, we can be able to implement a mental health education in the curricula that already Reverend Dr. Kibara was presenting on, so that we can be able to understand empathy from a very young age. And this education and awareness plays a very dominant role in our institutions. We can use positive portrayals, encourage accurate and positive portrayals of mental health in the media to challenge stereotypes. When you are walking on the streets, you are carrying luggages, you have an unkempt hair, there is a lot of labeling that is given to you. So we need to be able to have a proper correction of the persons that have these conditions, so that we can really come out of that stigma. We might need to share personal stories, because as we said earlier on, that such conditions, you cannot touch them, you cannot hold them, people are just feeling with that kind of apathy. So we need to begin to demonstrate that we can share some of these stories. When you tell me about your issues that you have gone through, I also tell you my issues, then we seem to be on the same level and we can help each other. By so doing, we can establish support groups in the community forums for sharing experiences and mutual support, like peer counseling, peer mentorship, supervision, so that these things can help us to demystify the stigma associated with the labeling. Workshops and seminars are very important because they will engage communities in informed discussions. Like this conference that we are having, a number of issues have come out. People are able to demonstrate these abilities by discussing them. As a result of this, we can be able to form policies and advocate for the protection of human rights of individuals with mental health conditions and ensure them have access to quality care. We can have barazas that can motivate people and even the government to understand the plight of persons living with mental illnesses. Workplace policies. Workplace policies are very important because they are helpful in helping individuals to come up with, appreciate and interest themselves in the work they do, so that they're able to enjoy the working environment. We can promote mental wellness by creating environments that support mental health for all individuals. Like now we can have facilities for staff, facilities for subordinate staff, academic staff, so that they're able to share some of these conditions, some of their frustrations in life through peer counseling. It's like watering them, watering plants, watering them so that they can be able to understand how to cope. We can have accessible mental health services which are affordable. One of the colleagues in psychiatry mentioned that the religious people have an ability to go and pray for people in the hospitals, but I don't know how many people have volunteered to say, me, I have this condition, I need to be helped. So this conference, in terms of integrated care, we are now forming ourselves into a group that will help us understand that these mental health services are available, and it's the basic primary health care that we really need. I would be very happy to go to someone's office and I say, today I'm not okay, I would like to stay at home. And someone should be willing to be able to accept that and then not complicate things. Supportive environments, we need to have safe spaces. We have to create safe and supportive environments in schools, workplaces, and communities. More important, I do not know whether most institutions have put in place recreation centers like the previous semester where you had a lot of workload and all that. You can have one day for a seminar. You can have one day. You go around the retreat. You take a retreat around the forest so that now you can rejuvenate yourself for the next kind of semester. So it's very important to encourage activities that promote mental well-being, such as physical exercise and mindfulness practices. Sleep, as earlier mentioned by my other colleagues and presenters, is very important, but I find that most of the members don't get sleep even when they should be sleeping. Sleep is not there. So we need to encourage people to get into some of those. And this can be done by developing skills. You teach life skills that promote mental resilience. Like when I want to go and sleep, I have to do some exercise. I have to tell the body now I want to sleep. I tell the hand I want to sleep. I close my eyes. I breathe in and breathe out. I don't just throw myself on the bed. So I have taught myself. And I think the other day Professor Carol was telling me that even she has a timetable for how to sleep. She monitors how sleep is really done. She has a really well established for her. It's a life skill. And once she doesn't meet those, she will tell the body again that let's go back and rehearse. So we need to develop some of these things so that we can have ability to cope with some of the frustrations. If we do not have these, then we can have trainings on some of these, like professional training, skills. For example, as we end this kind of project, I would like us to learn a few skills. Maybe I would ask you to take about 3 minutes so that we can do some of these skills together. And members who are here and online, I would like us to take a few minutes to practice some of these things. The other day, Dr. Gitonga was the one training about relaxation, muscle relaxation techniques. So I would like us to close our eyes. Members, I want you to sit in a good position. Sit very well and in a relaxed mood. And then make sure your posture is well done. You close your eyes. You breathe in. Hold the breath. Then you breathe out. I really want to hear the breathing out. Now you have not perfected this exercise, so we shall go back to number 1. Get a good place and sit in a relaxed mood. Be comfortable. If there is no space, you have to create the space and have a good posture. Close your eyes. Breathe in. Hold the breath. Breathe out. You have opened your eyes. There are those who have opened their eyes. There are those who opened their eyes. I thought the eyes would be closed. So in other words, what we are saying, now you can open your eyes and get back to the meeting. So what we are saying is that you need to learn most of these professional skills. You can be trained on psychological first aid if you experience like anxiety or fear of the unknown. You can really learn by having these simple exercises. You can do exercises with the chair. You can do exercises. You can run. You can walk. But simple skills that will really help you to overcome some of the strains that you may have. So in conclusion, breaking the stigma surrounding mental health and promoting mental wellness requires a concerted effort from individuals, communities, and policymakers. Like this that we are talking to together, we can be able to share some of those experiences. By educating the public, how do we educate the public? By having this conference, by going to the community, just we did a few minutes ago when we left you here, and advocating for policy changes. We said that we need to have what is called mental hygiene. We must be in a sound mind for us to be very productive, and we should be able to create supporting environments, and by so doing we can render a hand to healing and foster a society that values and promotes mental health for all. I know in this room we have a number of health professionals who can support. They can say we are going to give these support services without pay. And then we can have one day where we're going to have a mental hygiene day. In other words, the ultimate goal is to create a future where mental wellness is prioritized and stigma is eradicated, allowing individuals to seek help and support without fear of judgment or discrimination. Basically, that was just a tip of the iceberg, but I would call upon all of us to begin thinking of carrying out a baseline survey on how we can lend a hand. Maybe we can begin with the Jenu. Yes, we are asking ourselves if we can try to have a baseline survey about how we can lend a hand to helping using spirituality, psychiatry, mental health, and psychotherapy to really come out with the indicators of these psychological conditions. So I want to thank you and I submit. Thank you for listening.
Thank you, Prof. Bantu. Can we clap for him? Yes, that was great, and I'll just allow only one comment or question in view of time. I think we are done. Thank you, Prof. And let's clap for ourselves again. I also take this opportunity to thank you for allowing me to be in front here today, coordinating this session. May God bless you. I now hand over to Uday. Continue.
Thank you, assisting MC. Dr. Mushiri, thank you so much. The two of you have done an excellent job. Why don't we give them a clap? There is the people online that we need to really appreciate. There is Dr. Kinanga. Yes, he's been with us since the very beginning. In fact, he joined before most of us, and I don't believe he is there. That one actually should get 2 claps. Let's appreciate him. And Dr. Charles, if you are there.
Thank you. Thank you so much. Very humbled and honored.
Thank you so much for actually attending this conference from the very first minute to the very last one. We appreciate your time, and we hope in the future to engage with you because the discussion never stops.
Always available. Thank you.
At this time, we shall now go to the closing session, and the closing session is going to be a short one. We shall be informed whether the certificates are ready, and if they are ready, they are going to be issued at some point during the closing session. The speakers who will be giving us reflections on the conference. So you take a few minutes to give us the reflections on the whole conference, and at the end of the day, we are also going to come up with what needs to happen after this conference. Okay, we are looking ahead because this one is not an end to itself. We would want to say, okay, after this particular conference, what happens? Okay. So you will engage on that particular topic. We shall have Professor Caroline Palasivino. That is the first one to start us off. Then we are going to have Professor Edward Bantu, will be the second one. Then from home, we are going to have Reverend Trasila Kibara. And then we shall close with our guest, the one who will be closing for us. And that will be Dr. Some, who is representing the Vice Chancellor. In that order. Thank you, and God bless. So we start with Professor Caroline.
Thank you, everyone. These past 2 days have been great. It was such an honor, and I was humbled to be here and to work with you all and interact. I think today we brought up a lot of key issues. We talked about postpartum depression, all of which affect women, and not only the women but also the husbands and the families. We also talked about the students also gave input as to what they would like to see as actionables. We talked about the digital mental health application, and we also talked about forming peer support groups for the students. Like I said, it really has been an honor to be here and to learn from you all. This issue, mental illness and mental health issues, is not specific to Kenya, it's global. We are also having a crisis in the US. So I really appreciate that this is a bi-directional approach where we're all partnering up and collaborating to see what ways we can support our students, what ways can we support our communities. So I really appreciate this experience. So thank you very much for having me here.
Thank you very much, Professor Carol, for giving us all the time to be here with us throughout the conference. I want, in a very special way, to thank the partnering institutions that have been there for us since the beginning of this conference. The list of the universities in your own respective institutions, we are really committed. We are really committed to partnering with you and also able to support the cause for mental health. What we need to do now are the deliverables. One of the deliverables that would like to one of the deliverables is coming up and operationalizing the global mental health and psychology lab. That is very important for this institution, and also the surrounding institutions will benefit. The other deliverable that we need to have, we need to form a team that is going to work out a book on the proceedings, because we have had 2 conferences. The first one was done in March 21st and 22nd, and now the second one is now 21st, 22nd of May. So we need to come up with a publication in terms of a book proceeding, which will be used as a mama mat during other conferences. Then the other deliverable that we need to put across, we have identified a number of challenges that are affecting the institution, and this is because of lack of research. So we want to come up with research teams and themes from the diverse schools and departments, so that we begin now working on grants that are supposed to support the care and service for mental health in this region. More important, one of the deliverables is that most of the mental related causes are a result of poverty, and this is evident by the number of cases we have had, especially those ones who have suicidal ideation and also have committed suicide ultimately. So because of stresses that come from poor backgrounds, so we need to come up with a Hope Trust Fund. The Hope Trust Fund should be responsible to cater and be inaugurated within the Kenya Methodist University and also other universities in collaboration with Harvard University and also Carver University, because these problems of school fees for students put them in a very compromising situation that causes more stress than expected. Last but not least, we need to come up with a team that will plan for the next conference, a team that is going to make a conference next time. I want to thank the members who are very key in the implementation of these conferences. Special thanks go to this gentleman who is next to me. He's called Bwana James Muthe. He has been there all through, and we want to congratulate him for having made this thing work. The next person, of course, is the DVC in charge of administration and finance. Every time we have worked in his office, we want things done, and then sometimes he says, first of all, let's have a prayer, and these things will work. At one time, I had to sit in his office, and they said, come, we pray together. And indeed, prayer does wonders. The other persons that I want to appreciate are the team, the ICT team, including but not limited to Collins. Collins started with us. Jenu started with us in the meetings and also was able to make these things go. Then Kiwish, that I normally use it to call someone other name. So I want to thank those special people for those contributions. And then without missing, well, someone who has been our master of ceremonies for the two conferences, the Dr. John Mushiri. And more important, we want to thank the Directorate of Research that is headed by Dr. Job Mapesa, has enabled us to have very productive conference, two conferences, fully supported. And more important, while these things have been done, we've done them through the arms and hands of our able head of department, the Reverend Douglas Chebere. We want to thank you, our chair, for being there with us. Our chaplain, Dr. Karani, I have no words because every other time we have mentioned you, it's okay. Then the Reverend Karanja has been at the Secretariat. In occasions where we demand minutes, he would be able to deliver them very well. Then we have the Dr. Reverend Kibara. Dr. Reverend Kibara was very instrumental in making sure that whatever we lack, can I talk to the VC? Let me discuss this thing further. Let me check. And I think it's very important to recognize her this evening. More important, there is a man I've always called a stubborn person. This one, he will come and say, can we do this? Then after he has said, then he goes away. Then he comes again. Then he, very, very instrumental and has been very keen in forming the research teams. And this is none other than Dr. Nicholas Mwenda. He shares a similar name like Eric Mwenda, and Eric Mwenda has also been very keen in this endeavor. And again, the last person to thank, they already say the last is not the least. The Vice Chancellor acting has been always on our tour. Can you tell me any developments? Are you going very well? Is everything, tell me. And I think we want to thank her because even when she has had some challenges here and there in terms of this cold, she will ask, Mushiri, have you arranged for? And then I want to thank her also in a very special way. And even there is another gentleman where we almost lacked where to stay. And then when the DVC called, excuse me, is there anything that can be done? And of course, in his absence, tell him that we have thanked him for enabling us. That is the academic registrar for administration. Very good. I don't remember his name, but I think he has done. He's called who? Laititi, yes. Very good and organized person. Last but not least, these conferences were hosted directly from the US. And Professor Caro, every time I'm asking, now what do we do? I'm just stressed. And then he said, don't worry. When I say I'm disappointed, he says, we will move on. So I want to thank Professor Caro for being there all the time. And she's still there. She organized it for the link that we used the last conference, and we didn't have any problem whatsoever. Even now, as we are talking, most of the people are asking, you don't have any blockages. Anyone clicking on the link, they just go through. We do not take this for granted. I want to thank you especially and your team. When we were asking for the facilitators, this is like God had sent you. So all these things came, and we are very excited, and I believe we shall make more collaborations and make the Global Salama Institute a reality. And this will serve along with the other universities. I want also to thank my Vice Chancellor, Professor Joy, and I think you are aware that Kenya Methodist University shares almost, if not the same kind of words, but words put differently. Motto for Kenya Methodist University is the future is here, while Kawa University's motto is knowledge is the future. This, of course, works very well for us to transform lives, and I'm very excited that they also gave me permission, because when I went back, they were almost skinning me alive. But then I said, I'm going back because there's something very important which is supposed to be implemented. So I'm very thankful about Kawa University, and also the Inter-University Council for East Africa. The Senior Exchange Program Officer was in himself in this conference, and I don't know whether he's still there. He attended, and his name is so long, he's from Burundi, and he's been attending, and he has attended, and the rest of the other team that is also from the Inter-University Council for East Africa, they have been following this program closely. I want to thank them on behalf of myself, on behalf of the program coordinators. I want to thank them, and I wish them.
I also want to thank a really special person to me, which is the Women of Purpose organization led by Brenda. Brenda actually is taking the time this week to come with me. She's the one that's been bringing me awareness about East Africa and some of the issues, and her and I always exchange information about what I'm seeing in the U.S., and she's like, yeah, we're seeing something similar here. So I really appreciate Brenda taking the week off to do this with me. So thank you, Brenda, for coming.
I wanted to confirm to you that this issue of mental health did not start yesterday. There are people who run with their own, they don't need anything. They run on their legs. They just walk. So one of the special persons already that has been mentioned is Brenda. Brenda, this is her second time to come to Kenya, especially to Kenya Methodist University. So when we talked about her, I said, you know, we are trying to make sure that we reach out to people. She just said, I'm going to put off these other things and I'll be with you. And Professor Carol, take our regards to Dr. Dorothy, the Director of Women of Purpose International, Boston. And she really was the first person to be here together with Brenda when I was reporting. And we are very excited that this Women of Purpose International is not only going to be a stepping stone for reaching out for mental health, but it will be a foundation for understanding that mental health is a human right. Mental wellness is a requirement for all these views. So maybe I would like to request her to say one word. I believe she can be able to say something because she has also a mouth. She has also right.
Thank you so much, Professor Banto. I'm so grateful to be in Kenya. It feels like home, actually. There is no difference between Uganda and Kenya. So I'm so happy to be here the second time. And I look forward to come back again because I've met so many people who have inspired me, who really like what we do, and they do the exact same thing. I'm grateful for this conference. I was able to present in the first dialogue. Those who attended, I think that they really know what our organization does. So I'm so happy and grateful to KEMU for inviting us and for believing in the vision we have to create mental health awareness. Thank you so much, and may God bless you.
Okay.
In this committee, the committee that has made these things happen, do you know we have one counseling psychologist in the name of Rebecca, Dr. Rebecca Washura. Do you know, even when she would get so busy, you'll find herself in the group, and it was very, very enriching. And every time I say, and where is Rebecca, what do we do? Said, I am in, although I am going to be away for some 2 minutes or 3, but I'm with you. That's a very special commitment that someone brings in. And even throughout our interactions, we have had a good experience with her. And also need to mention the students that have been very keen. They have attended. I've seen some students who attended last time in March, and they are also still attending this meeting. So I want to thank you, students, and also thank you for being there and contributing to this dialogue. It's very, very important. I know there is one we always ask when we want to pray, and this one is Bishop Alice. Bishop Alice, every time you say, now pray for us, and then you should be able to really pray. So I want to thank you very much in a very special way, and all the other members that have made this a success. Then we have also one of our colleagues who has a project proposal on cancer, on oncology research. And she said, are you sure I am going to see Professor Carol? I said, yes, you'll have an opportunity to see her. This lady has a project, and we shall be able to look at it later. Do you know, I'm almost being tempted just to ask her if she can say one word. Sister, can you say one word? Her name is Mbara, I'm forgetting the name. She's called who? Mbara. Now that I have failed to mention the name, but she's there. She is going to share the proposal, and I think the DVC in charge of finance and administration, we are expected to have a meeting for the research teams. And then later on, we have an opportunity to meet with Professor Carol later around 17 hours. So I want to thank you very much. And I'm sorry that I've talked. You know, in our culture, if we are not stopped, we can talk and talk until the cows go back home.
Yes.
Thank you.
Thank you, Professor. Thank you. Let me proceed on what to do. Okay, thank you so much, our coordinator, Mr. Mude, and also Professor Vantu. I observe that you have thanked every one of us, and I want to take this opportunity on behalf of Kenya Methodist University to really register our appreciation to you for the 2 conferences you have steered, the first conference on mental health, and this the second conference, and the partnerships you have brought on board to collaborate with the Kenya Methodist University on mental health issues. I also observe that mental health, the conferences you have made, is not an end by itself, but it is a start of the journey. It has paved the way on how we are going to move about on mental health issues. Apart from having the Global Salama Institute, we are also going to continue with research and the generation of knowledge, because university is an institution where knowledge is generated to impart on policy and the transformation of the world. So we shall proceed on with our collaborations. Research will be key to go, and a lot has been done so far, or something has been done because research teams are there. And so our next meetings will be actually dissemination of the research findings now from the research teams. So the research teams have a lot of work to do to move now the dialogue forward and bring it now from theory to practice by coming up with the research findings which inform policy, which inform curriculums, and change management in the way we handle the issues of mental health. So without much ado, because vote of thanks has already been given through the remarks of Professor Bantu, I want to take this opportunity to invite our DVC Finance and Administration to give his remarks and to close the conference.
Good evening, participants. Good afternoon, good morning, depending on where you are on the globe. Ladies and gentlemen, we've come to the end of our second international conference on mental health and spirituality. Like everyone else who participated, I believe this has also been a learning experience and a dialogue. And just allow me to frame the interface between mental health and spirituality. Clearly, our emotional well-being, how we perceive and express our emotions, can be enhanced by our spirituality in the sense of finding meaning and purpose in life. Element of spirituality of pursuing inner peace and well-being. Even the very aspect of social well-being in pursuing healthy relationships. The fact that we learn to connect to one another and to love our Lord and love the neighbor helps us to forgive and therefore enhance our social well-being. The ritual of prayer, which manifests in various ways, can be summarized that it directly contributes to our mental health. When we pray, it transforms us, as we read in Philippians 4 verse 6. When we pray, it enables us to express our feelings to our Father in heaven, as we read in Psalm 62 verse 8. When we pray, it connects us to God, a much greater power than what we can imagine, as we read in Psalms 145 verse 18. When we pray, we grow in faith, as we read in Hebrews 11 verse 6. At a time of need and difficulties, when we pray, it strengthens us, as we read in the book of Matthew 26:41. When we pray, we know God's will for our lives, as we read in Matthew 26:39. And above all, we pray because we love God, in 1 John 4:19. As I listen all along, it's very clear that psychology is the link between mental health and spirituality. The study of mind and behavior, how we think, feel, and act, the mental functions and processes that lead us to behave the way we do behave. Allow me to intertwine Global Salama Institute and psychology using the Kenya public transport, popularly called Matatu. If we apply cognitive psychology to Matatu, we ask ourselves, how do they perceive danger? Do they remember the last time they caused an accident? How do they reason on the road? How do they solve problems when they come across problems on the road? How do they make decisions? That is cognitive psychology. But if you look at developmental psychology, you begin to ask yourselves, how does their driving competencies change as they grow older? One old driver was employed at age 67, and his first assignment was to drive a bus from Nairobi to Kisumu. And it was at night. He had an accident, and I think over 70% of the people in the vehicle died. Clinical psychology. How do we screen? How do we develop tools to diagnose what I may call mad matatu drivers, those who overtake us in dangerous sections of the road? In social psychology, we may ask ourselves, how does the matatu culture develop, or even worse, the Kenyan versus Tanzania driving culture? If you travel and drive in Dar es Salaam, the police will actually come to you and say, yes, I know you are from Kenya, just from the way we are driving. If you look at biological psychology, how the brain and the nervous system of some of our drivers behave, have they been influenced by substances? I forgot to mention, if you look at educational psychology, how do the Miraa drivers learn to drive like Miraa drivers? Or how do the Matatu drivers learn to drive like Matatu drivers? In fact, some of us have come across drivers on the road say, you must have been a former Matatu driver. There seems to be something wrong with you. Finally, I would say that forensic psychology is going to be a very, very big issue in the Salama Institute. Fresh in our minds is the Shakahola, you can call it a massacre. And therefore, the application of psychological principles to legal issues will be a major one. Ladies and gentlemen, I'd like to end just by repeating on behalf of Kenya Methodist University our gratitude to our vision bearer for the Global Salama Institute, Professor Edward Bantu. As a vision bearer, he already foresaw what needs to be in place. And therefore, this conference is just one of the cogs in that process leading us to that place. May I also take this opportunity to express our gratitude to over 23 partner universities and organizations who have participated in the first conference and this second conference. Our gratitude goes to our visiting professors, Professor Carol, Professor Bantu, and those who have been online. We are very, very grateful. Thank you, participants online, and also our KEMU participants right here. We are grateful to the university management, the university council for participating. Finally, I'd like to express gratitude to the people of logistics. Those of you have heard me express what logistics are, which I picked from someone who was providing logistics to the American armed forces in Afghanistan, and I asked him, what do you mean you're doing logistics for the US Army? And he said, we take care of the little things so that the big things can take place. So, there have been people from ICT department, the press coverage, the live streaming that we've heard, this venue, the food that we have enjoyed, all those things, we are very, very grateful. Ladies and gentlemen, let's actualize the Global Salama Institute for Mental Health and Psychology. And I've just illustrated what the Institute can do when it comes to traffic and transport psychology. Those are not my words. Those are words from Professor Bantu and many other elements which we shall be covering in our research teams. With those few remarks, I just want to express our, I don't want to call it gratitude, our thanksgiving to God, who has enabled all of us to participate without any one of us falling sick. Our sister had a little bit of a stomach upset. We're very sorry for that. Professor Carol, but now you're okay. So we are grateful. Those of you will be traveling, those of you will be going back home, travel safely. We thank each one of you for coming. And may God bless over all of us as we move forward in raising awareness of mental health and psychological conditions. Thank you very much.
Thank you. This brings to a close a very engaging event. The certificates are not ready yet. For those ones who are attending physically, kindly give us some time. Possibly you receive them tomorrow. We shall communicate because we have your contacts, so you can receive them tomorrow or the day after. For those of you who joined us virtually, we shall find a way to post how we can be able to mail the same to you. So at this juncture, I would wish to hand over to the chaplaincy so that they can bless us.
Just before that, research teams, if it's possible for you to remain just for no more than 20 minutes after the conference. Thank you.
Yeah, so I am handing over to the chaplaincy so that they can be able to bless us. I would request the members, of course, to stand. Maybe we can sing one chorus. We are very happy and it has been very successful before we say the final prayer. Thank you and God bless you.
Let us pray. Almighty and everlasting God, we are humbled in your presence this afternoon or evening. We are sincerely grateful that, Lord, you have seen us through the 2 days that we have had our conference. We are sincerely grateful for each and every one of us who has been able to attend physically or virtually. We want to give you thanks, Jehovah Almighty, for seeing us through the 2 days of great work of research. We are grateful, Lord, that you have chosen us at such a time as this, that, Almighty God, we can bring knowledge to the issues that are contemporary at this particular time, to the issues that are disturbing most of your creation, the people that you created. And Jehovah Almighty, we are humbled that we are the people that are deliberating upon issues and directives and policies and the research work that can be useful in this section. As we end this conference, Heavenly Father, we want to thank you for those that have sponsored us. We want to thank you for our guests, Professor Caro. We want to thank you for Professor Mbantu, who has spent many sleepless nights to see to it that this happens. There are many who have sacrificed their time, oh God, and everything that you've given them, including knowledge, that they can make these days a success. We are so grateful, Lord, even for Kenya Methodist University and its leadership. Thank you, Lord, for enabling them to allow us to give us space and all the support that we required. As we come to the end, Lord, we continue to surrender to you, O God, that our thoughts can be translated into a reality and practical benefits for your people. We place every dream unto your able hands, Lord, that it will come to pass and you receive glory and honor. As we live to go to our different destinations, O God, we pray for journey mercies. We pray for your care, for your love. Cover every one of us with the blood of your Son, Jesus Christ. That Almighty God, we shall be able to communicate later and say that we are all well because of your love and care. Dispatch us, O Lord, with your love. And when it will be time again for us to come together, we shall be able to give you thanks, for it is you who makes it to happen. We plan, but Jehovah God, you make everything to be accomplished. We thank you, Lord, and we honor you for everything that we cannot mention one by one. But we are sincerely grateful and continue to place all our aspirations to you, Lord, that they shall be accomplished and you receive glory and honor. We thank you, Lord, when we honor you for this, we pray in the name of the Father, Son, and the Holy Spirit. Amen. And now may the grace of our Lord Jesus Christ and the love of God and the fellowship of the Holy Spirit be with us now and forevermore. Amen. Amen.
The organizing committee, we shall be having a post-conference meeting tomorrow. At what time?
Kenya Methodist University, taking education to a new realm. The convergence of excellent
research teams, please.
learning environment for our
take your
scholars,
seats.
the expertise of our faculty, and the market-driven programs is by design geared towards producing the graduates that will serve and drive the world's economy.
Okay, research
now and in
teams,
the
come to these two tables.